So welcome to the medical student portion of the Summer Institute on Medical Ignorance. This particular program is sponsored by the National Heart, Lung, and Blood Institute. The medical student program has two components from that grant. One is a general program, and the other is especially targeting the diversity students. So we have two NHLBI grants that cover the salaries and stipends of the summer students. And we're very grateful to NIH for an existence since 1982. So this is now close to 38 years that we've been having a final summer presentations. So we're going to start with Ashley Che Vincent, and she's going to be talking on digital reflexes, and her mentor was Dr. Slepian, who's Regent Professor of Medicine.
Hi, good morning. All right, so I'll just share my screen then?
Yes.
Okay. So can everybody see my cursor?
Yes.
Okay, I just want to make sure because I might point to some things on my slides. So good morning, everyone. My name is Che Vincent, and I started the summer with digital reflexes, quantitation and signatures of superficial reflexes via stretchable electronic wearable sensors. But the summer kind of took a different turn, and we ended up focusing a lot on how we can advance telemedicine during the COVID-19 pandemic. So I'll get into this in a little bit. So a little bit of background for deep tendon reflexes. A healthcare practitioner elicits a hammer strike to the limb or the tendon, and the sensory 1A afferent signal gets sent to the spinal cord, which synapses with the lower motor neuron, and this signals the limb to move. Currently, it's a subjective test given by healthcare practitioners, and it's used to assess underlying pathology for patients in the clinical setting. But the current practices of this, it's a very subjective test, and there's a lot of room for error, especially each healthcare practitioner learns the test differently. They have different techniques of doing it. They use different hammers, so on and so forth. And then also the rating that is given by practitioners is based on what they see or how they see the limb move, and it causes a lot of room for error, and it's super subjective. So our study is looking at biostamps, which is this little guy right here, which is a stretchable wearable device that has EMG signal abilities and as well accelerometer abilities. So our biostamps would be used to quantify reflexes for the Achilles, patellar, and triceps reflex, where we'd be looking at a healthy patient group and then also a neurological disease patient group, just studying whether or not the biostamps would be accurate in picking up deep tendon reflexes. So as you can see here at the bottom, for the patellar reflex, for example, we would have a biostamp on the rectus femoris muscle, which would pick up the EMG signal for the muscle. We would have a biostamp sort of near the ankle area, which would measure the acceleration of the limb. And then we also place a biostamp on the hammer itself, just in case we need data for the force of the hammer strike. So this summer, we were supposed to measure the neurological disease patients, assessing patients with either hyper or hyporeflexia. However, we were unable to do this due to COVID-19. We were unable to recruit subjects. So this is one of the diagrams we made this summer. Sorry if it's a little blurry. We are still trying to work out the kinks. But if you look down here at our hypothetical hammer, we strike the tendon, the signal gets sent to the spinal cord. We have the blue line here, which is the alpha motor neuron, which sends the signal to the muscle. And the muscle, there's a biostamp on the muscle, and then that picks up the EMG signal, and we can see here at the top right the data from the EMG. And also have a biostamp on the limb itself at the bottom here, and that would pick up the acceleration, and then this is the acceleration data here at the bottom right. So what was completed this summer? We were able to complete some aspects on this project. We did a little
before you go ahead, remember all of the projects, you're going to have your starting questions and your ending questions. So before you get to what was completed, what were the questions that you began with on this particular project, Che?
So sure, the questions that we started with were, what was the neurological disease patient group going to show? Were we going to be able to assess or accurately assess reflexes in the pathologic disease patient group with biostamps? And how is that data going to compare to the healthy subject group? Because the healthy subject group had already been completed. So I do have another slide about what questions I ended with. This is the slide that got me to those questions. Okay. So the literature review about other motion sensor projects, what's currently out there. We did reading and review of current deep tendon reflex tests in clinical settings, just to see if they had any advancements or if they're still doing it. I don't know if everybody's mics are muted. I'm sorry if there's noise in my house, but I keep hearing noise. And then we did a lot of data analyzing of the healthy patient group. We created figures for the manuscript, and then we practiced with biostamps and the triceps reflex, and I'm gonna get to why the next slide. So this was a preliminary data from the healthy patient group, and as you can see here, the healthy patellar reflex and the healthy Achilles reflex data groups really showed the same trends. But if you look over here for the healthy tricep reflex group, you can see that the decreased lag time really showed an increased duration of the EMG signal, but you can't see that for these two groups. And we really wanted to understand why. So that kind of became the question that we ended with this summer, is why is this happening? So some ideas for that, we had a lot of ideas for why this could be. The triceps muscle is just different from the rectus femoris and the gastrocnemius. Has 3 heads. It's a smaller muscle. We could be placing the biostamp in a different position or an inaccurate position on the triceps. Everybody's arms are different sizes, and the triceps muscle could be very small in one patient. It could be larger in another patient. And the biostamp it's not huge, but it could be big enough that we're placing on multiple groups at the same, or multiple heads at the same time. So that could be providing some noise in the EMG signal. So that's just a list of what our ideas are. Our plan to answer this question would be additional literature review, discussion with our team about the data, and then possibly collecting more data for the triceps reflex, just to see if we can work out those kinks. But moving on, other fringe benefits of the summer, we kind of wanted to expand the telemedicine realm and see what we could do. So we're partnering with a team at the University of Nebraska who recently published a paper about a mobile motion capture system where they can track targets on an iPhone or a smartphone to assess either range of motion, reflexes, any type of movement really. But what we wanted to do was take a step back and assess the limitations of this paper. So we have been doing at-home experiments where we're testing like how far the motion capture technology can track, if they can track a moving target. So you can see a metronome up here where the target would be moving back and forth. We've been using different color markers and different sizes just to assess what are the limitations of this technology. And the future hope of this is to help advance telemedicine, especially the physical exam. If we can put markers on patients at home, or if they can self-put them on, just little neon targets, and they can move their arms, let's say post-operatively from an orthopedic procedure, and this could accurately test that, then there would be no reason for them to have to come into the clinic to have this assessed. So this is just very preliminary data from one run. We have multiple sets. I just wanted to show you, give you a little bit of an example. So if you look here at the top left, we have a 2 millimeter target. And as you can see, the technology can track, but at 6 feet, it's really the limitation, because at 7 feet, we see that it's very unstable and we can't track the target anymore. If you look at the bottom left, the 5 millimeter target can track up to 12 feet, and then 13 feet, it's unstable. And then at the top right here, we have a 10 millimeter target, and it can track all the way up to 18 feet, but at 19 feet, it's unstable. So you can clearly see that the size of the target does matter, and the 10 millimeter target is more accurate than the 2 millimeter target. The bottom right is just a comparison of the 3 charts. So this is kind of where we want to go. I don't know how far in the future, but hopefully not too far, where we blend the deep tendon reflexes and the motion capture technology, whether that's with the biostamps or without the biostamps, and we are just able to use the target, the neon target. I'm not really sure yet, but here we would put the markers on the patient. We would tap the tendon, and hopefully the motion capture technology would be able to assess the swing of the arm, or the flick of the foot for the Achilles, or the swing of the leg for the patellar tendon. This is a separate project, but also ties into the telemedicine theme of the summer, where we're working on color normalization. So the goal is to develop an algorithm that better assesses color on images and videos. We're partnering with the engineering college here at the University of Arizona. The preliminary study, which we have just begun, is normalizing color cards and other household items. Well, that will be the next step. And then eventually we're hoping to move on to actual subjects, where we take pictures of tongues, or faces, or eyes, or whatever that may be, and seeing an algorithm can assess different color changes. So the future use for telemedicine would be to assess tongue pathology, skin pathology, eye pathology, and then overall general appearance. Is the patient anemic, and do they have a pale pallor, or are they jaundiced and have maybe liver pathology, et cetera, et cetera. So these are all my questions that remain in the plan that I guess plan to complete. The motion capture technology, what are the color limitations in the markers used? And so we need to complete more data. The biochem technology is why is the triceps data different? What will the disease group data show? And then how can we implement biostamps in telemedicine? So like I said, we have to do data collection, literature, with more discussion. The color normalization project is in its baby steps. So it's really the same question we started out with. Is it possible to assess a patient's color via telemedicine? So we need to do those experiments. And then I didn't really touch on this too much, but we're also working on a COVID-19 survey for different colleges across the country and within the University of Arizona to test patients over, the students' overall knowledge of COVID-19, what their well-being is, how has their life changed, and are they comfortable with telemedicine in general, or are they more comfortable in clinic? And then we hope to complete another COVID-19 survey about the general public's comfort level with telemedicine, and if they trust it. So that is pretty much it, and these are my references and sources. Does anybody have any questions?
That was a tremendous amount of work that you did, switching gears. We have time for one question. We don't want to get behind too much, but we have time for one question if there's one out there. Is Dr. Slepian there?
He was unable to make it. I believe he's in clinic.
Okay, well, you were the authority then. Okay, thank you very much, Shay. That was very interesting. We're going to go on to Christina Starachak, and I'm just going to abbreviate her title because you're going to see it in the title slide, where she did investigation of neuroimmune biomarkers, and her mentor is Dr. Sturger. We'll have her comment at the end.
Hi, good morning. I'm going to go ahead and share my screen.
Good morning.
Can everyone see that?
Yes. Mm-hmm.
Wonderful. All right, so I'm going to go ahead and get started here. So my name is Christina Stroszak. I am a part of the class of 2023, and the project I worked on over the summer was entitled Multi-Dimensional Analysis of Sweat Using Liquid Chromatography Mass Spectrometry Methods. And I did this through the Andrew Weil Center for Integrative Medicine Laboratory. So the PI at the laboratory is Dr. Esther Sternberg. She's professor of medicine and psychology, director of research at the Andrew Weil Center for Integrative Medicine, and director at Institute on Place, Wellbeing, and Performance. And I worked almost on a daily basis with Dr. Runyon, an analytical chemist. He's an assistant professor from the Department of Environmental Sciences, and he runs the Stress Challenge Sweat Collection Stress Correlation Lab. So upon entering at the beginning of the summer, there was a lot of really cool projects going on in the lab. And one of the big projects that was going on was the analysis of sweat samples, sweat pore activation, and pupillary response during cognitive and physical challenges. So the lab really wanted to look to see what was going on in terms of the autonomic nervous system with the components inside of sweat. How sweat pores are activated or turned online, and how do we correlate that with a lot of our previous knowledge about pupillary dilation. And there's a lot of different departments working within this project. So the Department of Psychology, the College of Engineering, Image Analysis, and the College of Medicine. So on the left here is a graph or a series of graphs from one participant from this research. And so you'll see there's different colors, a lot going on. The first yellow color is just showing a participant at baseline. And then the grayish blue is showing a participant during a cognitive challenge. And then those pink stripes is showing a participant during a physical challenge. And then the first graph is showing sweat area. The second graph is showing the sweat number or sweat pores that were activated at any time. And then the last is showing pupillary dilation. So one thing I wondered entering into the lab was, how do you count sweat pores? So this is my next picture here of a thermal image of the ankle. And so there was a student at the College of Engineering Department of Electrical and Computer Engineering that developed a program to actually count these sweat pores as they came online, if you will. So all those little black dots there are actually activated sweat pores. And so he was able to use that program, and I helped to run the program that would actually collect the data in real time. So my interest was really in the LCMS method, looking at the sweat that was collected and seeing what type of biomolecules were found in the sweat at these different time points between cognitive and physical challenges. So after a lot of discussion with Dr. Runyon and Dr. Hyde, I developed my research question, which was, using LCMS sweat sample analysis, what variability is seen in both steroid and neurotransmitter pathways during cognitive and physical challenges? Turns out this is a really big question and probably pretty ambitious. I spent most of the summer working on method development. Before I had entered into the lab, the sweat had already been collected. And I won't speak too much on the sweat collection method, but I will say that within this project, the participants didn't need to be running around or moving a lot to collect the sweat. It was just collected as they were sitting, which I think allows for a lot of future application in this work. But I did help on working with the sweat extraction method. So what type of solutions are we putting the sweat in to prepare it for LCMS? And then also working on all the variability within LCMS to best hone in the ideal method for analyzing these molecules within sweat. And I have to say, there's not a lot of previous research with sweat. It's kind of an unknown territory. And so I think that makes it exciting, but it also makes it quite challenging. And then in the future, I hope to run those participant samples and also evaluate the data. So the questions I began with, the first one was, how does sweat pore activation and pupillary response correspond to these cognitive and physical challenges? I think now we have enough data to answer that, and we are realizing that we might want to change the experiment or improve it a bit to even improve the data that we found. And second was, in what context is mass spectrometry used? I came into the lab knowing very little about mass spec. And so now I understand, or have a clear understanding as to when we would use this type of method in research. And then the last is, what LC-MS methods work best to identify and monitor biomolecules within sweat? We are still working on that question. So a little background around LC-MS. Dr. Runyon likes to explain that LC-MS is like a molecular hammer that's going to break up the sample so that we can see all the components inside. So liquid meaning that we're looking at a liquid sample. In some cases, you might want to look at a gas sample. Chromatography meaning that it's separated into its different components, and that we're separating according to the mass of those molecules. So what is the mass of dopamine, or what is the mass of, let's say, aldosterone? And then spectrometry, meaning that we're looking at this on a spectrum. So I spent a lot of the summer looking at a computer screen connected to the LC-MS machine and looking at these little peaks here. And I'll talk more about that in my next slide. So on the right, this is just an example table of some of the masses that we programmed in, and some of just the steroids that we looked at. Again, we also were looking for neurotransmitters. And then these are some of the peaks that we would look at eventually. So you can see cholesterol on the top left has a retention time a little bit over 1.5 minutes, meaning that it's going to come out of the LC-MS according to its chemistry. So it helps us understand more about the molecule, how it might be interacting with other components within the sweat. And then the size of the peak really tells us what's the concentration of that particular biomarker in the sweat. So my progress, I learned how to use LC-MS. I'm getting better, but it is definitely just the beginning. I helped to identify over 18 steroid biomarkers and 8 neurotransmitters in sweat. And I also helped to apply techniques such as solid phase extraction and background subtraction to really verify these biomolecules. So sweat is difficult to look at. There's a lot going on. And so some of the obstacles were that sweat can be highly variable. There's a lot of different factors that need to be accounted for. Another obstacle was just developing this robust, reproducible method that eventually could be quantitative. And the last was resolving the varying retention times between standards and sweat samples. We weren't seeing the same exact retention time between what was coming out of sweat and then what we would see in a standard. And so that was something that we began to really evaluate in the last week. So there's a lot of other benefits working in the lab. Of course, I got this amazing LC-MS training and mentorship. I also trained in sample preparation, solid phase extraction, and running ELISAs. I worked on literature reviews, and I most certainly have a newfound appreciation for methods development. There's a lot of days, a lot of hours, a lot of thought that has to be put into method development. I also learned how to use the BioPack for physiological monitoring. And I also participated in biweekly lab calls, which really gave me some insight into the daily workings of a lab as we had to discuss progress or deadlines, budgets, and goals. So I think this part for me was the most exciting to think about at the end of each day. What's the big picture? What can we do with this work that we're really working on and researching? So these are some of the applications and discussions that we had in the lab. One was monitoring patients with acute respiratory distress syndrome using sweat. I think there could be some cool potential there. Also assessing and monitoring supplement usage, and also monitoring medication metabolism, what's happening with medications that people are taking in real time. Monitoring fitness for high stress roles such as the military, monitoring stress response in varying surroundings, and I think this long-term eventual potential for developing a wearable device that provides real-time reports of critical biomarkers. So, excuse me, my remaining questions were, what methods will allow for quantification? So just because we might see an increase or a decrease in a particular neurotransmitter or steroid, how much does it increase or how much does it decrease? Another question was, are these specific sweat biomarkers, or which ones are the best to inform us of pathway changes? Instead of looking at, let's say, 12 to 15 are there 2 or 3 that we could really hone in on to understand more about the pathways and create more reproducibility in the future? And the last was what improvements in current LCMS methodology may correct for this variability from individual to individual within sweat. So my future plans and the lab's future plans, short term, we're working to resolve those retention times within LCMS. There's a couple possibilities there. We know that sodium and potassium are essentially everywhere and very present in sweat. And so we started looking at accounting for those adducts or added ions to a particular biomolecule and add those into the programmed masses that we looked at. And we also evaluated and started looking at applying solid phase extraction to really clean up the sweat sample even before we collected data off of it using LCMS. And then there's plans for future studies to correlate sweat biomarkers under controlled stress conditions. So I just wanted to say thank you to the MSRP program, Dr. Whitty and the Graces for this opportunity. I've given a lot of thought about how I would use this newfound appreciation for research, and I hope that I can continue researching while I'm at the College of Medicine. I certainly have spent a lot of time thinking about the implications of research on clinical care, and I certainly hope that as a practicing physician, I can also be researching. And just a big thank you to the Center for Integrative Medicine. Dr. Sternberg, Dr. Runyon, Dr. Hyde, and Paula Cook have just been amazing. I'm sad to not continue on as I have to go back to classes, but it's been an incredible experience.
Thank you very much, Christina. I liked your continuing saying, I was thinking about, and I thought at the end of the day, and I'm thinking. That's certainly nice to see. Unfortunately, in medical education, you sound like it's going to interfere with your thinking. I'd like to think we enhance it. Just a simple comment, and then I want to ask Dr. Sternberg and Dr. Runyon, just very brief. We're already running a few minutes behind. When I was a resident, I had the opportunity to study a patient with primary aldosteronism. And I recall collecting sweat on that patient repeatedly under treatment with aldactone and changes in diet. But all we were looking at was sodium and potassium. Now we could actually measure aldosterone from what you're saying. So yeah, we've come a long way in being able to detect these biomarkers. Dr. Sternberg, did you want to just make a comment? And Dr. Runyon, very brief.
Well, I think it was excellent, Christina. You did a terrific job. And the only comment I would, am I supposed to ask a question or make a comment?
Either way.
I'm gonna put,
as long as it's an unanswered question.
Yeah, well, I just want Christina to clarify the connection between the pupillary responses and the sweat pore activation and the content. You talked about it, but just for the audience, what part of the nervous system are we honing in on when we're looking at trying to connect the, for example, neurotransmitters and cortisol with numbers of sweat pores that are activated?
Yeah, so from what we understood, and Dr. Sternberg, please jump in, we're really looking at the autonomic nervous system. So how does it respond to a cognitive challenge, and then how does it respond to a physical challenge? We know that pupils will dilate when the autonomic nervous system is turned on. And so we kind of used that baseline understanding and compared it with what was happening with the sweat at the ankle and the sweat pore number, the activation of those. Does that answer?
Yeah, thank you.
And how about Dr. Runyon? Did you want to just make a brief comment?
Hi, good morning. I just want to say thank you to Christina for all of your work and help in the lab, and your curiosity and your continuous lines of questioning. Those were always created really good discussions. The other thing I wanted to add is, and this goes also with the previous presentation that I saw, and I'm sure many that you will have throughout the session over the next couple of days, is that really addressing some of these problems are so multidisciplinary. And as a practicing clinician, I think it's good for as the students to get an understanding that many different disciplines come together. So, for example, fundamentally in this study, we're using a lot of environmental science strategies where we would look at contaminants in the environment and really applying them to low-level concentrations of biomarkers. So how can we learn from other disciplines that are out there, and how can that tell us about what's going on with the human? And I think that that's a really interesting sort of multidisciplinary approach and really important moving forward.
Thank you, Dr. Runyon. And I want to apologize because you have a namesake. I don't know whether you know it. Ray Runyon, who was professor here in molecular and cellular biology, and he was a regular mentor every summer for multiple students. But you're E. Ray Runyon, and it's nice to see that you're taking up his mentoring legacy since he just retired this year. So
we may or may not have had a few crossed emails over the years.
Okay. Well, I think you should meet because he's a molecular biologist, so maybe he'll be interested now that he's retired in joining your team. Okay, we're a couple of minutes behind, and I want to remind everybody these two students have obviously put a lot of their questions in. Try to have your beginning questions and ending questions. And our next presenter is Daniel Kitts, class of 2023. And I'm just going to abbreviate his title as thromboelastography. And Dr. Bilal Joseph, who's professor of surgery and head of trauma, was his mentor.
Right. I'll just share my screen. All right, can you guys see that?
Yes.
All right, so my name is Daniel Kitts. I'm a second-year medical student, and this summer I did my MSRP project with Dr. Bilal Joseph. He is an associate professor and chief of division of trauma and acute care surgery. So we looked at the significance of thromboelastography in traumatic brain injury patients on anticoagulants. So traumatic brain injury is definitely one of the most devastating causes of morbidity and mortality in trauma patients.
So I'll hopefully it'll stay on.
Often it causes about, it can lead to intracranial hemorrhage, the incidence of which is about 56%. And so intracranial hemorrhage can be defined as like a subdural or epidural, subarachnoid, intraparenchymal hemorrhage. And the progression of that intracranial hemorrhage on a CT scan depends on several factors of the patient. So it could be age, severity of injury, use of anticoagulation, or the presence of coagulopathy, which can be trauma-induced or often due to drugs like anticoagulation. And so the diagnosis of coagulopathy in trauma patients is very crucial. It's associated with about a 5-fold increase in mortality in the trauma setting. And so there's been a massive research effort here at the University of Arizona, led by Dr. Joseph, to investigate the significance and association of coagulopathy with traumatic brain injury. And so this was a study of Dr. Joseph's back in 2013. He investigated the association between pre-injury clopidogrel with adverse outcomes of traumatic brain injury patients. And so that was shown to patients that were on pre-injury clopidogrel prior to their TBI. It was shown to increase the intracranial hemorrhage progression on repeat head CT and neurosurgical intervention as well. And so a different study done by him in 2014 also investigated the use of platelet count in identifying coagulopathy and adverse outcomes in traumatic brain injury. And so this demonstrates that a platelet count of less than 135,000 can indicate as well an increase in ICH on repeat head CT, neurosurgical intervention need, and mortality for these patients as well. So the idea is that we can see that antiplatelet therapy, in addition to identifying use of labs to identify coagulopathy, are extremely crucial in traumatic brain injury patients. And with the increasing rise of anticoagulation utilization, it's very crucial to identify the use of anticoagulation therapy in traumatic brain injury patients as well. This graph just represents the increased use of novel oral anticoagulants over recent years. So the NOACs, as they're called, they include the factor 10A inhibitors, such as apixaban and rivaroxaban, and then also dabigatran, which is a direct thrombin inhibitor. And so their utilization has definitely increased. We kind of see a slight decrease in warfarin. Anticoagulation is mainly prescribed for patients with cardiovascular disease, atrial fibrillation, following an MI, or cerebrovascular disease, anything with atherosclerotic disease or hypercoagulable disorder. And so diagnosing coagulopathy in the trauma setting can really be done in a couple of different ways. There's conventional measures such as the PT-INR test or the PTT, prothromboplastin test, using platelet count. But one of the newest measures being used now is called thromboelastography. And so what is thromboelastography, also called TEG? Well, it's really a measure of the efficiency of blood coagulation. And so there's several advantages to using TEG because it represents the entire process of coagulation from the beginning of clot formation to the end of fibrinolysis. And so there's several parameters such as the R value, K value, alpha angle. They're all independent values of one another that demonstrate different parts of the coagulation cascade. And this has been why it's been widely used in surgery in the past, mainly to differentiate the cause of bleeding, whether or not it's due to coagulopathy or surgical induced. But it's very up and coming in recent years in the emergency care setting, as well as the acute care in the ICU. So advantages of TEG include it measures platelet function directly. It demonstrates clot strength, and as well, it also measures fibrinolysis. And these are all things that the standard tests of coagulation, such as INR and PTT, cannot do. So questions that we began with in our study was to really identify how anticoagulation therapy affects these TEG parameters in TBI patients. And in addition to that, how anticoagulation therapy can affect outcomes of TBI patients in general, such as progression of intracranial hemorrhage, neurosurgical intervention, mortality. Any of these adverse outcomes on TBI interested us in identifying these in anticoagulated patients. So to do this, we did a 2-year retrospective analysis of traumatic brain injury patients that were admitted to BUMC Tucson from 2019 to 2020. We included patients above the age of 18, patients with a head AIS of at least 3, and initial CT of the head performed at least within 12 hours of admission. We excluded patients that were dead on arrival, transferred from other centers, as well as patients that presented with liver disease, just to eliminate any confounding variables of coagulopathy. And so we developed 2 cohorts. We stratified patients, TBI patients who underwent TEG into an anticoagulation cohort, and that amounted to 66 patients. And then we stratified TEG patients into a no anticoagulation cohort. That was about 132 patients. And so we measured outcomes such as the ICH progression on CT, in hospital complications, in hospital mortality, and TEG parameters as well. This was all done using a 1-to-2 ratio propensity matched analysis to increase the sample size and power of our study for the statistical analysis portion. And so some of the results that we got, well, this is our demographics table of our study population. So you can see that we stratified into anticoagulants and non-anticoagulants. Mainly the demographics that we looked at were age, sex, admission vitals, such as systolic blood pressure, heart rate, Glasgow Coma Scale. And then we also looked at, something else was interesting, that we looked at loss of consciousness. There was no significant differences in this data, but in our injury parameter variables, we evaluated the frequency and size of subdural hemorrhages, epidural hemorrhages, subarachnoid, and intraparenchymal hemorrhages, and stratified them as well among anticoagulants and non-anticoagulants. There was no significant data or no significant differences in between any of the sizes here. Many of the anticoagulated patients, though, from what I noticed when I was collecting the data, seem to have increased sizes. I'm sure with increased sample size, we could potentially investigate that in the future, and I constantly question that too. I would bring that up to Dr. Joseph and the fellows as well, asking them those kinds of questions about what about anticoagulated patients and loss of consciousness, looking at different variables. It was all very, very important. And so we also included packed RBCs and platelet transfusions, looked at those. But this was really the meat of our study. And so we looked at the TEG parameters and how they differed between the anticoagulant group and the non-anticoagulant group. And we can see that there was significant differences across the entire board here. We see that there was a worsening of all TEG values for the anticoagulant group, which demonstrates either decreased clot strength or increased time to clot formation. And then we compared that, we looked at that and we compared that with variables of our adverse outcomes in the anticoagulant group as well. And so we can see that we did have a significant difference in the progression of ICH in the anticoagulants versus the non-anticoagulants. About 30% of anticoagulants showed an increase in size on repeat head CT scan. However, there was no difference between neurosurgical intervention, hospital length of stay, or mortality among any of these patients between the anticoagulant or non-anticoagulant group. And so in answering kind of the questions that we started with, we can see that there was a deterioration of TEG parameters, between anticoagulants and non-anticoagulants. But the progression of intracranial hemorrhage as well was also much larger for the anticoagulant group. But there was no apparent association with neurosurgical interventions and mortality. So this kind of reflects on the success of the trauma team and how they're able to, kind of read the crucial nature of these anticoagulant groups and how to treat them and how to best attend to them in the ICU. And so questions that we're still kind of sticking to, we want to evaluate the boundaries of these TEG parameters that demonstrate coagulopathy and identify at which point there's no reversal. So maybe there's an indication of where the line is drawn with coagulopathy and where there's an indication of mortality that really cannot be repaired in neurosurgical intervention or with any type of administration of a reversal agent. And then, excuse me. And then maybe we also wanted to compare between different types of anticoagulant therapy and how the TEG parameters differ between NOACs and warfarin and antiplatelet therapy like clopidogrel. And then eventually maybe even look into TEG becoming a wide standard test in for coagulopathy in the trauma setting. So plan for unanswered questions. We definitely just need further studies to verify the role for TEG in TBI patients with pre-injury anticoagulant therapy. We definitely need a larger sample size. More power will help us to answer the questions. Understanding how TEG parameters can predict adverse outcomes of TBI. And a lot of it is just based on more data. We collected a lot of data this summer, but with the increased utilization of TEG, it's just becoming more and more prevalent in trauma centers. Should be very helpful in identifying some of these questions and being able to answer them. And then just a very big thank you to the opportunities that Dr. Joseph and his fellows provided me over the summer. I learned a lot from these gentlemen. They really helped me just identify what I'm interested when it comes to clinical research and how to coordinate, how to plan, how to outline each variable. We collected over, I want to say 85 variables for each patient and really built a strong traumatic brain injury data set. So I got to ask all the questions in the world and these guys really helped me out. I'm forever grateful for that.
Okay, thank you. Thank you, Daniel. I mean, these have been masterful presentations that we're starting off with. I hope we're setting the standard for the rest of the day. A couple of points. All of the presentations are being video recorded. They will go up onto our YouTube channel, so you can put them in your bio sketches as refer to our YouTube channel as a site for this presentation. In addition, the Carmel meetings, which the students have gone to over the years, which occur at the end of January, have been canceled and they're now virtual. Last year, we had very few students go because they coincide exactly pretty much with the step 1 date, and they will again this year. But now that the meeting is virtual, the abstract submission time is in September. They're pretty lenient in terms of accepting abstracts with preliminary data, but it looks like some of you here are going to have more than preliminary data. And it is a publication, and I think they will still publish the virtual abstracts in the Journal of Investigative Medicine. So it will be a published abstract. So I urge you, if you do have your projects to that point, to submit for that meeting. Do have your mentor take a look at the abstract. I'll sponsor it since you have to have a member sponsor you.
I will be sending out the information to all the medical students next week. So please don't email me this week for the info.
It's going to be in mid-September, I think, the abstracts.
No, it's usually the last week in September, but I will get that out and it'll have all the explanation on how to do it.
Right. You're going to miss the Carmel experience, which is a wonderful time that the students have had there in the past. Okay, we are then going to proceed to the next presentation, unless Dr. Joseph is here. I'm assuming he isn't, or maybe one of his fellows, just to recognize them. We're a little behind time, and since mentors are coming in according to the time schedule, we're trying to keep as well as we can on time. Our next presenter is Christine Marie Hall, who's the class of 23, and she's become an expert on Merkel cell carcinoma under her mentor, Dr. Jennifer Erdrich, who's assistant professor in surgery.
All right, thank you, Dr. Whitty. I'm going to go ahead and share my screen. All right. Okay, so initially I did start out with a project on Merkel cell carcinoma. However, the IRB approval process for that project basically took the entire summer. So unfortunately, I wasn't able to complete a project on Merkel cell. So my mentor and I ended up brainstorming, and essentially what we came up with was looking at melanoma thickness in Medicaid patients in pre and post Affordable Care Act. Right. So initially with this project, something I really had to learn to do was pivot. So to change my question, because sometimes your initial question doesn't work out. And what I learned with that was that the initial project that I had was a skin cancer. Merkel cell carcinoma is a rare and aggressive neuroendocrine carcinoma of the skin, but our IRB delays made it so that I needed to create a new question. So I started looking at melanoma, which is also a very aggressive skin tumor. However, it's a lot more common. So I realized that a lot of the questions that I was asking about Merkel cell carcinoma could be asked about melanoma. So I started asking, okay, how is it diagnosed? How is it treated? Who's being diagnosed with melanoma? And what are the patient demographics? So I had to start refining my questions and my train of thought. So I found that the typical patient who's diagnosed with melanoma is a middle-aged or elderly white male. And I thought, okay, what about everyone else? And I found that patients who were members of a minority group were more likely to be diagnosed with advanced stage melanoma. To me, I initially thought, that's really strange. I did some more research and I found that Black patients are actually less likely to receive surgical treatment for melanoma. This is also a trend with Hispanic patients as well. So I started thinking, why is there an inequality present? And I also thought about dermatology in general. Needless to say, I think we all know that dermatology can be a field in which cosmetic procedures and people who have more money are able to, see a dermatologist more regularly. So I started to think about the inequalities present. Is it based on income? Is it based on someone's education level? Maybe they don't know what a melanoma looks like. Does it depend on their neighborhood where they live, unemployment? All of these things could affect their access to care. And I looked at that and I reviewed the literature, and it was sort of a mixed bag on a lot of these different socioeconomic issues. However, one thing that really started to stick out to me was that your insurance status really mattered. So when I talk about insurance status, I'm thinking about private insurance, like your marketplace insurance, like Blue Cross Blue Shield, United Healthcare, those kind of private marketplace insurance plans, as opposed to Medicare or Medicaid, which are government-sponsored public insurance. So just to pivot back to the inequalities, one thing that you can do on the SEER website, which is a national cancer database, you can look at their website and do some cool stuff with statistics. So I started out looking at, okay, is this trend actually being observed? So SEER, what it does is it collects data from different cancer centers across the US. So this graph that I'm looking at here is melanoma of the skin. It's the stage distribution. So we have localized, regional, distant, and unstaged. So of course, the most advanced melanoma that we're seeing here is going to be the distant melanoma. And I've circled it for everyone to see. And this is in white patients, and it's all ages, male and female. And then we move on. This is a graph of Hispanic patients. And you can see there's been a notable increase in distant melanomas. And then finally, we look at Black patients, and you can really see these bars have increased. So something that really struck me was, okay, I need to maybe take a look into this. Maybe this idea is something I can roll with. So I started to think insurance is mattering for the treatment that these patients are getting. I wasn't sure what socioeconomic factors could be at play. However, one thing I did start thinking about was the legislation around healthcare. And I started thinking about the Affordable Care Act. It was passed in 2010, and a big part of the Affordable Care Act was that it created a Medicaid expansion. So essentially, this Medicaid expansion allowed people ages 18 to 64 years old who are at less than 138% of the federal poverty guidelines to have insurance. So this meant that more people would be getting insurance. The only catch is that certain states could choose to implement the Medicaid expansion sort of at their leisure, or within a certain time period. So this is just a map from the Kaiser Family Foundation, and the light blue states show you the states that have adopted the Affordable Care Act Medicaid implementation. However, the dark blue states have not implemented. So then I started thinking, okay, are there any differences that we're seeing between the light blue states with Medicaid and the dark blue states without the Medicaid expansion? And I found my answer in a paper by Jamal and his colleagues. I found that patients who resided in Medicaid expansion states had a very small but significant shift towards lower stage disease, especially in melanoma or in other cancers that you can screen for, like breast cancer. So this was really interesting to me because I thought, okay, well, if we can see a decrease in the stage of cancer, perhaps we can see even greater decreases and follow this trend before and after the Affordable Care Act. So my question became, if increased insurance coverage increased your access to care, would I find less advanced stage melanoma at the time of diagnosis in patients in the years after the implementation of the Medicaid expansion under the Affordable Care Act? So the year range that I decided upon to use was from 2010 to 2017. 2017 is the most recent year that I can get out of the SEER database, and 2010 was the year the Affordable Care Act was passed. However, in 2014, that's when most states passed the Medicaid implementation. So that was why I chose that age range. And then the next thing I needed to run into was, okay, I have a question, how do I investigate it? And the answer to that was by using a large population-based national cancer database. So I ventured into learning how to use the SEER database. Learning to use a database is kind of a task in and of itself. But as I became more familiar with the database, I learned about the variables I would need to extract. And probably the most important variables that I had to learn about just to get up to speed with the research I was doing was learning about tumor thickness. So the thickness of the melanoma and how that plays a role in staging. Some other variables that I'm looking at are surgical treatment, radiation, sex of the patient, where they live, their race, their age, and of course their insurance status. So first and foremost, I had to learn about staging information. So as we all know, staging, the way we stage is with tumor, nodes, and mets. So for melanoma, the way we judge the T stage is with the Breslow thickness, or just the thickness of the melanoma. You can also see if the melanoma has had a micrometastasis to a sentinel lymph node, and we'll talk about that in a bit, as well as metastasis to distant organs. So just to sort of get myself up to speed, I had to say, okay, how am I staging the T portion of melanoma? And there's a clinical component and a pathological component. So there's a lot of people working on the care of a melanoma patient. For clinical staging, that is sort of the first excisional biopsy that either a dermatologist or a surgical oncologist will do. And that looks basically to determine, is this a melanoma that's more superficial and something we aren't worried about that doesn't really need to be staged? Or is this something that has a deeper Breslow depth and we need to do further staging? In addition, at that time when you're doing that initial excisional biopsy, you're going to do a clinical exam for other nodes in the region. And then the pathological component here, this is really important. This is where you see the microstaging of your melanoma, and that sort of has to do with how deep is it? Are there mitotic figures, things of that nature. So moving on, as far as the T stage goes, I kind of have this table here, and this is from the American Joint Committee on Cancer, and they put out these guidelines, and this is what surgical oncologists follow. So essentially anything that is 0.8 millimeters to 1 millimeter in depth is considered stage T1. And on this graph right here, this is just a really simple graph that I pulled out of the cancer guidelines. And you can see that this hot pink line is up here. So this means that these patients are having the best survivability. So that's what we want to see. So lower stage of the T means better survivability.
Christina,
And
we're running over.
the next
10
component
minutes, so kind of move along.
nodes. Okay, next component is nodes. This is a sentinel lymph node biopsy. I had to learn about this. Essentially, it's a very safe technique. You essentially remove the lymph node that melanoma tumor drains to, and you determine if there are any micrometastases in that lymph node. This is what it looks like. This is a micrometastasis in that node. And then these are just some more pictures of the nodal staging. And finally, I had to learn about metastases. So different kinds of metastases, where they go, what organs. And then as far as my statistics go, so once I had all the data that I wanted to extract, I needed to bring in a statistical expert because the statistical relationships that I would be looking at would be fairly complex. And I had a couple issues I needed to consider. One of which was the staging criteria that I had just talked about from 2017 or from 2010 to 2017 had changed considerably. So I needed to find a way to keep everything fairly standard. And the answer to that question was looking at tumor thickness. So a lot of the relationships I'm going to be pulling from this paper will be based upon tumor thickness. Another thing I thought about, well, what if the relationship I'm looking at doesn't exist? I talked with an expert and he said, normally how these database projects go is that a researcher finds a relationship first, and then from there, they kind of write about it. So I did it the exact opposite way. And that was one big takeaway that I learned. So moving forward, I'm actually meeting with the statistician this upcoming week. We will be doing data analysis and discussing relationships with my mentor. So specifically, I'll be looking at the melanoma-specific survival for patients before the Affordable Care Act and after the Affordable Care Act who had Medicaid and private insurance. I'll also be looking at overall survival for those patients and percent changes in thickness. Additionally, I'll be looking for other relationships, including potentially Medicare relationships with marital status, things of that nature. Okay, that's it.
Okay, thank you very much, Christina. It was very hard for me to stop you, but you were running over. That was masterful. Just one comment. I co-organize a conference called Cancer Metastasis Through the Lymphovascular System. It's now just called Cancer Metastasis. It is the major international conference on melanoma, and melanoma surgeons and experts from all over the world come there. And I think you should submit the abstract. The next meeting is in September of next year. The abstracts will be in the spring. I'm one of the judges of the abstract, and I'm not guaranteeing you, but I'm saying you certainly will have a chance to get your abstract in there. And we also have Young Investigator Awards too. So make sure you check with me. This is a real opportunity to meet the leading melanoma experts and surgeons. They're primarily surgeons, but we have basic scientists, epidemiologists as well there. So check with me on that.
Thank you so much.
We really have to keep to the 10 minutes from now on. I know I've been a little lenient, but there are mentors coming in and out, and we'll have to shorten the lunch break at this point, make it a real quick lunch. But we're going to move on now to Haley Owen, who's class of 23, and she's going to be talking about aged platelets and mentored by Dr. Slepian from the Department of Medicine. And we've also had several of the medical students, several of the high school students actually tapped into Haley, had her as a mentor during the summer.
Hi, good morning. My name is Haley Owen. I am an MD candidate at the University of Arizona College of Medicine, Tucson, and my PI for the summer is Dr. Slepian. He's a Regents Professor of Medicine. And what we wanted to focus on this summer was the differential response of age platelets versus younger platelets to physical and biochemical stimuli, because although platelets and thrombosis are central to homeostasis and hemostasis, there's actually a lot that is still unknown about the differences between younger platelets and age platelets. And some of that goes back to the uniform treatment of all of these patients with antiplatelet medications. And it's actually indicated that these antiplatelet medications may not work the same in all patients and may not be completely effective for patients that have CTDs. So thrombosis, while it is absolutely necessary, it can also be a dominant pathophysiologic process and disease and death. And in fact, thrombotic diseases are among the leading causes of death. And according to the World Health Organization, ischemic heart disease and stroke are the two top causes of death in the past 16 years. In addition, coronary artery disease is actually the leading cause of death in adults that are 75 years and older. So platelets are essential to thrombosis, but they also participate in inflammation and response to infection. They can be activated by numerous things such as collagen, thrombin, von Willebrand's factor, etc. Now, activation of platelets leads to the upregulation of the clotting cascade and more platelet aggregation, which can be helpful in thrombosis, inflammation, infection. However, overactivation of platelets can actually lead to occlusion, which can be detrimental. Now, altered platelet function can lead to prothrombotic and pro-inflammatory states, which can increase a patient's risk of cardiovascular disease and infectious syndromes like sepsis. However, altered platelet function was documented or has been documented in older adults, which indicates that older adults are at this increased risk of cardiovascular disease and infectious syndromes. Now, another way that platelets can be activated is actually through shear-mediated platelet activation, or SMPA, and that's the activation of platelets via blood flow-induced mechanical forces. So one way that this can occur is when a vessel is narrowed. This increases the velocity through that vessel and increases what we call shear rate. That allows for von Willebrand's factor to be unfolded and adhere to the vessel wall, which allows platelets to adhere and aggregate and can cause vessel occlusion. Cardiovascular therapeutic devices, or CTDs, are stents or mechanical circulatory support systems that can contribute to turbulent flow and non-physiological shear forces. So they can increase this shear force in the vessels. And so antiplatelet agents are actually the standard of care with CTDs to prevent these thrombotic complications.
Make sure that anyone who has their audio gets rid of the background noise so we don't hear that in Haley's presentation. So she should be the only one who's not muted, and myself. Go ahead. I'm sorry to interrupt you, Haley, but I didn't want your presentation to have all that background noise in it.
No worries. Thank you so much. So antiplatelet agents are the standard of care for patients with CTDs so that we can prevent the thrombotic complications. However, antiplatelet agents mitigate thrombosis itself, but have little effect on this actual shear-mediated platelet activation. So all of these information led to the question, how do age-related changes in platelets alter their response to physical versus chemical stimuli? Now that led to three more specific research questions, which include, what are the biomechanical, biophysical, and biochemical differences between younger versus age platelets? Is there a difference in platelet reactivity to shear stress versus biochemical agonists in younger versus age platelets? And what is the effect of shear stress versus chemical agonists on platelet biomechanical, biophysical, and biochemical properties in younger versus age platelets? Now, to answer these questions, the idea was to conduct blood sample collection of two age cohorts, so younger adults between the ages of 21 and 35, and older adults 65 years and older. then to perform dielectrophoretic electrodeformation, which assesses membrane stiffness, scanning electron microscopy to assess the shape of the platelet, whether it's elongated or discoid, platelet activation state assay to determine the level of thrombin generation of platelets, and flow cytometry to stain for different platelet activation markers or aggregation markers. Now, like many other students, my project was affected by COVID-19, and this left us unable to collect blood samples from donors due to safety risks. So I did a review of the literature on some of the thrombotic changes that occur with increasing age, and I've listed here just a few of the differences that I've discovered in this literature review. So some of the things that increase with increasing age include platelet reactivity to various biochemical agonists. Those that have been documented are an increased reactivity to ADP, epinephrine, collagen, and arachidonic acid. We also see an increase in reactive oxygen species production in older adults, which can contribute to increased platelet activation as well as aggregation. There's also an increase in platelet monocyte and platelet aggregation, which can contribute to detrimental results in stroke, and an increase in beta thromboglobulin, platelet factor 4, von Willebrand's factor, IL-6, fibrinogen, and plasminogen activating inhibitor, all of which may contribute to either increased activation or aggregation of platelets. Now, we do see a decrease in platelet counts in older adults, and also a decrease in bleeding time. This goes back to the fact that we see an increase in platelet reactivity. So although there are less platelets, the bleeding time is decreased because platelets are more reactive. And then we also see a decrease in prostacyclin surface receptors on platelets, guanylate cyclase, cGMP, and nitric oxide production, which decrease vasodilation, so that would increase vasoconstriction and allow for more platelet activation and aggregation. Now, although our specific research questions for this project still remain, there were more questions that we could ask based on the literature review, like what is the cause of platelet hyperreactivity to biochemical agonists in older adults? Because while many studies do indicate that there's a direct relationship between age, platelets, altered function, and hypercoagulability, why this is happening is not necessarily understood. The second question is, does senescence-associated secretory phenotype contribute to changes in platelet reactivity in older adults? Why is there an increase in beta thromboglobulin and platelet factor 4 in older adults? And how does an increase in cholesterol in the membrane of platelets contribute to hyperreactivity or enhanced aggregation? Now, this is important because platelet dysfunction may contribute to increased risk of MI, stroke, VTE, sepsis, and mortality. In addition, increased platelet aggregation contributes to mortality rate and stroke burden in elderly adults. And a decrease in estrogen in older women contributes to an increased risk of thrombotic disease. And as I mentioned before, thrombotic complications of CTDs are actually more severe in aged patients than they are in younger patients, even with the addition of antiplatelet medications. And now just to bring in a current aspect of this project, this was an article recently published in JAMA, Thrombosis in Hospitalized Patients with COVID-19. It's actually indicated that COVID-19 allows a patient to be at an increased risk for thrombosis, even more so than other viruses like the flu. And it's indicated that this thrombosis can occur through a number of pathways as like endothelial dysfunction or cytokine storm, but another factor they mentioned is platelet activity or platelet dysfunction. So because I wasn't able to completely work on the platelet project, I was involved in a number of other projects, which Shay actually went over as well, which include testing a motion capture technology system, testing biostamp reflex technology, color normalization technology, and developing a survey for COVID-19 to be distributed to U of A students as well as other students at other colleges. And I'd just like to thank the College of Medicine Tucson, MSRP, my PI, Dr. Slepian, and Shay.
Okay, thank you, Haley. That was remarkable also. I mean, the sophistication of first-year medical students, it's really remarkable that you've come to this level of sophistication. Also, as we do this video recording, if I interrupt you, we will edit out my interruptions, so don't worry about that. Juan will take care of that, so they will be as technically perfect as we can make them. We can have time for just a single question if there's one out there. If not, we're going to move along and try to catch up. We're about 20 minutes behind. Our next presenter is Christine Hauer-Megan, class of 23, and she's going to talk about over-the-counter supplements in breast cancer, and her mentor is Dr. Funk, and I suspect that Dr. Funk is here somewhere. Is Dr. Funk here?
Yes, I am here.
Okay,
Thank
all
you.
right. So when
Good
you finish,
morning.
we'll have her make a very brief comment. She's one of our all-time great mentors from the Department of Medicine.
Okay, so good morning. My project was on the use of over-the-counter supplements in breast cancer, and my mentor was Dr. Funk. So a little bit of background on this information. Breast cancer is an important subject to study as it's the second most common cause of cancer in women. And complementary and alternative medicine, which is also known as CAM, was our specific focus of this study, which includes the use of nutrition, acupuncture, and mind-body approaches. And then within this study, we were looking at the botanical side of complementary and alternative medicine, which botanical dietary supplements are products made from plants and plant extracts that are used to supplement the diet. So some commonly known ones include fish oil or turmeric. And then when patients use specific dietary supplements, there are potential risks with them, which a lot of women and healthcare providers are unaware about. So for example, there's a common extract known as DIM that comes from broccoli, and it's known to change the way that drugs are metabolized. And a lot of females with breast cancer are on tamoxifen, which is metabolized by the liver. So that's of concern. So the aim of this study was to determine which over-the-counter supplements are commonly used by individuals who are diagnosed with breast cancer. The initial questions that we started out with were, what are the most common vitamin, minerals, and dietary supplements used by breast cancer patients? We were curious who is recommending the use of these supplements to breast cancer patients. We were interested in how does the subtype of breast cancer affect the use of supplements? And then on the larger scale, interested in what are the potential drug-drug interactions between supplements and medications taken by breast cancer patients? So to collect this information, an undergrad student about a year ago had designed a REDCap survey, and then myself and another student revamped this survey. So we collected information about the patient's background and demographics. We characterized the patient's breast cancer by asking questions such as what was their initial diagnosis and what was their initial treatment. And then the majority of the survey was asking questions about the specific over-the-counter supplements use. And you can see on the right-hand side, if a patient were to click that they were currently taking it, then they'd be requested to answer how they take the supplement in addition to the primary source of information when they were taking the supplement. And then to recruit patients to take this survey, it was all done online through the use of social media, such as Facebook ads or Instagram. And we started recruiting at about the beginning of July, and as of July 20th, we had 373 total responses. For the basic demographic information, it was all females. The majority were Caucasian. The majority were from the US. So when we compared this demographic information to the national averages, we found that our survey was overrepresenting Caucasians and underrepresenting African Americans. So this is a new question that was raised that we're going to focus on how we could recruit a more representative demographic group. In addition, the average age at initial diagnosis was 56 years old from our data, And you can see on this graph that was published by the Sears database, the average age of breast cancer diagnosis is typically between 55 to 74 years old. So we do accurately represent this information. The type of cancer at initial diagnosis, from our data, the majority of women responding had estrogen receptor positive or progesterone receptor positive breast cancer. And based on the national data, the majority of women do have ER or PR positive breast cancer. And this is also of interest to us because with ER and PR receptor positive breast cancer, there's a concern about females taking supplements that are phytoestrogens. For the current treatment that patients were undergoing, the majority of patients were on a hormone anti-estrogen therapy, which is consistent with the data showing that most of our respondents were also ER and PR positive, as anti-estrogen therapy is a treatment that most of those patients would be on for 5 to 10 years after their diagnosis. So from our initial data, the most common vitamins and minerals used included vitamin D, calcium, a multivitamin, and vitamin C. And when we compared the use of the primary source of information for these different vitamins and minerals, it was interesting to see that for vitamin D, 80.5% of those taking it chose to based off of information that was provided by their healthcare provider. Whereas for vitamin C, we saw that only 35.3% of those taking vitamin C chose this based off of healthcare provider information. And there was a variety of other sources that they used to choose to take this supplement. For the top 5 botanical supplements in our preliminary data, we saw fish oil or omega-3, a probiotic, melatonin, turmeric, and cannabis. And then again, looking at the primary source of information, comparing these, and then in the previous slide that you saw about vitamins, you can see that with supplements, with specifically the botanical supplements, it seems to be that patients are getting less information from their healthcare provider and more from alternative sources. It was interesting with cannabis, the 35.9% were getting it based off of information from family or friends. And this was a trend that we saw when we looked at all the data about the botanical supplements, was that it was more common to have a variety of sources of information. So the questions that remain, well, this was just our first look at the data, and we're still collecting responses. So we're still interested in determining what the most common supplements used are. We now want to focus on how we can recruit patients in a manner that accurately reflects the demographics of patients with breast cancer. We're interested in what the potential drug-drug interactions between supplements and medications taken by breast cancer patients. Is it safe to consume these supplements when taking medications for breast cancer? And during the recruitment phase, we've brought up the question if all patients are well educated about their disease and current medication use. So moving forward, we're going to continue recruiting patients. We're going to analyze the data to determine the most common supplements, correlate this with the use of specific supplements to the type of breast cancer, correlate current drug use with current supplement use to look for potential problems, and determine the most common source of information for specific supplements. And then in the future, on a larger scale, we hope that this would direct studies on specific botanical supplements and the potential drug-drug interactions.
Okay.
Questions?
Thank you, Megan. Are there any questions? If not, we'll go to Janet. Janet's comments. Janet, you want to comment on Megan's experience with you or the general topic?
Yeah, no, I mean, it was Megan, great job on your presentation and everything this summer. Meg worked with Tony Rossi, who's an undergraduate, and they really did a great job on this project. So I think it's a great example of what you can still do from your bedroom, right? These are really...
Both of you were in the bedroom, not the same one, but you were also in your bedroom.
Right. Just to clarify, right? We were
I haven't seen you for months.
But anyway, so Meg and Tony did an amazing job on this. So kudos to them for this. And they have over 500 respondents so far. So they've done really well. So
these projects are ready for prime time. I mean, you're ready to submit abstracts. Some of you are ready to submit manuscripts. And we've been reluctant to fund projects that have a defined question and go to a national database to answer it. What you've done, if you use the national database to answer questions that you're working locally on, and you're either doing lab work or literature reviews locally. So this is the kind of use of a national database that we'd like to encourage. With simple question and answer that comes from. And also, you're following your questions. You're following your questions, and this is exactly what Nobel laureate Francois Jacot wrote in his autobiography, The Statue Within. In fact, one of our MSRPs met Dr. Jacot at the Pasteur Institute, but he said that his life was chasing question after question. It was exhilarating, never finding the answer before you had another question. So he described this adventure of science, and you're experiencing it. And I think that that is remarkable, commendable, and of course, I'm very excited personally to see you do this question chasing, if you will. Okay, are there any other questions of Megan, since she didn't take her full time?
If I could just say two things. One is I really think the idea of presenting at Carmel is something that all of the students should really consider. Again, in some ways, COVID presents an opportunity because it's going to be virtual. It'll be more easy for you guys to participate. So I'd really suggest you do that. It's great in person, and I think it'll still be a good opportunity. And then secondly, just to plug about what Meg was studying, I used to, along with Lane Johnson, present a lecture for you guys as medical students about interactions between drugs and botanicals. And I think just in general, I think both consumers and healthcare providers are not aware of the fact that there's a high risk for interactions. But botanicals are understudied, so a lot of times the exact risk is not really known. But I think as diagnosticians, you need to be aware of that, the fact that that's possible. And then the obvious thing then is if you don't know what your patients are taking, then you can't add that to your possible list of causes of side effects that you're seeing in your patient. So just to be aware of that, and always make sure you get a really good history and consider the possible medical or effects or side effects of things that you aren't prescribing, but that your patients might be taking. That's it. So good job, you guys. Very impressive presentations.
And some of those botanicals not only have serious life-threatening effects, but they can be fatal as well. I mean, they can lead to a liver failure and death alone, let alone in combination with other drugs. So they haven't been regulated or really studied. And Janet has brought her great expertise as an endocrinologist and metabolic disease expert to this field of complementary medicine. And that's a very important dedication that she has. Okay, we're going to move on to Nathaniel Wyatt Bridge, who's class of 23, and he's going to talk about cage fixation and screws, a little bit of a different topic. And I know a number of the high school students and undergraduates have worked also in this area. So go ahead, Nathan.
Okay, yeah, so hopefully everyone can see my screen. So as Dr. Whitty said, my project is entitled Stability of the Cervical Stand-Alone Cage Fixation and Screw Angle at C5, C6. And my mentor is Dr. Venkat Ganapathy, and he's an associate professor of orthopedic surgery here at Banner. So before I get into the actual procedure and what we're going to be testing, I wanted to talk about the surgery itself and how we will be testing what we will be testing. So The procedure is called an anterior cervical discectomy infusion, or ACDF procedure. And it's actually fairly prevalent. It's regarded as one of the most commonly done cervical spine procedures, and it's about 130,000 people in the United States per year actually get this procedure. So it's done pretty commonly. And the indications for why you would need this procedure done is any reason for just instability in the cervical region, disc herniation, and then especially any disc herniation and compression upon the spinal cord. And then so I listed a few diseases, that are commonly treated by this procedure, as you can read. And the big thing that has gone on in the past decade, I'd want to say, is distinguishing between the two constructs that are used when completing this procedure. So I took a screenshot. This is from a paper that I'm actually going to talk about in a few slides from now, but on the right side, these two plates is what they call just anterior plates. And if you can imagine, it was typically done with this plate. And if you can imagine a cage, just like this cage on the left, except without the screws, what has been done in the past is they will remove the disc and remove whatever is, compressing the spinal cord or whatever, if it's just a diseased disc in general. And they will input this cage, again, usually without the screws, and clean up whatever needs to be cleaned up in the actual spinal cord canal. And then once they stabilize the joint, they will actually plate this plate on the two vertebrae in the front, on the anterior side. So my study is specifically looking at C5, C6, so we'll just say C5, C6. So you can imagine that the superior two screws would be on the C5 vertebrae and the inferior would be on the C6 in this case. And the procedures typically go very well, and they're able to stabilize the vertebrae, and the cage allows for fusion of the two bones together. But it's not without post-surgical complications. And so the major complications that have been described in literature is pretty frequently dysphagia, especially in the acute phase after the procedure is completed, but especially in the chronic phase too, unfortunately. And then there's a wide range of recurrent laryngeal paralysis, nerve paralysis that is, esophageal perforation, even dural perforation. And so what people have tried to do recently is make now what is this, take the cage that was plated in between the two vertebra in the intervertebral space and put screws into it and see if you can stabilize it internally, per se, instead of having this anterior plate stick out in the front of the cervical vertebrae. So I will go ahead and show the construct we will be using. As you can see, this is titanium, and it's kind of a newer product that's been given by Medtronic, and specifically Titan. It's called the Titan endoskeleton interbody device. And so as you can see, there's two screws, and this would be able to fit right in the intervertebral space for these patients. You would have no anterior protruding of the device, and this would all be able to be within that intervertebral space. So using these two screws, obviously one goes superiorly, one goes inferiorly, and what we will be testing is actually manipulating the screw angle of these screws. And so I believe these are at 45 degrees. What we want to do is test stability of what we'll be using is cadaveric specimens. And we're going to test using these screws at 30 degrees, 45 degrees, and 60 degrees, and doing some, biomechanical testing and seeing if stability changes at all. But this device is great in that you can see, I put up on the left side just a few descriptions of the device in general. It comes in 24 different sizes to kind of have the perfect fit with whatever the patient's anatomy is. As I mentioned before, the zero profile, so it won't stick out and potentially cause those adverse effects I mentioned before with the anterior plate. And it's got this window in between the construct itself to facilitate bone growth. And it's actually got this microscopic roughened surface, as you can tell, which the creators of this device say will facilitate bone growth and fusion around that area. So my beginning questions I was wondering if manipulation of the screw angle alone would actually provide increased stability, which is obviously what we will be testing. I was wondering if it's possible that manipulating the screw angle may actually weaken the overall strength of the adjacent vertebra. And also I was wondering how well can the testing machine, which I will talk about in a few slides from now, how can it actually simulate real forces that would be experienced in patients? So just to go over kind of the current literature, this is a paper that we are trying to base our study off of, in a sense, but basically, as I spoke of before, this study used the anterior plate and then kind of basically, if you can imagine that cage I spoke about, but without the screws, they just put the cage, after they removed the disc, they put the cage into that intervertebral space and then plated. And this is all, again, with cadaveric specimens. As you can see, they've connected the two sides, I think C3 through C7 here. And they were able to move this around and test stability and things of that nature. So they tested the anterior plate construct and then also just the standalone interbody spacer. And this was significant because, as I wrote here, I took a quote from their paper. Their study indicated that there are no statistical differences in biomechanical stability conferred to the instrumented level between the anchored cage device with the 3 points of anterior fixation and the rigid anterior plate fixations. This was big because then you could assume that doing this interbody spacer itself would actually be just as stable as doing the anterior plate fixation, and hopefully you'd be able to remove some of the post-surgical complications associated with the plate. So another quick paper that I found that we spoke about is talking about the side effects itself, and I pulled a quote from there saying that the zero profile anchored spacers actually lead to similar clinical and radiographic outcomes compared with ACDF with plating. And then later on in the article, they mentioned that low rates of dysphagia, 2.9%, have been reported 3 to 6 months after implementation of a zero profile implant. And this is significant because many of the papers I read before mentioned that the dysphagia rates in patients with the anterior plating were anywhere from 20 to 30% acutely, and I believe roughly 10 to 15% chronically. So it's still pretty common that would happen. And so now what they've done with these findings is the interbody spacer that I showed a few slides ago that we will be using and testing on has kind of become the new way to do this procedure. So these are the testing machines that we will be using. These aren't actually from the lab at U of A that I'll be in, but these are the same machines that I will be using. So I found a picture and put them in here. So on the top is the MTS tensile testing machine, and you can think of it basically as a hydraulic press. So we plan on, once we have our cervical spine specimens and we do our implantation process with the interbody spacer, we're going to test stability, which we will be doing as flexion, extension, lateral bending, so bending to the left and the right, and then also axial compression using this hydraulic press and kind of manipulating pieces and parts as we go along. And then on the bottom is the Faxitron radiograph system, where it's just kind of a small box where we can do x-rays, and we're going to use this before, during, and after specimen testing to verify that our construct is still stable and things look as they should. So as far as progress made, unfortunately, lot of progression to this actual, all the biomechanical testing has been halted because we've been looking for grant approval, as the Medtronic devices are fairly expensive, as I'm sure people can imagine, and the cadavers also cost money too. So I spent a lot of time actually this summer researching and applying to grants, which I previously had no experience in before this summer, and kind of working on our project's protocol and making sure that things made sense and we were actually able to test what we wanted to test. But my mentor, Dr. Ganopathy, and some other people who are on the project believe that we're going to go through the external research funding program at Medtronic, and we can be funded through that. So I'm excited to get that started. But as I spent a lot of time on grant work, and as I mentioned before, I had no experience in grant work before this, and I'm sure that there are people and listening to the presentation who do have experience, but for those of you who are in my position and will be in the future where you haven't had much experience, it took me a lot of time to find grants. It was very inefficient. I didn't really know exactly what I was searching for, and if I didn't know if there even was a resource I could use that would kind of put everything I wanted to look for into one source. So after reaching out, I actually spoke with a research administrator here at the U of A, and she pointed out 4 resources actually, which I've all kind of listed up here on the top. The first being Pivot, which I'll talk about on the next slide, and then a university just database resource through Arizona, and then Proposal Central and Grant Forward. These last 2 are fairly similar, I believe, both useful, but specifically Pivot was the most useful for me. And I'll talk about it a little bit more, but this just makes the process of looking for grants and identifying actually applicable grants much easier and a lot faster than just doing Google searches. So just to quickly talk about Pivot. So Pivot has the advanced search platform where you can put in just any detail that you'd want to identify grants. And so you can put in any of the words that you want, and either doing it in a and/or format. If you need all of these words included, you'd want to put it in the and column. And if you just wanted any grant that matched a few words, you can just do the or column row. But as you can see below, you can specify the amount, the deadlines, the funding type, keywords, applicant type. You can really get very specific with it, and it does speed up the process of grant applications tremendously. So I just thought I'd mention that, as that's something that I've learned along the way that was very useful to me, and hopefully can be used in the future for anyone else who might find themselves in a similar position. And again, these are all through U of A. It's very easy to make an account, and you can just go through U of A for that. So remaining questions is, how can we standardize measuring range of motion during testing for each specimen? So some of the previous studies that I mentioned used an optoelectronic motion analysis system to measure how much these specimens actually moved during the testing and to what degree they moved, and so they can actually compare the stability. Of course, this will cost more money, so I threw that in there that we have to consider that. And then I was wondering if 3D printed fixed angle guides would work during surgical fixation of the specimens. As I mentioned, we are testing not only the 45-degree ankle screwing, but also the 30 and 60 degree. And so we need what is called a fixed angle guide, which can make it so that we standardize the drilling among all specimens in each angle that we will be testing, to make sure that every specimen is screwed the same. And then lastly, I was also wondering if muscular structures should be retained on each specimen during biomechanical testing. Previous studies have actually removed all adipose and muscular structures before the testing. But I was talking with one of the residents that is on the project, and we think that actually keeping on the muscular structures might actually make it more realistic to what the patient would experience. So as far as my plan, once we receive funding, which we're hoping to do in the next month or so, we're going to order our specimens from the Southwest Institute for Bioadvancement, also called SWIBA. We're going to have our cervical specimens DEXA scanned pre-arrival and x-rayed once we get it here, just to ensure that none of the specimens have any pre-existing osteoporosis or malignancies that would affect our testing. Develop the 30 and 45 degree angle guides, hopefully through 3D printing at Aztec, and then after that, just begin our testing procedures. And these are my references, and that's all I have.
Thank you very much, Nathaniel. Is your mentor there by any chance, or is he busy?
I don't believe he's here, no.
Okay. Are there any questions from the audience? Because we have some screw experts among the undergraduates, I know, and some of the medical students. Okay, if not, we'll move on. And our next speaker is Sarah Falahi. She's class of 23 also, and she's going to talk about models of diabetic retinopathy. Her mentor is Dr. Erica Eggers, who's Associate Professor of Physiology and Biomedical Engineering.
Hi, yeah, so I hope you can all see my screen. So my project was doing an RNA scope analysis of glycine and GABA receptors in diabetic mouse models. So to give you guys some background on diabetic retinopathy, this condition is a major cause of blindness in working age adults in the United States. And basically years of hyperglycemia from uncontrolled diabetes results in retinal ischemia. And as a consequence, the retina undergoes new vessel formation. But these new vessels are thin and they don't work well, so they end up bleeding and cause damage to the retina. And in general, diabetic retinopathy is thought of as a vascular disorder, but the hyperglycemia actually causes damage to the neurons of the retina before these neovascular changes occur. So the neurons that are involved in the rod pathway for light detection are especially prone to this damage. And it's important to know that the rod pathway is involved in the retina's response to dim light. So it's not surprising that patients with early diabetic retinopathy often report a reduction in their night vision. So learning more about the neuronal changes that are occurring in the retina with diabetic retinopathy will be important in understanding the disease process and for developing better treatments and management for the condition. So for my research project, we looked at 6 layers of the retina and looked at these layers for the levels of mRNA for glycine and GABA receptors. And so to better orient everyone, the ganglion cell layer is closest to the vitreous of the eye, which is basically the inside of the eye. And then the inner segments is closest to the sclera. And so the ganglion cell layer contains the cell bodies of ganglion cells and displaced amacrine cells. The inner plexiform layer has the synapses and is the relay station for bipolar cells to connect with ganglion cells. And it's also the location where various amacrine cells interact. The internuclear layer has cell bodies of bipolar, amacrine, and horizontal cells. The outer plexiform layer contains the synaptic connections between rods and cones, and the synaptic connections between bipolar cells that are vertically oriented and the horizontal cells. And then the outer nuclear layer has the cell bodies of the rods and cones. So for my project this summer, we focused on the glycine and GABA receptors in the retina. So for some more background information, the amacrine cells of the retina release both glycine and GABA, and specifically the A2 amacrine cells release glycine and the A17 amacrine cells release GABA. And both glycine and GABA are inhibitory neurotransmitters. And then in addition to these cells, the horizontal cells also release GABA. So in diabetic retinopathy, previous research has indicated that the amount of GABA that's released from the cells is reduced. So for the project I was working on this summer, we wanted to see whether or not the receptor levels for GABA and glycine also changed. So in a typical retina, glycine receptor 1 alpha can be found in the ganglion cell layer, the inner plexiform layer, the inner nuclear layer, and the outer plexiform layer. And the GABA A receptor alpha 1 are typically found on almost all retinal neurons. So the beginning questions we started off with were, does diabetes cause a reduction in the mRNA levels of inhibitory glycine and GABA receptors in the retina? Second question was, if receptor levels are altered in the diabetic mice, will this be reflected in the intensity of the particles in addition to the area of particles per region of interest? So basically, to explain that a little bit, ideally, if the mRNA levels are actually changed, you would see this reflected in both the intensity of the particles and the area of particles per layer of the retina. However, sometimes the results just reflect a change in the area of particles per retinal layer. And then the third question was, what threshold values should be implemented for analyzing particles for the glycine mRNA and GABA mRNA? And basically, threshold values are implemented as part of the process for analyzing the retinal images on a program called ImageJ. And the values used for thresholding is important because it eliminates unnecessary autofluorescence, likely due to blood vessels, and it converts the image to one that can be used to actually analyze the particles we're looking for. So for our methods, the RNA scope system was used to stain glycine and GABA mRNA on mouse retinal slices. And this was done prior to when I started performing the research this summer. So what I mainly did was using the ImageJ program to evaluate the 40 times magnified images of the retina for mRNA levels in each retinal layer. And then I also implemented MATLAB to produce graphs and compare the control and diabetic mice data. So the images here just show ones that are produced from ImageJ. And basically this one is showing how the glycine receptor mRNA levels are stained with green fluorescence. And then these are the GABA receptor mRNA that are stained with red fluorescence. And these are in the various layers of the retina. So we had 4 control mice and 3 diabetic mice. And what's important for you guys to know, because you'll see it on the next few slides, is that GABA1 stands for the GABA A1 receptor alpha 1, and GLRA1 is glycine receptor 1 alpha. So our initial results have shown that in non-normalized mean intensity data, there really is no difference in control versus diabetic mice for either the glycine or GABA receptor RNA. And so mean intensity is basically just indicating the amount of mRNA that's present in the retinal layers. And one thing to note when you guys are looking at these graphs, they're not in order of controls and diabetics. So as a reminder, mouse 301, 305, and 359 were the diabetic mice. And it is interesting to note though, even though we didn't find any real differences, control mouse 306 right here ended up showing glycine mRNA particles in the outer nuclear layer, which is unusual because typically you don't have that kind of receptor in that layer of the retina. So when we tried to look at the retinal images of the mouse, we didn't really know why this was happening, but it's something to look into in the future. And then this is similar data, but the data has been normalized for the intensity now. And again, the data doesn't show much difference in the levels of glycine or GABA mRNA levels when comparing the controls to the diabetic mice. And then these graphs show the results of how much area in each retinal layer is occupied by glycine or GABA mRNA particles. And the ROI just stands for region of interest, which is basically just each retinal layer. And these graphs also suggest that there aren't really any differences seen between the control and diabetic mice for the amount of area that glycine or GABA receptor mRNA take up in each retinal layer. But there are a couple things that are interesting to point out. So first, diabetic mouse 301 had the highest area of glycine mRNA particles in the inner plexiform layer of the retina. And we're not quite sure why this was happening. And then also the GABA receptor mRNA, the ganglion cell layer, right here, the GCL, is maybe indicating that the diabetic mice had a lower area of particles, but control mouse 306 also had lower levels of this mRNA. So a clear trend can't really be established, and we have to look into this more. And these graphs represent the area of glycine mRNA that's found in each layer of the retina. And the graphs have just compiled all of the mouse data so that we're comparing all of the diabetics to all of the controls. And again, the results don't show any statistically significant differences between the control and diabetic mice for any of the retinal layers. And this is a similar graph, except looking at the GABA receptor mRNA. And again, we didn't see any statistically significant differences between the control and diabetic mice for any of the layers. So in summary, like I said before, the GABA A1 receptor alpha-1 mRNA levels didn't show any statistically significant differences. And this was similar with the glycine receptor 1 alpha mRNA levels. So in the future, we want to answer questions like, why did diabetic mouse 301 have the highest number of glycine receptor mRNA in the inner plexiform layer? And will analyzing the 63 times magnified images show statistically significant differences in control versus diabetic mice? And so in order to do this, in the future, we'll be analyzing the 63 times magnified images using ImageJ, and then performing MATLAB analyses on this data as well, and then comparing this to the 40 magnified images. And these are my references. And I just want to thank Dr. Eggers and Andrea for helping me throughout this whole summer. And that's
Thank you, Sarah. Is Dr. Eggers here?
Not that I know of.
Okay, are there any questions of Sarah? Okay, if not, we'll move on to Cassandra. Cassandra Ann Roos, she's class of 23, and she's going to talk about the impact of COVID-19 on mental health. And her mentor is Dr. Chor, who's professor in the Department of Psychiatry, Medicine, and Psychology.
Alrighty, thank you. Let me move this. There we go. Are you able to see my cursor?
Yes.
Okay, wonderful. So my study was on sex differences in anxiety disorders and low socioeconomic status during the COVID-19 pandemic. Some background information from different studies is there are many articles that support sex differences in anxiety disorders, specifically that they're more prominent amongst females than males. And this results in a variety of different complications. For example, from metabolic standpoint, women secrete less gastric acid, which makes it so that the ability for them to absorb drugs is a little more difficult. And the way in which anxiety manifests in females tends to make it so that they're not diagnosed until a later time in their lives. There are also several studies that support the link between anxiety and socioeconomic status. The reason being that the psychosomatic symptoms with which females experience tend to require them to have more disability days, and as a result, end up resulting in a decline in their income. There are also gendered impacts of the COVID-19 outbreak, such as school closures that have, due to our cultural norms of women being more of the caretakers in families, have resulted in them quitting their jobs or lowering their hours at work in order for them to be at home more frequently. Our study looked at 1,000 different participants across 50 states. We gathered information from them through surveys that have been administered every month. Individuals had to be over the age of 18 and in good health. Through these surveys, we've been able to track the psychological evolution of their perceptions on the COVID-19 pandemic. We've assessed their perceptions from all different angles, whether they relate to politics, religion, fear, isolation. We've administered several different mental health assessments, two of which I'm going to focus on a lot today. Questions that I found answers to during this process are females disproportionately affected by anxiety than males during the pandemic? Is there a correlation between anxiety and income during the pandemic? Are higher rates of anxiety present among individuals in lower income quantiles? Are females earning less than males during the pandemic? And do females express more worry over the economic consequences of the pandemic than males? So to begin, these are two different studies that I looked at. Starting with the GAD-7, it scored from 0 to 21. If an individual has a score between 5 and 9, they're considered to have mild anxiety. If it's between 10 and 14, it's moderate, and 15 and above is severe anxiety. When looking at the Zung self-rating anxiety scale, it's from 0 to 80. If an individual is between 20 and 44, or 0 and 44, their anxiety is insignificant. They're said to be of normal standing. 45 to 59 is mild. 60 to 74 is severe, and anything over 75 is extreme. And I did a correlation study between these two using a plot diagram because I felt that it's very interesting and also important to note the relationship between these two different assessments. So our R-squared value came to 0.6, and so that means that on average, you have, if you were to get a Zung anxiety score, 60% of the time you can predict what GAD score that might correspond to. Now there's a 40% variability in this because, as we saw in the previous slide, the Zung scale goes a little more in depth with having 20 questions, and the way in which questions are phrased also varies, and so this tends to make it so that they have an additional component where they assess anxiety from different angles, and so certain parts of that do not align, but 60% of the time there is enough commonality between the two to where we're able to assume a tight relationship. So to answer the question, are females disproportionately affected by anxiety than males? I used the GAD-7 first, and so I developed a cutoff score of 8 to determine whether anxiety was present or not, and I used this from the Screening for Anxiety Disorders, a Systemic Review and Diagnostic Meta-Analysis. So that's where the cutoff score originated from. And as you can see here, I did a cross tabulation and found that with males, anxiety is present in 25.2%, versus in females, it's 38.1%. So after looking at the cross tabulation, I further wanted to look at the t-test results to ensure that there is no overlap in the bell curves, and to prove that these two groups are statistically different. They have a significant difference between them. And so initially, this was very interesting. My Levine's test showed that the equal variances were assumed to be similar, and there was a significant value here. And so I had to correct for the degrees of freedom in order to get an accurate p-value. And so what this means is, in a sense, there were independent variables that had what would be the equivalent of outliers that kind of skewed the bell curves, because they were already very tight, but they were close enough to where it might appear that there was some overlap. But after accommodating for the degrees of freedom, I was able to see that there was a significant difference between the two. And then I did that same process, but with the Zung anxiety score. And my cutoff was a 45 because that corresponds to the beginning of a mild level of anxiety. And I used the Norms of Zung self-rating anxiety scale to confirm this. Again, we had 16.5% of males versus 21.4% of females that showed anxiety. And then here, I did not need to adjust for the degrees of freedom because my equal variance is assumed was already insignificant. Is socioeconomic status influenced by anxiety and sex was another question I thought a lot about. And in this case, looking at this graph, our correlation study shows that the p-value is very significant. So these findings are significant. However, we have a inversely proportional relationship to the annual income and GAD-7 score, which is what I anticipated, because my thought was that individuals with lower socioeconomic status would indeed have higher rates of anxiety. So although this is present, and we see a shift right here at the 75,000 annual income mark, so that's when the trends start to shift. And again, this is a 0.121 value, R value, which, to give you a frame of reference, if anything is around a 0.3, it's said to have a moderate influence, and 0.5 is a significant influence. So the fact that we have a 0.1 influence means that although that relationship is definitely there, it's very significant, anxiety is not influencing an individual's annual income as much as I had predicted. And so I found that to be a very interesting finding. In addition, we have sex differences across different income quantiles. And so here I was able to see that immediately after doing a correlation analysis, the p-value was not significant, meaning that there is no difference. And so, do females express more worry over the economic consequences of the pandemic than males? So we asked some very interesting questions, one of which is, have you become worried about your ability to financially support yourself and or your loved ones? And initially at glance, it looks as though the females believed or felt more attached to this statement. However, our p-value is insignificant. And so, so after adjusting for this, we were able to see that that was not the case. Versus, I believe my chances of experiencing a decline in my income that could severely affect my health or ability to provide for the basic needs for me or my family this year is closest to. And then we rated them upon a percentage. And again, our p-value was above 0.05, so it was insignificant, although there is a trend. Some fringe benefits I gained from this program are I learned how to use the statistical package for social sciences, and I had to adapt to specific data available because my hypothesis initially, I wanted to look into different subsets of anxiety, social anxiety versus generalized anxiety disorder, and I didn't have the opportunity to do this because of certain limitations in our data, and so that was something I learned to adapt to based on the information I had available. Another benefit was I gained insight on how the pandemic has affected individuals in unique ways because we have such a large sample and so many different questions that we had administered in our survey. There are a lot of very unique and interesting trends and associations that I was able to look at over the course of this program. I also increased my critical thinking via questions, so learning more about how to ask questions and how to think critically about these questions was something very valuable I gained from this program and from working with my mentor. And then I worked alongside an awesome mentor and got to build connections through him. And so that's been such a wonderful experience. Some questions that remain are, how might additional economic predictors such as zip codes influence sex differences during the pandemic? This I thought was particularly interesting because I would like to model something that I saw, a study that I saw an individual run in the influenza pandemic. How might the data vary if biological sex was replaced with gender? To what extent have gender roles in America influenced job loss among women during the COVID-19 pandemic? And how does being high risk influence an individual's psychological state? For example, do they feel more anger or frustration towards society, or are they more feeling emotions alongside of worry and anxiety or depression? Future plans are continue to expand my knowledge of statistical analysis. I plan on continuing this research through the research distinction track so that I can further analyze these complex trends and correlations. I want to expand information available about the psychological impacts of the pandemic and expand my knowledge on the economic consequences of the pandemic at hand. And then develop programs to support and assist individuals affected by the pandemic is a very long-term goal that my lab I'm working with has. And acknowledgements are, I want to thank Dr. Kilgore for all of his guidance. He's very brilliant and he's very kind, and so I feel very thankful to have been able to work with him. I also want to thank Dr. Witt for helping me to find a mentor and for providing this experience for me that has helped me to grow. I also want to thank Grace and Grace Ann, as well as Mike Miller, who's our lab manager.
Thank you very much, Cassandra. I'm glad you found the perfect mentor. That was a tough matching process that we went through. I suspect most of you are going to go on to research distinction track. And when we founded the research distinction track, which was the first distinction track, we named that, and that was a project that medical students took on to recognize students who continued. It started in 2000. We started with just a couple of students, and now I think we have 60 or 70 students who are in the track. And if all of you come in, that's going to be 80 or 90 students that are in the track. So I urge you to get your applications in so you can count everything after Friday. Any time you spend on the project can count toward your research distinction track. Okay, we're going to move on. Again, we're a little behind. We're going to go next to Jillian Cardoli, who's the class of 23, and she's going to talk about the impact of HIV-specific antibody affinity on the reservoir. And she worked with Dr. Elizabeth Connick, who's professor of medicine here.
Okay. It's okay. All right, so hi everybody. As Dr. Whitty said, I'll be talking about my summer research on the HIV-specific antibody affinity and the persistence of the follicular dendritic cell reservoir. My mentor is Dr. Elizabeth Connick, and she's the chief of the Department of Infectious Disease, and I also had a lot of help and guidance from Dr. Ollerton and Joy, who are also in the lab. So to start, I'm going to give a little background on HIV. So HIV is an enveloped virus, so it has a lipid membrane, and it also has a nucleocapsid, which holds its DNA. And on the membrane, it has these spike proteins. They're HIV glycoproteins, and they exist as a trimer on the outside of the virus, and that's how it binds and infects cells. And I think we hear a lot about HIV in the blood, but actually the majority of HIV replication occurs in secondary lymphoid organs. So that's like the spleen, gut-associated lymphoid tissue, lymph nodes. And antiviral retrotherapy, abbreviated as ART here, decreases replication in these tissues, but HIV RNA positive cells are still detected in those secondary lymphoid organs, and specifically B cell follicles where HIV replication is most concentrated. And in addition to this, virus replication rebounds once antiretroviral therapy is stopped. So one of the big questions in the field right now is this due to new infection of cells or reactivation of latently infected cells? And one reservoir that's involved in this are follicular dendritic cells, which are mesenchymal-derived cells that form networks in lymphoid follicles. And one of their functions is to capture and retain immune complexes. And these immune complexes are captured on those cells for many months. And actually, the majority of HIV in those follicles exists on follicular dendritic cells. And it has been shown that that HIV is infectious for up to 9 months. And that 9-month mark is just the amount of time that the study studied it. So it could be longer than 9 months. And so one of the questions is, how important is the FDC reservoir in HIV persistence and rebound viremia? And in order to address that, we would like to know what factors promote the retention of infectious HIV. So with those questions, the hypothesis of my summer work was the greater the antibody affinity for HIV envelope, the greater the magnitude of persistence and infectivity of virus on FDC. And this figure on the right we're looking at shows a follicular dendritic cell capturing this red antigen, and both antibodies and complement are involved. So my project right now is just looking at antibodies. And this is showing an antigen, but follicular dendritic cells hold intact HIV. And so in order to investigate this hypothesis, we need to know the affinity of several HIV antibodies. And so most of my summer was actually performing those measurements using a technique called biolayer interferometry, which measures interference patterns between waves of light using these sensors that this diagram is showing. So how this works is that you can immobilize molecules on this sensor tip. So one of the molecules involved in an interaction, in my case, an antibody. And the technique works by shining light down this sensor, and the light reflects off of this molecular layer as well as an internal reference layer. And those two beams of light interfere and create an interference pattern. And then that interference pattern changes as molecules bind the surface, because binding of the surface increases the effective distance between these. And so that change in interference pattern is reported as a change in wavelength, and that's where the measurements for kinetic data come from. And this is what that data looks like. So in this technique, this is showing the steps that these sensors are passed through. So in this sensor, this is just the sensor tip with nothing. This is what molecules are going to bind to. So first step is a baseline, it's dipped in a buffer, you see no change in signal. And then the loading step is when you dip the sensors in one of the molecules of interest. It's called the ligand. And there's an increase in signal because this distance has increased. And then another baseline to stabilize the signal, just again in buffer, no change. And then association of the second molecule of interest. So we see an increase in signal. And this is performed with several different concentrations of analyte to give reliable data at different concentrations. These, of course, affinity constants should be the same for different concentrations. And then dissociation in buffer again, where these molecules can dissociate. And I just want to point out that in this setup, they are looking at a one-to-one interaction. So this blue molecule binds this red molecule in a one-to-one interaction. And that's the type of fit that would be chosen for this data, but the software can also analyze 1-to-2 interactions and 2-to-1 interactions. So now moving on to what I actually did this summer, I started wanting to use antibodies, the antibodies that I wanted to measure, and intact HIV. So that's what we're seeing over here. I attached the antibodies to the sensor and then dipped them in HIV. And so what we're seeing is analyzed data. This is just the association and dissociation steps. And the colored lines are my actual data, and the red lines are the theoretical curves, the data fitted. So I was using a 1-to-2 interaction model, or actually a 2-to-1 interaction model. And you can see that the red lines don't fit very well with this data. And these are HIV at different concentrations. So 5 times concentrated from our standard HIV solution down to 2.5. And then there's 2 more lines here that are 1.25 times concentrated and 0.625 times concentrated. And so what this told me was that this system wasn't going to provide well-fitted data. But what it also showed me is that HIV was not dissociating from the antibody. We should be seeing some decrease in signal if it was, and it wasn't, which makes sense because there are so many spike proteins on this HIV that these antibodies are binding to. So the HIV is essentially sticking to those antibodies very tightly. So from there, that told us that we could actually create a new sensor with this, where the HIV loaded onto these antibodies, tightly bound, could be our new sensor. And then I could use the antibody of interest as the analyte. So I'd be dipping this into a solution of antibody to measure the affinity. And so I tried this, and I did this in replicates to see if it could give us reliable data. So this is all HIV 5 times concentrated. And you can see that the data just doesn't fit very well at all. And I ended up speaking to a representative of the instrument, and he thought that the system was too complex because we were using culture media to support this virus. So moving on from here, this antibody is binding to spike proteins on the HIV. So we moved on to using, instead of intact HIV, purified spike protein, the glycoprotein complex. So it's the same idea where the antibody is being used to bind the spike protein, which exists as a trimer, which is why we wouldn't want to just use that as the analyte, because software would not analyze a 1-to-3 or a 2-to-3 interaction. So the ligand is the glycoprotein trimer, and the antibody is again the analyte. And so here is the data, different concentrations of that antibody, and we can see that it fits very well. Those red theoretical curves fit the black experimental curves. And besides visually, we can also tell this using statistics. So the chi-squared is close to 0, the r-squared is close to 1, and that tells us we have a good fit. And the KD, the affinity constant, is 5.56 nanomolar. So I just measured this with one of our antibodies, but we have a panel of 9 antibodies to measure the affinities and compare them for future experiments. So that brings me to future direction. So I want to characterize all antibodies in our 9 antibody panel. And I want to correlate the antibody affinity to concentrations of follicular dendritic cell bound HIV over time using P24 antigen staining and in situ hybridization for HIV RNA. And I also want to correlate the affinity to the proportion of infected CD4 T cells in ex vivo infection experiments. And so most of my summer was spent measuring the antibody affinity, just optimizing the BLI experiments. And this is what I would like to do with it moving forward. So thank you for listening to me, and thank you, Dr. Connick, Dr. Ollerton, Joy, Dr. Whitty, and Grace. And does anyone have any questions?
Any questions of Jillian? Is Dr. Connick here? If not, yes, good.
I'm here.
Yes, Elizabeth, you want to make a comment?
Oh, Jillian did a great job. She troubleshot the whole assay, because this isn't an assay that we do normally in our lab. And, you know, as you can see, went through multiple iterations of the experimental design, because the first and the second ones didn't really work, but with a lot of perseverance, she got a system to work, and we're thrilled that now we can move on with the rest of the experiments. And she's going to be in the lab on the distinction track, and we're thrilled about that as well.
Great. And I want to compliment both of you for focusing on the follicular dendritic cell. There's been a lot of relatively unpopular and very popular themes in AIDS research, and I've been interested in them actually since before the epidemic began. And in 1987, we put on a conference in Vienna on AIDS in the lymphatic system, and there were 3 leading investigators who spoke on the importance of follicular dendritic cells. And yet the focus has not been on that for many, many years. And you've gone back to this and with the modern techniques, looking at the follicular dendritic cell as an extremely important cell in AIDS immunology. And maybe it'll hold the key to finding better treatments than we have now and flushing out those reservoirs in the lymphatic system. So I compliment both of you on emphasizing that particular cell. Everybody is focused on the helper cell and maybe the killer cells, but the follicular dendritic cells may really hold the key here. Okay, we're going to move on to the next presentation. We're getting close to lunch, and we have James Walling Patterson, class of 23, on the utility of point-of-care ultrasound diagnosis of perirectal abscess. I mean, I think you should all recognize and marvel at the tremendous variety of presentations and of students and their interest. As a faculty member, when you look out during a lecture at a class, I mean, you see people who look different physically, and then with the logs, I've seen how different you are mentally. But to look at your different choices of projects, your different methods that you use, the different things you want to pursue, there's just such infinite variety. And somehow there's an awful lot of cookie cutter in medical education, and it's nice to see this variety blossoming here in these presentations. Everything from a perirectal abscess to a screw in the neck, to a follicular dendritic cell, to an attitude, anxiety, and so on. It's really wonderful to see that variety. I wish there was more possibility of more of it. Let's then proceed. James, I didn't want to co-opt your presentation, but I did want to make that comment.
All right, thank you, Dr. Whitty. Let me share my screen here. All right, let's see.
And his mentor is Dr. Adhikari in emergency medicine.
Is that showing up right?
Yes. Mm-hmm.
Okay. So yeah, like you were saying, Dr. Whitty, it's an interesting project, obviously. You know, I think probably a lot of people would be like, why are you studying this of all the things out there to study? That would be a good question. But the reality is this perirectal abscess is like a very, very debilitating condition, especially in the elderly, especially in the obese. And the prompt diagnosis and treatment of perirectal abscess is extremely, extremely important. And it can really alleviate a lot of pain and suffering. So that's basically the background behind this project. The purpose of this study, yeah, like we said, was to determine whether or not the point of care ultrasound in the emergency department is useful for evaluating and diagnosing and ultimately treating perirectal and perianal abscess. So the little background here, kind of like I was saying before, patients often present to the emergency department with these anorectal symptoms, which can include, you know, fever, pain. They can actually have abscess and they can have drainage. And as I was saying before, the prompt diagnosis is very important for preventing complications like fistula and sepsis. And so what can actually happen in the case of fistulization is that the rectal cavity can basically essentially be bypassed by an abscess and by eventually kind of like a secondary tract that can essentially drain outside. And that's a very, very bad complication, and it can have a lot of really bad effects. And so point of care ultrasound is increasingly useful in emergency departments. Anyone who's ever worked in one knows obviously about like the fast exam and that kind of thing. But I think it's very cool that that you can do something right there at the patient's bedside. You know, maybe find the diagnosis for what's actually going on and be able to at least rule things out. And so that's the point of this study, is to basically see whether or not you can really do that and whether or not people have effectively done that over the past 5 years in emergency departments. And so these are the beginning questions to use the structure that we were given, which is have the utility of ultrasounds been studied in this context before? And if so, what were the results? To what degree is ultrasound currently used in emergency departments? How often is it used, for what purposes, especially as it pertains to perirectal abscess? And then what is the disposition of those patients? How does it change their care? Does it improve their care? Is it a more efficient form of care in terms of time costs and you know, other factors compared to other imaging methods? What percentage of people who get an ultrasound end up with one of those imaging modalities anyways? You know, so there's a lot of questions to ask here, but those are probably the three that we'll focus on. So in terms of progress in answering those questions, so the first question dealt with, you know, has this been studied before? And it turns out not really. There are quite a few studies that talk about cutaneous abscesses. There are quite a few studies that talk about MRI and CT, but very few that talk about ultrasound as it pertains to perirectal abscess. There is only one real study that compares any of the modalities, or that especially involving ultrasound, and that's from about 30 years ago. And actually, if you read through it, it's pretty poor data and a pretty poor study. Then there's some specific studies that have to do with Crohn's, and you know, the fistulization that occurs with Crohn's and whether or not ultrasound can detect that compared to other modalities. But not really any in the terms of just somebody presents to the ER with this pain, with these symptoms, with this fever. Does this, you know, does ultrasound work? And so, yeah, so what we found pretty early on is that it was a good topic for continued research, and so that's what the research was on. And so what I did was probably very similar to what a lot of people have done, which is pretty much just a retrospective chart review. In our case, the setting that we were in was we evaluated patients at Banner, UMC, and South Campus pretty much for the last 8 years. And we included pretty much anyone who presented with symptoms that were suspicious for perirectal abscess that had an ultrasound performed at the bedside in the emergency department. 27 patients ultimately is what we were able to find that met those criteria. Hopefully more to come, but at least in terms of this batch, it would be about 27, and collecting about 180 variables on each patient. And so that was what I spent my summer doing. And so talking about then the results of the study, at least the preliminary results, because we haven't really hit the number that we need yet at 27. So the ultrasound itself was able to diagnose an abscess in 16 of the 27 patients. It was able to essentially rule out abscess in terms of calling it cellulitis instead of abscess in 8 out of 27 patients. It was able to identify perianal abscess in 2 out of 27, which is the same as abscess, just more specific. And then it was able to identify necrotizing fasciitis, which is another extremely important thing to be able to pick up on early in 2 out of 27 patients. I thought very noteworthy in terms of the actual medical documentation in the chart reviews. It was used for medical decision making in 25 out of the 27 patients, and it changed the patient management in 25 out of the 27 patients. So, you know, I mean, I thought that was a fairly noteworthy finding. In terms of how it changed patient management, 10 of the 27 went on to receive confirmatory radiological imaging, which confirmed those diagnoses. 9 received early consultation to surgery. 8 were able to receive early antibiotics. 7 avoided the unnecessary procedure in the case that they actually had their abscess ruled out, so they didn't have to do an IND in the emergency department for an abscess that wasn't there, which is maybe just as important. And those 7 obviously had a reduced length of stay in the hospital for that reason. In terms of the hospital course, 13 were discharged pretty much immediately. 13 were admitted to the hospital, and then 1 left against medical advice. This is the hospital course of these patients, not quite as in depth, but we talked about fistulization, where 3 had developed fistula or were able to be diagnosed with fistula over the course of their stay. Some, 3 developed sepsis, 1 developed septic shock, and then these are the final discharge diagnoses, or at least the most prominent ones: gluteal abscess, perianal abscess, and anal fistula. The fringe benefits that I think came along with this was being able to learn how to use all these softwares. RedCap is where we did all the data entry, which is a database software, as I'm sure pretty much everybody knows, and it has some data analysis capabilities, not extensive, but at least the basics. And then I was also able to use Cerner, and then Epic is basically Cerner before Cerner, which Banner used, or I guess U of A used back before the transition over. And so, yeah, I thought all those were useful skill sets to develop. The remaining questions that we have primarily actually has to just do with whether or not the results are typical. And so we only have 27 patients currently in the data set, and so pretty much need to add about 23 more to get to 50. My plan is to continue doing that over the next months and however long that takes, and eventually do a write-up on all this and hopefully have some kind of manuscript to show for it. And so I think that concludes it. Does anyone have any questions?
Okay, any questions of James? Okay, if not, we're going to move on to the last presentation before lunch, an abbreviated lunch, and that's by Taylor Paul Cox. He's class of 23, and his topic was lymphatic dysplasia and lymphatic imaging in Noonan syndrome, and he worked with me on that.
All right, let me just
with Marlise Whitty, professor of surgery.
Yep. Thank you, Dr. Whitty. Yep. So as she said, my name is Taylor Cox. I'm a second-year medical student, and the title of my project is Imaging of Lymphatic Dysplasia in Noonan Syndrome. My mentor needs no introduction. She is the one and only Dr. Whitty, as you all know. I also owe a lot of where I'm at today to my undergraduate mentor, Dr. Kim O'Neill from Brigham Young University. I did cancer immunotherapy research back then, and joining Dr. Whitty's lab and doing lymphatic system research was a really neat way to go from looking at the micro level to the macro level. So that's kind of my perspective on that. Just to talk a little bit about the lymphatic system background. Lymph is the fluid that leaks from your blood as it exchanges gas in the capillaries. And normally that fluid is channeled back into the blood through this system that's the lymphatic system through passive transport, or just, squeezed along as your body moves naturally through one-way valves up until it joins the venous system, so the blood that is returning to the heart. And as you can see in this diagram, I have a figure which shows which areas of the body are drained by which sections of the lymphatics. So the majority of the lymphatics are drained up through this structure here in the middle, called the cisterna chyli and the thoracic duct. And then there's also these right upper quadrant lymphatics that drain into the right lymphatic duct. Noonan syndrome is a genetic disorder that we were looking at this summer. It's a very interesting disease in that it has a lot of different presentations and a lot of variability in how severe that those symptoms are. So the prevalence of this disease is between 1 in 1,000 and 1 in 2,500 live births. It's a dominant autosomal inheritance pattern, and it has no karyotype changes. And the reason I mention that is because that's what distinguishes it from something like Turner syndrome, which has karyotype changes. Then also another note on here that I didn't remember to put down is that this can be passed along genetically, or it can just be a spontaneous occurrence. So in other words, your genes can simply mutate and you can be born with this regardless of whether or not your parents had it. Now, there are several symptoms that you can get starting at the beginning and throughout life. Heart disease is the most common one that they present with as infants. They'll usually have some sort of valvular disorder or a septal defect, and they'll need to have that repaired surgically. Then there's also musculoskeletal abnormalities. They'll have a pretty characteristic barrel-chested appearance. They'll have spinal deformities. A lot of them will have issues with growth, so they'll have short stature. And then they also have a very characteristic facial structure as well. So they'll have a triangular head, a webbed neck, and facial features that when you see that, you think Noonan syndrome. Also, Noonan patients can have intellectual disability. That's a very variable symptom. It's not as common, and it can also vary in whether it's like a mental disorder or an emotional or behavioral issue. They're usually mild, but they can vary and become pretty severe as well. Then you also get genital and kidney conditions, bleeding disorders, hearing and vision problems, just a whole slew of things that come along with this. And then you've got lymphatic malformations as well. And what we wanted to address when it comes to the lymphatics and Noonan syndrome is essentially kind of how I have it presented here is how most people will look at Noonan syndrome. They'll say lymphatic malformations are one of the things that you see in Noonan syndrome. It's something that just kind of comes with it. But what we want to say is that lymphatic malformations, we want to demonstrate that the lymphatic malformations are actually the cause of a lot of these other problems that these patients have. So our beginning questions are, should lymphatic malformation be considered the principal hallmark of this genetic disease? And then what are the common findings of central lymphatic imaging studies? A lot of what we're looking at here in this study is lymphatic imaging specifically. People going in and saying and showing what exactly is going on with the lymphatic system, whether there's overgrowth or whether parts are missing. And then how does this lymphatic dysfunction correlate to specific clinical phenotypes? So in other words, how does a lymphatic malformation connect to what we see in the clinic? So going on to our research, we started out with literature review, and then we also did some case reports as well. And I'm sorry, Siri apparently thinks that I was talking to it. All right, so the first paper that we looked at in our literature review, so I'm just demonstrating 4 papers in here. There were obviously a few more, but these are the ones that I think tie in the best to this presentation, the purpose of this presentation. This one was published in 1975. It looked at 2 Noonan syndrome patients with pulmonary issues. And essentially what you can see along here, they used something called an X-ray lymphangiography, which is essentially just your typical X-ray, but beforehand they've given you an injection of this dye into your lymphatics, and as it's moving along and as it's distributed throughout the lymphatics, it'll show up as white on the X-ray. And what you can see here is this thoracic duct, but you see this big gap here. You see a missing segment of the thoracic duct, and that's what we would call a central lymphatic abnormality. And then they also noted collaterals between the retroperitoneum and the pulmonary lymphatics. What a collateral means is that if you block this completely, that lymph is going to try and go somewhere because that pressure is going to build up. So a collateral is essentially a new sprout of a new lymphatic vessel that the body is trying to use to compensate for that lack of this thoracic duct. But the problem with those new structures is that they're not very strong. They're prone to leakage and breakage, and you can get all sorts of problems like this patient has. Then the next paper we looked at was lymphatic vessel dysplasia in Noonan syndrome. This was published in 1980. This looked at Noonan patients that had more of the genital swelling and inguinal symptoms. And what they found when they did also an X-ray lymphangiography, they just saw what they called dysplasia of the lymphatic vessels. That's just a lot of overgrowth of relatively non-functional lymphatic vessels. The stuff is moving along, but it's moving very slowly because it's just all caught up in this labyrinth of extra lymphatic vessels. Then another one that we were able to review is a case of a patient that was evaluated in Italy by Carlos Bellini. And he looked at this patient, confirmed that they had a mutation in a gene called KRAS. And there are a lot of different mutations associated with Noonan syndrome, but they all have to do with this RAS signaling pathway, this cell signaling mechanism. When they did something called a lymph scintigram on this patient, a lymph scintigram, when you look at it, it doesn't make a lot of sense at first until you kind of understand what it is you're looking at with all the little dots. So essentially what you do is you inject a radioactive tracer into the hands or feet of a patient, and you essentially just track its movement along the lymphatic system. And what you see here, or rather what you don't see here, are very clear lymphatic structures and movement along those vessels. What that's telling you is that when you inject the dye, it's just staying in the hands and feet. It's not moving very well along these lymphatics. I'll show you an example later in a few slides of a patient that actually has a lymph scintigram that you can see the lymphatic channels as they're more or less supposed to be. Then there's a more recent publication in 2019. I forgot to mention this one was in 2015, and this one is a bigger study that they did in 2019, where they looked at, they specifically looked at central lymphatics, so the cisterna-chyli up to thoracic duct, and they looked for abnormalities in patients with Noonan syndrome, and they had 10 patients in total. And that doesn't sound like a lot, but the other cases only had 1 or 2 patients each. It's difficult to find lymphatic imaging for Noonan patients because lymphatic imaging has only recently become a priority for these patients. So when we look at the magnetic resonance imaging of some of these patients, you see a very wide variety of central lymphatic abnormalities. You see dilation of the thoracic duct means that there's probably some sort of obstruction or blockage at the junction between it and the vein, which is causing this to become overloaded with lymph. And then you also get leakage into the lungs. In this one, you can see even more leakage into the lungs. Then you can also see over here, we've got another clear image. This is a lymph angiography as well, looking at the thoracic duct, and it looks like part of it's missing there. And then I want to say that they said that this was blocked and that up here, this arrow is kind of pointing at some collaterals of the lymphatic system. So that's how big those collaterals can be when you block the main route that the lymph takes to try and get back into the blood system, the circulatory system. Let's see. Okay, so now we're moving on to the cases that we actually looked at, and these were patients that were seen at the University of Arizona by Dr. Whitty. This patient was a 35-year-old male who presented with scrotal edema at age 15. Initially, they were leaking, his scrotum had blisters and were leaking a cloudy pink fluid, which tells you something I forgot to mention about the lymphatic system. It's also important for immune function and the absorption of fats from the digestive system. And when you have a cloudy leakage of fluid from an area that is refluxed into by the lymphatics, what that tells you is that you're backing up all the way from up here because those fats are going to make that lymph cloudy. And so that's the origin of that. So A here in this left column is showing a lymphscintigram of this patient before he was operated on at age 23. He presented at age 15, but he was looking for a diagnosis for quite a few years and looking for solutions. And eventually he was seen by a surgeon at the Mayo Clinic who performed a lymphatic venous shunt. So essentially he went in here in the abdomen and he connected this lymphatic system to the vein, the inferior vena cava or some other vein that's down here in the abdomen. And what that did was essentially bypassed any abnormalities or blockages that are up here in the thoracic duct and gave the lymph somewhere to go. So even though he's started to have regression of that scrotal edema and blistering, what we see now with B and C is this patient's current condition is still much better than it was back when he was 23. Now you still see, when you delay the imaging, you still see some reflux of the radiotracer, which is in the lymph, into the abdominal cavity, and you see some persistence of that scrotal edema, but it does go away over time. But then another thing you see, something we're wanting to investigate further, are these little black nodes that you see along this leg. Those were initially marked in the patient's notes as lymph nodes, but we actually know that there aren't lymph nodes along this portion of the leg. So what we think is that those are lymphatic valvular malformations. So the valve itself has malformed and is allowing lymph to pool up in that area and dilate it. And what we think is that after this lymphatic venous shunt was performed, that took the pressure off and was able to eliminate some of those accumulations down here. Okay. So then this is also from that same patient, and this is an MRI image, and this just shows the same thing. We show a dilated thoracic duct indicating that there's a blockage further upstream that's keeping the lymph from being able to drain properly into the venous system. Although they did not find any collaterals for him, so we believe that it's still able to drain. It's just not draining very effectively. Then our second case is a much more severe case. This is an 11-year-old female who over the years has had several, I could have an entire presentation just on this poor girl's presentation over the years. But essentially, at the current time, she's been having respiratory illness, declining cardiac function. She's had enlargement of the liver and spleen, which we call hepatosplenomegaly. She's also come down with anemia, and I think we believe that comes from the spleen dysfunction or swelling of the spleen, and then malnutrition as well. And that has to do with the lymphatic system role in absorbing fats. So this girl was tested to have an SOS1 mutation, and that's another one of those genes that are involved in that RAS signaling, as I mentioned before. She's had a lot of imaging done, and I'll show you the highlights of that. Here's her lymphscintigram, kind of similar to the other ones before. As you can see, her leg lymphatics look good. What we see though is up here, you should not be seeing the spleen on a lymphscintigram. You should not be having reflex of lymph into the spleen so that we can see that. So that's a pretty abnormal finding. We can also see some effusion into the lung, and that's what she presents with a lot is respiratory illness. Then we also see up here, we can kind of see hints of that dysplasia that I'll show you in other imaging, which is the formation of too many lymphatic channels. And then you also just see that even after a 26-hour delay, that reflux is still present in this patient. Here we have a SPECT CT imaging just showing basically the same thing, that we're seeing lymphatic reflux into organs such as the spleen. We're seeing it enlarging the lymphatics down here in the abdomen. And we also see accumulation up here in the upper mediastinum. And that's where we'll see in this image that we can see a lot of lymphatic dysplasia. And it's actually to such a degree that it is impinging on the trachea. And when you overlay that with the SPECT CT image, you can see that the fluid is accumulating in those areas and preventing lymphatic drainage into the venous system properly. And all of these imaging studies that I just showed you were done at age 11. Now this is the last case that we had. This actually didn't come with a clinical correlate. It's just an image of a confirmed patient with Noonan syndrome. This came in from a colleague of Dr. Witty's in Argentina, Dr. Papendiek. And he noted that this patient, who is an infant with Noonan syndrome, had a lot of lymphatic malformations in the trunk. So the applications and conclusions, I know that went on a little while. There was a lot of cool stuff we looked at, but essentially what we're coming to is that the imaging results that we've seen consistently indicate the presence of diffuse lymphatic abnormalities. Basically, we're seeing that Noonan syndrome patients almost universally have some lymphatic abnormality of some kind that we can see on imaging. And we can see that through decreased lymphatic flow. We can see that through overgrowth of lymphatic vessels. We can see that through absent sections of the central lymphatics. These were all very common findings. Then 2, lymphatic dysfunction is key to syndromic pathogenesis. Basically, our findings draw a connection between the imaging and the clinical phenotype. We see a direct comparison between the results of the imaging, which show dysfunction or malformation in one area of the lymphatics, and then their clinical correlate as a Noonan syndrome patient corresponds with it. For example, for the first patient that I showed you, patient 1, he mostly was presenting with genital swelling, and we saw a lot of the lymphatic dysplasia in the abdomen, which would reflux down into that area. The third thing we want to conclude is that lymphatic imaging should be used as a screening for early intervention. This is something that needs more research, but we predict that having an early lymphatic imaging study for Noonan syndrome patients as early as is safe and possible may improve patient outcomes by increasing the awareness of the fact that their lymphatic abnormalities may be the cause of a lot of these issues that they have later down the line. And we know through several of these patients that when they have an operation such as a lymphatic venous shunt to bypass lymphatic abnormality, then they tend to do a lot better. So some of our new and unanswered questions are: what interventions are most effective in preventing some of the life-threatening complications that stem from central lymphatic dysplasia? We want to know, are valve malformations present in the peripheral and central lymphatics? I noted the possibility that there are valvular malformations in that first patient. You could see what looks like nodes in his legs, but that's something we would need to investigate. Then what are the embryological connections that exist between congenital heart disease and central lymphatic malformations? And then lastly, what animal models would be best suited for studying Noonan syndrome in the lab? And the way we plan to address those things is, first, I'll address the mouse model. We plan on doing pregnancy studies in SOS1 mutant mice to characterize a homozygous phenotype in utero. There haven't actually been any homozygous mice that have been born alive, so we want to perform some pregnancy studies to figure out why that is. We want to investigate the embryological development of the thoracic duct in connection with the right heart. And then we also want to compile all this information, compile all known Noonan syndrome imaging studies and their available clinical correlates if possible. And we want to publish these findings as a comprehensive study, almost like an atlas of Noonan syndrome that can be used as a resource by other people who want to research this disease. And with that, I'll take any questions.
Well, thank you, Taylor. Since I hadn't seen this presentation before, we only discussed it, you really made this doctor proud in covering this very complicated syndrome. One additional feature is we actually think the face, there's something that in lymphology we call lymphedema face, and in the different anomalies with lymphatic abnormalities, we often see a particular facial appearance, and that is hypertelorism, that is widespread eyes, a flattening of the nose, and this is also a feature of Noonan. The web neck is thought to be an involuted cystic hygroma, which is the beginning of the lymphatic system embryologically. So we think a lot of what's happening in the head and neck also is related to a lymphatic obstructive process occurring in utero. And we think one of the problems is that the system doesn't connect up from the head either, from the cervical lymphatics. So Taylor's done a remarkable job putting this together, sending out emails in Spanish to my colleagues in Buenos Aires who greatly appreciate it. They always want me to give my talks in Spanish, and I just haven't felt that I could do that. But Taylor is fluent, and he was able to communicate also with our Italian colleagues to try to put together all of the lymphatic imaging that's available to encourage much more lymphatic imaging, since it can be done non-invasively, very simply. Catch these problems early before these children develop chylothorax, respiratory disease, protein-losing enteropathy. All of these are lymphatic complications that are seen in Noonan syndrome. So I congratulate you, Taylor, on so pleasantly surprising me with such a comprehensive presentation.
Thank you. I could maybe see you starting to sweat a little bit before I presented.
I think you did quite a bit of it in the last 24 hours, and it's remarkable how you put this together. Very far-flung information, very complicated patients.
Thank you.
Are there any comments, any questions about any of the presentations, or any questions of Taylor? Chris, is Chris there? Chris Vance?
I invited him. I don't know if he joined in.
I'm here. Yeah, Chris, did you want to comment? Because you've come in on this project also, since it's a kind of a monumental one, going from really looking at the epidemiology of the disease, the genetics of the disease, the imaging of the disease, the embryology, and kind of putting this all together internationally. What are your thoughts?
Yeah, first of all, I thought it was a great presentation. I thought you did a really good job of laying out kind of what we looked at, all the cases that we discussed. I think going forward, it's going to be really interesting to see like the common mutations in Noonan syndrome and kind of how they relate to lymphogenesis. So I think that's going to be a really cool avenue that we can take and make some connections there.
Yeah, and Chris is a fourth-year medical student, and he's taken a year off to do research, and he's got his hands in quite a few projects with different mentors, basic science and clinical. So we're happy to have him on board. Okay, this concludes the morning session, and we're actually on time. I think there was an error here, thinking we'd have a half an hour if we got done on time, and we're actually half an hour over. So it looks like we start the afternoon session at 12:30. Let's start that promptly at 12:30. And I congratulate all the presenters up until now. They really are remarkable presentations, very thorough, ready for prime time, ready for research distinction track. And I hope the high school students and undergraduates and the other medical students learned a lot about a lot of different specialties and methods from your fellow students. And also, I like very much the collaboration among students at different levels, which is important. And we plan on alerting NIH to what we've done, since many of the R25 and T35 grants that cover summer research haven't gone forward at most institutions. They've either been furloughed, delayed, or whatever. And here we've gone forward with all of the programs and all of the mitigations and all of the waivers and all of the hotspots and protests and wildfires and hurricanes and tornadoes and whatever. And we pulled it off. So I congratulate all of you, because it's a great effort.
All right, hi, I hope everyone had a good lunch. My name is Jared Blackwell. I'm in the class of 2023, second year medical student now. My project was on bile acids and necrotizing enterocolitis. So our initial questions were, are bacteria that dehydroxylate bile acids necessary in the development of necrotizing enterocolitis in premature rodents? And are bacteria which are capable of deconjugating bile acids necessary in the development of necrotizing enterocolitis in premature rodents? So in all newborns, the intestinal epithelial barrier, it's more permeable compared to the mature intestinal tract. And that's due to the development of adherent and tight junctions that you begin to proliferate as you grow older. So the tight junctions, which support the integrity of this barrier, they're altered in NEC. And moreover, it's been shown that prolonged exposure to lipophilic bile acids further disrupt this barrier. So what is necrotizing enterocolitis? It's a medical emergency that affects premature newborns, and it's actually the most prevalent gastrointestinal medical emergency. It's characterized as a hemorrhagic inflammatory necrosis of the distal ileum and the colon. And in the United States, nearly 9,000 infants develop NEC annually, with an associated mortality rate of 20 to 40%. And this is highly dependent on their birth weight, with lower birth rates increasing this mortality risk. So the clinical presentation of NEC, it varies from abdominal distension to feeding intolerance, bowel perforation, intestinal gangrene, and is linked to numerous congenital heart defects. The top arrow that we see here, that's pointing to hepatic portal venous gas that accumulates. And the second arrow below, it's demonstrating pneumatosis intestinalis, which is, it's the radiological hallmark of NEC. So the current issues with NEC are that the major risk factors leading to the development are well described. However, studies which investigated the intestinal microbial environment, they've been unsuccessful in determining the primary microorganisms responsible for the disease, in addition to the exact mechanism of the pathophysiology. In addition, the approach of the majority of treatment interventions, they're mainly supportive, and there aren't really any predictive tests available. The buildup of bile acids in enterocytes, it results in cytotoxicity. And in 2006, Dr. Halpern, my PI, she was the first to demonstrate that the accumulation of ileal bile acids is actually crucial to experimental NEC pathophysiology. Preliminary data suggests that infants who develop NEC have variations in daily fecal bile acids. And in this study, we used the bacteria Clostridium scindens, and that was chosen because of its ability to convert primary bile acids into their more cytotoxic secondary form, the hydrophobic form. And furthermore, Clostridium scindens has been demonstrated to induce NEC-like lesions in quail, and they're generally non-pathogenic. the bacterial genus Clostridium has also been proven to be elevated in fecal samples obtained from infants suffering from NEC. So the methods, we utilized an established experimental protocol to develop NEC in premature rat pups. A cesarean section was performed on pregnant rat mothers. Each litter size was an average on 13. And the premature pups were removed and they were cleaned. The rats were then weighed and they were divided into various groups. So the first 2 litters of rat pups are divided into the 3 groups you see here. And that's the NEC group, the NEC group plus Clostridium scindens. And then we had a group with cholestyramine, which was added to their formula as well. The stress that you see here, that involved, continue here. So yeah, hen-fed formula stress was a hypoxic state plus a cold environment. We hand-fed the rats every 4 hours from 6 a.m. to 10 p.m. And the preterm rats in the NEC group were subjugated to this stress, which entailed a hypoxic state through the exposure of nitrogen gas for 30 seconds, followed by cold temperature for 5 minutes in 4 degrees Celsius. On the 5th day, the pups were sacrificed and the distal ileum was resected to later examine the bile acid contents. And an additional portion of the ileum was removed for immunohistochemical staining and for a histological score. And this you can see the pups in the incubator labeled. So we basically just take them out every 4 hours, clean them off, feed them, and then place them back. So the expected results, throughout the 8 weeks of this research, we are unfortunately unable to answer our 2 original questions. This is partly due to, the COVID-19 pandemic, which placed restraints on our ability to conduct the experiments we really wanted to and to also get the materials we needed. We were successful in feeding the rat pups and performing the subsequent ileal resections, and the tissue samples have been labeled and stored for future analysis. So in the NEC plus cholestyramine rat pup group, we anticipate that there would be a decrease in the severity of NEC, and that is due to the fact cholestyramine prevents the absorption of bile acids. We also expect that the rat pups who received every NEC treatment and the ones that, especially with the bacteria, will have a greater development of NEC. So the questions that remain are, what is the role that gut microbiota play in the development of NEC in premature rodents? And how do bile acids impact this? And in order to answer these questions that we originally proposed, we're going to need to further analyze the resected ileum samples. And we're going to conduct BCAA assays and Western blots on the tissues to determine the protein concentrations within the epithelial barriers. And the bile acid composition, the statistical analysis of that will be done using ANOVA. And the intestinal epithelial barrier proteins will also be identified using chromatography with tandem mass spectrometry, which is LC-MS/MS. And that's it.
Okay, thank you, Jared. Is Dr. Halpern there?
No, she was unable to make it.
Well, she's given presentations every year, other than this one, to the summer students. And she does relate how her interest in NEC arose because her newborn son developed NEC early on in her career, survived it. And she's devoted her career in trying to figure out this disease and detecting it early, preventing it, and treating it as well. So she has a very personal motivation pushing her onward. And also, she mentors a lot of students too, high school, undergraduate, and medical students.
Yeah.
Okay, thank you very much, Jared. Are there any questions of Jared?
And how do I stop sharing this screen?
If you'll
There's
help
a
him.
red button on the top that says Stop Share. Top of your screen.
Oh, got it. Thank you.
Mm-hmm.
Okay, we're going to move on then to Kathy Ower, and she is class of 23, and she's going to talk about proteomic differences underlying sex-related phenotypes in heart failure. And her mentor is Dr. Nancy Schweitzer, who's professor of medicine and director of the Sarva Heart Center.
Hi, so as Dr. Whitty introduced me, I'm Kathy Owett. I'm a second-year medical student, and Dr. Schweitzer is my mentor. And my project for the summer and which I plan to continue during the school year is the analysis of proteomic differences underlying the sex-related phenotypes in heart failure with preserved ejection fractions. Oh, sorry, I should have done that. So I know that it's a bit of a mixed audience, so I did want to give a bit of a background. So heart failure is a clinical syndrome, and we can subclassify it based on the ejection fraction. And so ejection fraction is a percentage which takes into account stroke volume and end diastolic volume. And in more layman's terms, stroke volume is the amount that the heart is pumping out, and end diastolic volume is how much volume is in the heart when it's relaxed. And we're usually looking at the left ventricle because that's the chamber that's pumping out to the rest of the body. And under 40 is usually the when we characterize it as reduced EF, and when it's over 50, it's preserved EF, and there's a middle range, but clinically we don't see it defined like that as much. The symptoms, however, are pretty consistent no matter which heart failure you have. So you can have shortness of breath, and it can be especially prominent during exertion, chest pain, exercise intolerance, and fluid retention, for example, in your extremities or in your lungs. And the pathophysiology of heart failure with reduced EF is like pretty well characterized. It usually occurs after a significant initial insult, like you have a heart attack, a myocardial infarction, and then your heart is trying to recover, and it's just still a week after that trauma. And so there's an accepted treatment, usually triple therapy, as tolerated with a beta blocker, an ACE or an ARB, as well as an angiotensin antagonist like spironolactone. And together, studies have shown time and again that they really help to remodel the heart in its recovery. And patients can often either recover their EF or stop further degeneration. But when you have preserved EF, so for heart failure with preserved EF, we can kind of shorthanded by saying HFpEF. It has a pretty heterogeneous pathophysiology, and there's no real treatment that's been proven to be efficacious across the board. So a lot of like prior studies had looked at, like, for example, the accepted treatment used for reduced EF, and it hasn't shown consistent results in HFpEF patients. And so at this point, it's mainly treating comorbidities like having a history of AFib, and treating like known risk factors like hypertension. which are known to cause HFpEF if left unmanaged over time. And so I just wanted to pull out a quick visual in that HFpEF is quite complicated. There's many factors that go into it, and it's an issue with like that relaxation stage. So things like age and hypertension have a known effect on, like, for example, cardiomyocytes. But then there's just so many other factors that contribute. And HFpEF is just really important because around half of the patients with heart failure do fall under HFpEF, and mainly the elderly and women, interestingly enough, are disproportionately affected. And it's been a gradual increase in incidence every year, and we do expect this to increase over time. To kind of highlight the difference in sexes for women, they tend to have a lot more, as much as a 2-to-1 ratio compared to men, and they also have a higher chance of hospitalization compared to men. So we also anticipate looking over the literature on the epidemiology that in the next several decades, the amount of patients are really going to rise dramatically, especially with our aging population. And so the project I'm working on, it's a lot of data. So each patient has phenotypic data like their age, sex, BMI, quantitative data from testing, so echocardiograms, lab tests, and also information about aptamer proteomics. So aptamers are specifically small molecules that bind targets with high affinity, and they've been used in cancer research for over a decade, but haven't really been applied to looking at cardiovascular diseases thus far. And so by the end of this project, we're hoping to utilize this technology to look at biomarker differences between patients with good versus bad outcomes, and hopefully get more insight as to the underlying mechanisms for HFpEF phenotypes. But before we can even and start this analysis, it's one of the initial steps is establishing the phenotypes and variables of interest and really harmonizing the data from multiple centers. So just to kind of put it in perspective, this project is multi-centered and international, with the inclusion of a site in the Netherlands. And so there, with all these different locations giving their data, there are differences in what they were focusing on, and a lot of what I was working on this summer was looking at how we could harmonize it. And first of all, what are we interested in investigating on our end, as well as do we have that information, and if not, we need to try and get it from the clinical site in question. So due to time constraints, I'll just kind of rush through this a little bit, but I just wanted to show with this slide that some of the locations do provide some control patients. So we are most interested, of course, in HFpEF patients, but we're going to end up with 3 different groups. So HFpEF patients, people with no heart failure in general, and people with reduced EF. So the initial questions did focus on the aptamer proteomics part. So mainly, can we identify specific plasma proteins that are associated with the end outcomes, so death and heart failure hospitalization, to identify new targets to reduce morbidity and or mortality in HFpEF patients, and can we better characterize the very heterogeneous phenotypes of HFpEF, especially for this project between the different sexes. And so when I was first given the data sets, I have to admit, I tried to just jump into it. So there are, to put in perspective, about 100 columns. And I was trying to figure out how each one related to HFpEF specifically. But after talking it over with Dr. Schweitzer, it was pretty clear that a lot of them were actually characteristics to exclude other known etiologies of heart failure. So just to tie it back in a bit, for SIMI, one of our lectures was about knowns and unknowns, and that really highlighted how I should have maybe taken a step back and just kind of established, okay, what do I actually know? What am I trying to look for? And just kind of characterize it in the beginning before running down some rabbit holes. And so this summer, I was given the work in progress. So my predecessor on the project already started to harmonize 4 of the data sets. So from the TopCat trial, which was a previous very large study that was also multi-centered and international, as well as the data from UPenn, Henry Ford, and Northwestern. And I did do some summary statistics on those already harmonized data, and a lot of that was showing me that I really need to look at the quality and act as like the filter to find any outliers or any major errors in the data thus far. And also I've been trying to format and prepare for incorporation the data from Mass General. So there was a pretty big difference in some of the variables that they were interested in versus what we have currently. And so, like for one example, also like I had to go through all of them, and it was about 400 patients. They had their a list of other medications listed, and I was just kind of manually going through and double checking for quality control purposes, which is important because I did find some discrepancies, so I do have to reach out to them in the near future to resolve that. And MassGen also sent over some of the control patients who have no heart failure, so just starting that second database with this control group. And we're still waiting on one of the data sets, the one from the Netherlands, and hopefully we will be able to get that in the near future also and start to incorporate that. And I just really quickly pulled out some of the variables. It was a very long list because it was, as I said, about 100 columns, but this is just an example of the basic summary statistics I was running. So the overall, and then the broken down male versus female, and so highlighted is a clear error, so I have to follow up on that. It may be an input error or a lab error or what have you. But just doing these summary statistics was really good in showing me these potential errors that I can fix up before we actually start crunching the numbers. And so the next steps include actually completing the harmonization. So first of all, doing the quality control aspect, as well as incorporating the new data sets that we haven't formatted yet, referencing the master data sets to see if maybe it's an input error on our end versus something that was coming from the clinical site in question, in which we have to follow up with them directly about that. And then after we actually finish finalizing our data sets, then we can actually start doing the analysis on the aptamer proteomics and comparing the different groups, so HFpEF versus the controls. And we should be having someone who specializes in big data statistics come in the next few months for that. And hopefully they can really help out with the number crunching for that. And in doing so, we hope to just find some correlations between all these different variables, with so many being there. Our results should be able to give us a lot of information for future studies and investigation also, which is one of the, I suppose, fringe benefits of this current project. And that's it.
You know, that's an amazingly challenging project. And for you as a first-year medical student, having not had any experience with the data, it's just remarkable how you've attacked this with such calmness, patience, and confidence, I would say. Is Dr. Schweitzer here?
I don't think so.
Okay. Are there any questions of Kathy? Okay, well, you've got a lot of work to do, but you've gotten a really good start there, I think, in getting your arms around this very complex data set. Okay, we're going to move on then to Debbie, Debbie Edith Derman Monry, I'm sorry, it's a long name here, class of 23, and she's going to tell you about the firefighter multi-center cancer cohort study, which she's been working on for several years now.
Thank you for that introduction, Dr. Whitty. I will go ahead and share my screen here. Just to introduce, I've been working with the firefighters on this project since 2016. It's taken a couple different forms now, but the overall structure is the same. And so I will go ahead and get started. I'm currently, the current manifestation of this project is called the FFCCS, also known as the FEMA Firefighter Cancer Cohort Study. We are funded by FEMA and have been funded since 2016. We hope to continue to assure their funding for the duration of the study, which we hope will be approximately 30 years. But the reason that this study was even initiated was because cancer was recognized as the leading cause of mortality and morbidity in the fire service. And firefighters have a higher incidence and mortality rate from cancer compared to the general population. And this includes volunteer firefighters, wildland firefighters, different subgroups of firefighters that are not conducting firefighter activities for the entire year, but rather might be doing it seasonally or on a part-time position. So because of this presumed correlation, at least 33 states in the country have established presumptive cancer laws. The problem with that is that these laws often fall short. And so the firefighters who end up with a diagnosis of cancer and file a workman's comp claim are often denied and asked to prove, from what fire did they get the cancer? How can they assure that the cancer that they have is strictly related to fireground causes or their occupation, as opposed to their genetics or other risk factors like smoking. And so the FFCCS aims to sort of meet that need. It's a large, greater than 10,000 firefighter multi-center cancer prospective cohort study. We currently do not have 10,000 firefighters enrolled, but that would be the goal. And we're working towards that currently. The overall study aims are to determine whether a causal relationship exists between carcinogen exposure on the fireground and the development of cancer, determine what interventions may be used to mitigate this presumed increased risk, and determine what novel epidemiologic biomarkers exist that may later predict the development of cancer. So up until now, the FFCCS has pretty much been limited to the recruitment of male career firefighters, leaving out subgroups of firefighters that are still being exposed to these same carcinogens on the fireground, but the relationship between those exposures and the later development of cancer hasn't really been examined. So the specific research question driving my project this summer was, do subgroups of firefighters, including wildland firefighters, female firefighters, volunteers, instructor trainers, and fire cause investigators, have a similarly increased risk of cancer as male career firefighters? And the methods are the same as the overall FFCCS study, which is recruit, consent, and collect biological samples from these subgroups and analyze the biological and survey data collected from them. So what was accomplished? Obviously, I think as many students have talked about, the COVID pandemic has really limited our ability to sort of work on this project. However, we were able to accomplish some things. One is that we trained a study team in Phoenix to begin recruitment, consenting, and sample collection of the Phoenix Fire Department. So that falls under the overall FFCCS aims. And then specific to my project, we are lucky enough to recruit and consent LA County Fire Department and Cal Fire, which is a wildland subgroup of LA County, last year. And we also trained their personnel in the FFCCS methodology. And so we recruited and collected samples from them remotely using the staff that we had trained on site. And so in this format, we are able to process the samples collected by CAL FIRE through the month of July. We're continuing to do that as of yesterday. Process biological samples collected from trainers at LA County Fire Department. Process biological samples collected from the recruit class at LA County Fire Department. And unfortunately, the onboarding of other fire departments was halted due to the restrictions of domestic travel. So the questions underlying the project still remain, which is that, does a causal relationship exist between carcinogen exposure and the development of cancer? What interventions exist or can we discover that may mitigate this risk? What novel biomarkers exist that may later predict the development of cancer? And then specific to my project is the original question of, do these subgroups still have an increased risk of cancer? So next steps, continue to recruit these members of these firefighter subgroups. We're hoping with when there is a return to travel, that will begin again recruiting departments out of state. The reason we're doing this is one, because to recruit 10,000 firefighters, that's a very large number of personnel and requires multiple fire departments from different geographic locations. And the other is to potentially limit the possibility of confounders affecting this presumed relationship. There is a difference between West Coast and East Coast fire departments in terms of their exposures, as well as the types of materials they use to combat fires. And so we want to minimize these potential confounders, again, by recruiting from many different departments around the country. So the second project that came up is actually an addendum to the FFCCS study, but it is specific to evaluation of COVID-19 in first responders. So as we know, COVID-19 is a recently emergent coronavirus. It was declared a global pandemic in March, and first responders are among those with the highest risk. One, because of their close contact to COVID positive individuals, and two, the potential additive effect of work-related exposures, such as smoke and other carcinogens affecting the pathophysiology of the lung. So what is the RECOVER study? As I said, it's an addendum to the FFCCS. It is also a prospective longitudinal cohort study, but only of 400 first responders across Southern Florida and Arizona. The overall study aims are to assess whether the current exposure control methods are effective in preventing infection, to inform firefighters if they've already been exposed and have an immune response to COVID-19, and based on serologic testing, determine the extent of the need and/or modifications necessary for a future exposure reduction effort. So my specific project is to evaluate the frequency of symptomatic and asymptomatic COVID-19 infection in the Tucson Fire Department. Also to evaluate the frequency of reinfections among TFD personnel who are seropositive and or with documented prior PCR confirmations of infections, and determine the incidence of SARS-CoV-2 in the Tucson Fire Department. What was accomplished? So Recover only received IRB approval just over a week ago. But before that, we're preparing a lot of sample collection kits. We've made approximately 9,000 units. There's a lot. So this is what the sort of weekly nasal swab kit looks like, and that's what we've been prepping. I've also contacted vendors to assure supplies because we are ordering in such a high volume. And also trained on FedEx software to make shipping labels and track the sample collections that have been sent to participants. So because the study hasn't started, the original questions still remain, but I think they're really relevant and really important to answer, just as the previous questions were. For a lot of reasons, first responders happen to be a population that is poses and sort of has a unique risk due to their close contact with infected individuals, and also because of their additive effect of fireground exposures. So these questions remain and continue to drive us forward. The next steps for the Recover project, I will begin recruiting and consenting TFD personnel next week. We expect this will take a period of about 2 weeks because we have to go station to station to individually consent and recruit individuals. Sample collection will also, at least baseline sample collection will also occur during that period of 2 weeks. Baseline sample collection will be 1 blood tube from 100 TFD firefighters to test for antibodies. And then we will also give them a kit to begin testing for active virus. They're going to be collecting self-swabs on themselves every week for a span of 9 months, which we'll use to test on PCR for a positive or negative infection. This would be an assessment of acute infection versus antibodies, which would be a previous infection. So continued work with these individuals. I'm very lucky to be a part of this lab. Dr. Burgess is a great resource, Sean and Sally. And then of course, our fire service partners, the Tucson Fire Department, and specifically Captain John Galata. Any questions?
Thank you, Debbie. And I did want to mention, of course, that Dr. Jeff Burgess, who's Associate Dean and Professor of Public Health, was your mentor. I had a question whether you're going to be able to capture the population that dealt with the Bighorn fire, because you had thousands of fire personnel coming in, some of them volunteer, coming from all over the country. And I wonder whether they'll be accessible to you.
It's a really good question. We really wanted to. Unfortunately, the wildland crews were mainly out of state. So interestingly, Tucson Fire does not do a lot of wildland activities. They do one controlled burn at Sweetwater Preserve every year, but that's the extent of their wildland activity. This is sort of unusual. Phoenix Fire and LA County and Orange County all have wildland activity, and they will send personnel every year to do wildland firefighting. Unfortunately for the Bighorn Fire, most of the crews were from Utah in California. So while they may be collected, if they're from California, we may get them through our project working with LA County and WUI, which is, WUI stands for Wildland Urban Interface. And that's what they've named the division of CAL FIRE that works on wildland firefighting. So if they're under that umbrella, there's a possibility we may get samples from them this fall, which is the California firefighting season. But for the Utah crews, unfortunately not. And the other aspect is that they're not full-time employees. They work seasonally, so they don't have any health insurance and they don't have any benefits. And so it's actually really hard to find them once they quit doing wildland firefighting. They sort of drop out of the system and we miss them.
Well, I think in the past 4 years, you've become the world expert in this whole area. And it's certainly something to look forward to in your career, and with tremendous impact, I think, on this very large population that takes so many risks. Are there any other questions? By any chance, is Dr. Burgess here?
He said he may try to be on, but I don't see him. So.
Okay, well, if you see him later, tell us and we'll get to him if he does get there. Okay, we're going to move on then if there's no other questions. And we're going to move on to Benjamin Rounceville, who's the class of 2023. And he looked at central lines analysis using deep learning and analysis.
Yeah, hello. So I'm just sharing my screen, one sec. Oops. Like, can everyone see it? Okay.
Yeah.
Oh, wait. Sorry, one sec. Okay. So hi, I'm Ben Rounceville. I'm in the class of 2023. My mentor is Dr. Charles Hennemeyer, who's a radiologist. He's an associate professor of medical imaging here at the U of A. So the question we were looking at was if we could develop an automated system that can help in the localization and identification of central venous catheters using deep learning. So a central venous catheter, AKA a central line, are catheters that are placed into the large veins around the heart to administer medications and to perform certain procedures such as dialysis. And normally after you place one, you always check, you always confirm it with a chest x-ray to make sure it's placed correctly. So just to go over some basic anatomy that's relevant to central lines. So the two main veins that radiologists or that people use for central lines are the subclavian vein and the internal jugular vein. And then the optimal location is down here at the cavo-atrial junction or in the top 1/3 of the right atrium. Sometimes they can get misplaced and accidentally go up the ipsilateral IJV from the subclavian or vice versa. And then there's also a lot of other veins that they can get stuck into that aren't good. So it's always confirmed with a chest x-ray. So when we do get a chest x-ray of a central line, these are some of the questions we have about it. So one, is there a line present? What type of line is it? Is it tunneled or non-tunneled? What is the course of the central line? What is the vein of entry? Where's the tip located? And is it positioned correctly? So unfortunately, radiologists get dozens and dozens of chest x-rays every day. And it's kind of common procedure, like every ICU patient every day, they get a chest x-ray. So a lot of times radiologists they have so many chest x-rays to get through and they're not able to go through all of these and put them on the radiology report. So if we can have a system that can kind of identify some of these questions automatically, that could help save time and improve quality. Also, there's one complication with central lines that's very serious, and that's if it gets into the arterial system rather than the venous system. So that occurs when you're placing it into the, let's say, the internal jugular vein. Instead, you go into the carotid artery, and then that will look like this. So instead of kind of coursing down nicely towards the right atrium or the superior vena cava, it crosses the midline towards the aorta, and that can be very serious. So if we have a system that can kind of flag potential arterial placements, that could help improve quality and safety. So how do we do all this? So I'm sure most of you have kind of heard about artificial intelligence and technology, and it's kind of a hot topic. So artificial intelligence is kind of a very broad term. It kind of encompasses a lot of stuff, but whenever people talk about AI in radiology, what they're talking about are deep learning algorithms and neural networks. So just super briefly, I'll try to explain a little bit of what this is. So basically, a neural network, as the name implies, is kind of loosely inspired by how our own brains are structured. So you have these really simple computational units called artificial neurons or a node, and it has inputs and outputs, and each node has its weights and biases. So these weights and biases kind of allow the node to be activated by certain types of information and not activated by other types of information. So that kind of is how it is able to identify certain things. And then in a network, you have these layers of nodes, and then you have an input layer and an output layer. And what you're trying to do is map an input layer to an output layer. And your input layer could be, let's say, the pixel intensities of all the pixels in an image. And your output layer is, depending on how you design your system, it could be either a binary classification. So either there is a central line present or there's not a central line present. You can also design it so your output layer spits out an image, like another image that, let's say, like highlights a certain portion of the image, or it can be like a box around a certain region of interest. So earlier I was saying that each one of these computational units has its own weights and biases. So these are learned parameters, and when you train a deep learning algorithm, what it's doing is adjusting all of those weights and biases until it reaches kind of an optimum. And the way that's done is when you get your output, you compare the output to a ground truth, and that ground truth is kind of labeled by a human, and that's like what the image actually is. And then based off that comparison, the algorithm goes back and adjusts all of the weights and biases by a very small increment, and then it tries again, and then it just keeps on going until your loss or your error, basically, it reaches a minimum, and that's kind of where you get your optimized algorithm from. So that's just very brief. Can't really get into too much more detail. And what we're collaborating with some professors and students in the College of Computer Engineering that are really helping us out with a lot of the technical aspects of it. But so anyway, back to kind of the questions we're asking. So they kind of fall into two different categories. So there's classification problems, where it's just like you're asking a question and you basically just want a yes or no answer to them. And then there's segmentation problems, where you want your algorithm to spit back out some sort of like segmentation map that highlights all of the pixels in a certain area of the image. So classification problems are generally much easier to train an algorithm on. And the reason that is because the data you need can be labeled with weak labels versus strong labels. So a weak label is basically a label that you give to the entire image. So for example, if you have a chest x-ray, you could label it 0 if there's no central line present, or you could label it 1 if there is a central line present. So that's pretty quick to do by a human. And you could generate like a really large data set pretty easily doing that. Whereas strong labels, you actually have to go in and highlight every pixel that's a part of a certain structure. So if you wanted to like identify the central line using a strong label, you'd have to go in and highlight every individual pixel by hand. And that is much more tedious to do by a human. And we're still doing it, it takes a lot longer. So to get our data, we applied for an IRB to get chest x-rays from Banner, and we got the IRB, but getting the actual chest x-rays just took a long time. So we turned to a public repository, and these things, like especially recently, there's a lot more of them out there that are publicly available for research use. So this one is put out by Harvard, and it's just a collection of over 200,000 radiographic studies. And you have to apply and do training to have access to it. And we were able to do that, and we got access. And then we went through, and about 5,000 of the chest X-rays contained a central line. So we were in luck there. And then, but there's also other repositories out there that have all sorts of other different types of images. So the chest X-rays we got, though, they were unlabeled, so we had to go through, and first we went through and just applied weak labels to all of the images. So we just basically like went through and gave it a single number, like 0 for central line or 1 for no central line. Or we did dialysis catheters versus normal central lines. So dialysis catheters are a lot bigger and thicker than normal central lines that are just used for medication. So we had, in the file, we had about 50-50. And so we went through and separated them out, just the dialysis versus central line. And then this is kind of like the simplest problem we could do. So we started with that. And with about the 5,000 chest X-rays, we trained our algorithm, and then we reserved about 300 images for like testing and validation, just to see how well it went. And so here's kind of the results of the testing data. So as you can see, this is actual and this is predicted. So of the actual data, we had 117 plus 27, that's 144 total central lines, and our algorithm got 117 of them correct. And then for dialysis catheters, there was 149 total, and it got 136 of them correct. So this was kind of just a preliminary, like, proof of concept algorithm, just to kind of show that we can do it. And we're collaborating more with the professors at the College of Engineering to kind of continue making more of these algorithms for the rest of the problems. But kind of going back to this one, just some more information about it. So neural networks kind of have a reputation of being inscrutable black boxes. Like, you can't really, it gives you an answer, but you can't really tell how it arrives to its conclusion, because basically you have millions of weights and biases and parameters that are spread out across millions of nodes, and it's kind of impossible for anyone to make sense of just all of that information. But one thing that's been developed is you can look into one of the layers in the neural network, and then kind of make a class activation map, which is based off of what areas of the image give the highest level of activation in that layer. And that's kind of like a roundabout way of seeing or of understanding what the algorithm's looking at. So for example, in this one, the algorithm predicted a dialysis catheter, and it indeed was a dialysis catheter. And then you see right here where it's highlighted, that's kind of what was activating the algorithm the most. So we could kind of tell that's what it was looking at, which is kind of the same way a human would do that. However, this is the same thing for a central line. So there's a central line, and then it's kind of showing, like, it's looking that it's not looping around like a dialysis catheter. So that's just kind of interesting. Although there is a bunch of activation down here, which is kind of a problem with some of these algorithms, where you just give it an image and then it'll just look for patterns anywhere. And then sometimes a lot of those patterns are kind of meaningless, but the algorithm doesn't know any better. It's just looking for any sort of correlation. So that's kind of exemplified here, where it thought it was a dialysis catheter, but it was actually a central line. And as you can see, there's probably like all these other chest tubes and external and internal objects that are really confusing, and it just kind of got messed up and was looking at everything and wasn't able to predict correctly. Although one way to kind of get around this is just use more data, and then you can also, instead of just using weak labels where you just label the entire image, you can kind of specify like you want to look over in this area. But that's where you have to like get into more of the stronger labels where you actually have to hand annotate right there to look at. So just kind of future directions, we were able to kind of explore, this is kind of what our final product we want is, we get a chest x-ray and then the algorithm will like determine is it a central line or not. If it's not, it ends it. If it is, then it goes down here and asks the rest of these questions. And so we're kind of just slowly going to go through each one of these modules and create an algorithm, and then eventually just kind of put it all together so it and see if we can get a product that is useful for radiologists. So that's basically it. Any questions?
Okay, it's very interesting. And it's certainly the future of many aspects of radiology. Are there any questions? Is Charles there? Is Dr. Hennemeyer there?
Unfortunately, no, I don't think he could make it.
I know he works from sun up till sundown, 7 days a week. I know that. I haven't seen him in a few months. Okay, if there's no questions, we'll move on then to Emily. Emily Susan Westerbarth, who's class of 2023, and she's going to tell us about the Cancer Genome Atlas for colon cancer. And her mentor was Dr. Fonsum, who's professor of surgery.
Thank you, Dr. Whitty. I'm just going to share my screen. Okay, so hi everybody. My name is Emily Westerbarth and I'm a second-year medical student. And this summer I worked with Dr. Fonsum and I also worked with Dr. Pandey. And my project was called Upregulation of the Expression of Cartilage Oligomeric Matrix Protein, or COMP, correlates with disease subtypes and stage. Oh, there we go. So my beginning questions were, how do levels of COMP vary across different colon cancer consensus molecular subtypes? And how do levels of COMP vary across different colon cancer stages, 1 to 4? And then how does COMP expression affect patient survival, and how does this survival vary by subtype? So the importance of this project was that the overall incidence of colon cancer is declining, partly due to improved screening practices, but the early onset colon cancer cases, which is patients under 50 years old, have continued to rise over the past 30 years. And so our previous research has focused a lot on COMP and several other genes that have been shown to be uniquely differentially overexpressed in early versus late onset colon cancer. So these genes, as they become studied more often, can be potential colon cancer biomarkers, which could be diagnostic or prognostic indicators or used for treatment response monitoring. And then they could also be targeted for treatment therapies. So what is COMP? It belongs to a family of proteins called thrombospondins, and it's also known as thrombospondin 5. So COMP is an extracellular matrix protein, and it binds to collagen and fibronectin in the extracellular matrix, and it aids in assembly and stability. So it's found mainly in cartilage tissues, and it participates in chondrogenesis, but it's been studied with relation to a lot of other diseases. So connective tissue diseases such as pseudoachondroplasia, multiple epiphyseal dysplasia, and then arthritis. And interestingly, in arthritis, it's been studied with, you can measure the serum COMP levels, and that correlates with disease severity. So with regard to cancer, it's been studied in breast and prostate cancer, and then also, of course, in early onset colon cancer. So a lot of our previous research has centered around COMP, and we found that it correlates with increased expression of the Ki67 proliferation factor, and then also ACAT pathway activation, which is a pathway involved in tumor proliferation. And then it also co-expresses with EMT factors, which is epithelial mesenchymal transition. And basically what these factors allow is for cells to lose their polarity and then travel off to distant sites in the body and invade tissue. So metastasis is a big thing with this. And then we also know from our previous research that COMP correlates with poor patient survival outcomes. So then consensus molecular subtypes in colon cancer, this is a system that's used to classify colon cancer. So we know of 4 distinct subtypes, and the classifications are based on genetic, epigenomic, transcriptomic, and microenvironmental features. And then each different subtype has different clinical behavior. We know about different pathways expressed within the subtype, and then we can say things about patient prognosis and different treatment options based on this. So this is a table that kind of breaks down the consensus molecular subtypes. You can see there's 4 of them, and I'm not going to go super in depth on this for the sake of time, but we have CMS1, which is the immune subtype, CMS2 is canonical, CMS3 is metabolic, and CMS4 is mesenchymal. So I did want to highlight that CMS4 has the poorest patient survival that we know of, and CMS2 generally correlates with the best survival, but CMS3 is close in that regard. And then I also wanted to highlight that there is prominent TGF-beta pathway activation in CMS4, and this pathway is heavily correlated with induction of EMT. So what I was talking about before with invasion, metastasis, angiogenesis, et cetera, that gives tumors the ability to move. So our project specifically utilized the Cancer Genome Atlas colon adenocarcinoma dataset. And this is basically a public data set that has a bunch of different information about colon cancer tumors. So we have RNA sequencing data for 456 colon cancer tumors and then 41 normal samples. So we analyzed the COMP expression in these tumor samples and the normal samples. And then we stratified by patient stage 1 to 4 and then subtype, which is CMS 1 through 4. And we compared the levels of COMP that were present in each. And then afterwards, we wanted to analyze the survival of each. So we divided our patient samples into 3 quartiles based on COMP expression. So our top 25% quartile had the highest COMP expression. Our bottom one had the lowest COMP expression. And then we had like an intermediate group with the rest of the patient samples. And so we looked at each quartile to kind of see what consensus molecular subtypes were present in each. And then we did Kaplan-Meier survival analysis. So we did 3 quartiles, and then we compared different subtypes within the quartiles. So here's our first set of results, and this is looking at the stages. This is a box plot. So as you can see, the COMP expression levels increase from stage 1 to stage 4, and this is significant from normal to stage 1, and then also significant from stage 1 to stage 4. So it's kind of showing as your cancer gets more severe, your COMP levels also go up. And then this was showing the consensus molecular subtypes. So here, our lowest COMP expression was found in CMS3, but this was still significant when compared to normal samples. And then our highest COMP was found in CMS4. And then the NOL, BL are samples that weren't assigned to any subtype. So here's the results of our first survival analysis. So this is after we moved the patients into different quartiles based on COMP expression. So our bottom line here is the top expressing quartile, so the green line, if you can see my cursor. So that's the top COMP expressing quartile, and that's showing that it has the poorest patient survival probability. And this x-axis is in days, just for reference. So then the blue line is intermediate COMP expressing levels, and then the red line is going to be the bottom expression levels. And then this is basically just a table showing which subtypes were present within which quartiles. So in the highest expressing COMP quartile, we see that it's mainly CMS4 that is getting expressed there. And then in the bottom quartile, we can see that that's dominated by CMS2 and CMS3 pretty much. And then this was comparing CMS3 and 4 samples in the top and bottom expressing quartiles.
So again, we're going to see that CMS4 in the top quartile has the poorest patient survival. And then we had the most data for CMS3 in the bottom quartile. So that's clearly a better patient probability of survival. But in the top quartile with CMS3, we didn't really have enough data. We only had one patient in that cohort, so it was hard to compare and get statistical significance. So summarizing the results, which I basically said a lot of, so I'll just kind of go through them quickly, is that COMP expression increases as colon cancer stages progress from 1 to 4. And then COMP expression is highest in CMS4. And this, again, was the subtype associated with mesenchymal transition, stromal invasion, angiogenesis, and then poor patient survival. And then we saw in that one figure that higher levels of COMP in our patient cohort correlated to poor survival outcomes overall. And then high levels of COMP and poor survival was mostly made up of CMS4 samples. So again, kind of demonstrating that COMP is aggressive and CMS4 is also known to be aggressive. So it makes sense that they're correlating with each other. And then CMS4 was not present at all in the quartile with low levels of COMP and better survival. So kind of tying those two together again. So what do these results tell us overall? Basically that COMP is contributing to colon cancer tumor progression, which is kind of proving what we've looked at in our previous studies and further telling us that COMP has some contribution to aggressiveness. And then when we're looking at the COMP expression levels, we are thinking that COMP is likely participating in EMT induction. So we showed in our previous studies that COMP co-expresses with EMT factors. And then we also know that CMS4 is heavily associated with EMT factors, likely through this TGF-beta signaling pathway. And so if they're both kind of correlating with these factors, we're thinking that COMP is participating and contributing to the progression of CMS4 in that way. So COMP may have a role in the TGF-beta signaling pathway. This is going to require further investigation, but it is looking like COMP has a role in EMT expression. And then all of these things are important because COMP has promising results as a diagnostic or prognostic indicator of colon cancer. And our current standard for prognostic indicator is CEA, which is something that's been used for a long time to measure just disease progression in general, but it's not entirely accurate. And so there's a lot of push to develop something that could be a little bit more useful and an accurate predictor. So remaining questions in future direction are basically what are the specific mechanisms surrounding COMP's role in colon cancer? And this is a big thing that our lab studies, and there's a couple other labs that study this. So we really need to kind of elucidate those mechanisms moving forward. And then how is COMP participating in tumor proliferation and metastasis goes along with that. And then kind of in the future where we want to go is, can serum COMP serve as a predictor of colon cancer stage or subtype? And especially we've seen those associations with COMP and CMS4. So I think that there could definitely be some promise with that. And then what are the effects of high, intermediate, and low COMP expression on survival within each subtype? So we would clearly expect that high levels of COMP would impact survival in a poor way in each subtype, but I think that we could characterize that a little bit more moving forward. And then I just wanted to thank Dr. Whitty and Grace and everyone for everything this summer, and to thank my mentors because they've been very helpful. And with that, any questions?
Any questions from the group? Is Dr. Fonsom here? I see that Dr. Pandy is here. Ritu, did you want to make a comment on Emily's work?
Yeah, I think she started into it, and it's a very complicated system to work on. So there's a lot of opportunities for her if she wants to continue in the lab and do further research. It's pretty interesting that colorectal cancer, one of the things about that is you can get a lot of samples. So it's one of the tissues that is easily available. But over the time, it has become so complicated because earlier it was being screened on mutational profile and certain factors. But after bioinformatics stepped up and all these molecular subtypes have come in, the 4 subtypes based on transcription, the colon cancer, left, right, transverse, everything has a different subtype now, a different outcome, different response to therapy. So I think if Emily wants to go further on this project and wants to do, there's a lot of opportunities, and she did a good job. I mean, it was good to see her like understanding the whole big picture. So.
Yeah, and I don't know how much statistics the medical students get, but I suspect it's a very little in your basic science. Does anyone want to tell me how many hours of statistics that you have?
Most of my statistic experience came from undergrad, actually, and like biostats. With med school is kind of touched on, but not really in depth, and especially not to the extent that this project explored.
And so many of the projects today required very sophisticated statistical analysis. Now, you've had access to statisticians to help you, but it seems like all of the students who presented really understood what they were doing statistically. They understood the methods, the limitations, et cetera. So it's stuff that you learned on its own, on your own. So,
yeah, but I think you bring a good point, Dr. Witte. I mean, I'm noticing that all these medical school students are going to graduate in an era where there'll be so much big data, so much molecular data. You got to understand all this and include that in every decision you make, every research you do. So it's very important for them.
Precision medicine.
Yeah, I know. Yeah, that's what we are doing.
Right. So as students, you might ask that there be more available, certainly on an elective basis, if not required. And certainly the faculty should also promote that as well. Okay, thank you for that excellent presentation. And we're going to go on to Mackenzie Lee Schaefer, class of 23, and she's going to talk about lymph node ratios for pancreatic cancer. And her mentor is Dr. Amanda Arrington, who's Associate Professor of Surgery.
Thanks, Dr. Witte. Let me share my screen. Okay. So, oops. All right. So my project was the significance of lymph node resection after neoadjuvant therapy in pancreatic adenocarcinoma. And I'm actually going to try and get this screen looking better. I'm not sure why it's looking like that. Sorry, guys. I might just have to present it like that if that's okay.
Juan, can you help her?
What's the issue?
She wants to bring up her individual slides. And not
did you try the, can you go ahead and click on that button that you were hovering over, the presentation slide button?
Yeah.
And then, are you using more than one screen?
Yes. Shall I unplug that?
No, that shouldn't be an issue. No, it's just that the button on the top left said swap displays. I didn't know if it was talking about the way it looked or the screens that you have.
Should I try that?
Maybe do use slideshow.
There we go. Thank you.
There we go. Thank you.
Yeah, so anyways, my presentation was the significance of lymph node resection after neoadjuvant therapy in pancreatic adenocarcinoma. And my mentor was Dr. Amanda Arrington. So my initial questions were kind of broken down into 2 different groups. The first was regarding surgical resection of lymph nodes. And those questions were, is there relevance in the total number of lymph nodes removed during surgical resection? Can the lymph node ratio aid in determining prognosis of pancreatic adenocarcinoma? And is there significant is there a significant difference in lymph node ratios between patients who receive neoadjuvant therapy versus upfront surgery? And then regarding neoadjuvant therapy, do mortality and morbidity outcomes differ in patients who receive neoadjuvant therapy versus upfront surgery alone? And do complication rates, pain control, and length of hospital stay differ in patients who received neoadjuvant therapy versus upfront surgery alone? So a little bit about the significance of the problem. Pancreatic cancer has recently become the third leading cause of cancer mortality in the US, and it's estimated that it will actually become the second leading cause by 2030. And morbidity and mortality relating to surgical resection remains high. It's a pretty bleak 5-year survival rate of 8%. Cancer resection specimens with no lymph nodes or low number of lymph nodes leads to potential understaging of disease. And lymph node dissection is not thought to be therapeutic, but rather it's more to guide additional treatment. And so there's really no current recommendations for the minimal lymph node numbers for accurate staging in pancreatic cancer, which has been kind of a gap in the literature. And multimodality therapy is recommended in node-positive disease, and that is chemotherapy and/or radiation. And it has been proven to provide a lot of theoretical advantages in the neoadjuvant setting before surgery. And those can include kind of downsizing or downstaging of tumors, which allows for organ preservation, and higher R0 resection rates, early treatment of metastatic disease, increased tolerance to chemotherapy. And so there's just been a lot of data that it has been working, so it's become the standard of care now. So the methods we used was using the National Cancer Database information, and we pulled data for patients with primary adenocarcinoma of the pancreas between 2010 and 2015. And we included stages 1, 2, and 3 disease. And then patients were further classified into 2 groups: those who received neoadjuvant chemotherapy with or without radiation, and those who had initial surgery with or without adjuvant chemotherapy or chemoradiation. And our exclusion criteria included non-adenocarcinoma tumors, patients with another primary cancer, or patients who underwent intraoperative radiation, and patients who were missing the relevant data. And so the overall study evaluated gastric, rectal, and pancreatic cancer, but my specific summer project was just the pancreatic cancer. So this is our results. We had a total of 15,000 pancreatic cancer patients were identified, and of those, only 21% received neoadjuvant chemotherapy, while 78% went through upfront surgery. And then of those with neoadjuvant therapy, 30% were downstaged on final pathology, compared to only 3.2% of the initial surgery group. So in this graph on the left, you can see that the number of actual lymph nodes removed for those on neoadjuvant therapy versus initial surgery weren't significantly different, but then the number of positive lymph nodes, which are the nodes that tested positive for cancer, was much lower, significantly lower in the neoadjuvant therapy group. And then we also did Kaplan-Meier survival curves for this, and you can see here that the neoadjuvant therapy had longer survival percentages than those who underwent upfront surgery alone. Some of the fringe benefits that I got this summer was a pretty deep dive into the Cerner database. Over 250 variables were collected on each patient, so it took quite a bit of a learning curve to figure out where everything was in Cerner. And then once that I began to be familiar with that. It's nice now to understand Cerner and kind of know where everything is. I also was able to get a lot of mentorship on manuscript writing, editing, revision, and submission. And I was able to become familiar with various software that's necessary for research projects. And we also did grant and IRB submissions. And my lab group was multi-physicians, so there's 3 hepatobiliary surgeons. And I also was able to learn a lot of interesting insights into cancer care, including the multimodal therapy and end-of-life care, because pancreatic cancer does have pretty bleak survival. So remaining questions, that study answered a lot of the neoadjuvant and regarding lymph node ratios, and now we're kind of switching over to neoadjuvant therapy and looking at mortality and morbidity outcomes, along with complication rates, pain control, and length of hospital stay. So to do that, the second research project that we did and are still doing was a retrospective chart review of pancreatic cancer resections here at BUMC Tucson over a 12-month period. And so in order to do that, we made an electronic database in REDCap, and relevant patient information was extracted. In total, there was 50 surgical cases, and the data analysis will aim to evaluate the following parameters in patients who did receive the neoadjuvant therapy versus surgery alone. And that's where we're going to start looking at those mortality and morbidity outcomes, complications, pain control and management, and length of hospital stay to further quantify the use and the recommendations of neoadjuvant therapy in pancreatic cancers.
Next Friday.
And just a huge thank you to my lab group and my PIs for the mentorship and the opportunities over the summer. It's been great and I've really enjoyed it. Any questions?
Thank you, Emily. Is Dr. Arrington there?
She had a surgery today, so she wasn't able to make it.
Would students alert their mentors that these presentations will be on our YouTube channel momentarily? We might want to put them up immediately, and then we can edit them later, because there may be mentors who want to look at the presentations. And so far, I don't see any reason why they couldn't go up directly and we can edit them later.
Okay,
So
yeah, we can try that.
Mentors, because there were so many of the mentors who are busy, they're operating, they're doing interventional techniques, and I'm sure they wanted to hear your presentations. So we can put them up maybe next week sometime and get them up on the YouTube channel. Okay, thank you very much, Mackenzie. And we're going to go on to William Estes, and he's class of 23, and he's going to talk about gait analysis in posterior tibial tendinitis. And his mentor is Dr. Dan Latt, who's associate professor in orthopedic surgery and another very prolific mentor.
All right, so let's see. Okay, so I am Bill Estes, and I am a second-year medical student. And as Dr. Woody said, I've been working with Dr. Latt, who works in orthopedic surgery, and I'll be discussing PTTD and AAFD etiology, prognosis, and treatments. So first, for a little bit of background, the main culprit in the studies that we're looking at is the posterior tibial tendon, which you can see here wraps around the medial malleolus of the ankle and is the body's the foot's strongest inverter, which is important during gait because it holds the foot in kind of a rigid position that allows you to more effectively plantar flex and push off. And so PTTD stands for posterior tibial tendon dysfunction, which is usually the result of tendonitis of the posterior tibial tendon. It's very common and affects about 3% of women over 40 and is more common in women who are overweight. It usually manifests as retromalleolar pain and reduced inversion force, which leads to a negative single leg heel raise test. So when you have the patient stand on one foot and try to go up on their toes, they usually can't do it. And this is a common cause of AAFD, which stands for adult acquired flat foot deformity. This is usually unilateral, but sometimes it can be bilateral. And usually what you see, there's some cardinal characteristics that you see. There's a valgus deformity of the hind foot, which you can see right here. There's a collapse of the medial arch, which you can't see in this picture, but you can see in this one. And then there's also abduction and supination of the forefoot, which you can also see here. This is called a too many toes sign, where you have the patient standing with their knees pointed forward. And if you can see all their toes to the side, then that's indication of AAFD. Like a lot of different diseases, AAFD and PTTD are staged in terms of severity. So in stage 1, it's just pain and weakness without any structural changes. Whereas stage 2, which was the main focus of our research, the tendon is actually lengthened and you see these foot deformities, but they're still flexible. So if the doctor actually manipulates the foot, they can kind of bend it into the correct position. Whereas in stage 3, those deformities actually become fixed because usually they've been in that position for so long that they become rigid in that position. And then stage 4 is where the tendon actually ruptures, which leads to ankle deformities as well, and is often associated with osteoarthritis. With both PTTD and AAFD, they're kind of used interchangeably. There are specific gait changes that we usually see, and this was based on a meta-analysis that Dr. Latt did. And what you see is that during mostly the single support phases of gait, you see increased forefoot dorsiflexion and increased abduction, whereas in the hind foot, you conversely see decreased dorsiflexion and increased eversion. So there's a couple of different ways, or there's a bunch of different ways of going about treating this. Usually in stages 1 and 2, you want to err on the side of conservative treatment rather than jumping right into surgery. And that usually consists of rest and anti-inflammatories. And they're usually put in a cast or one of those boots that you see athletes wear after ankle injuries for 4 weeks. And then after that, they're given a supramalleolar brace, which you can see here, that supports the correct position of the foot and ankle. And they're put on a physical therapy regimen for 3 to 6 months to strengthen their inversion and to increase their Achilles range of motion, because Achilles tightness is often associated with this, and to reduce inflammation. And usually this is about 70% successful, but obviously that means that 30% are not successful in alleviating symptoms with this. So with those patients, along with patients who have stage 3 or stage 4, you move into operative treatment, and there's a bunch of different things that physicians can do. Usually depends on the severity and the specific deformities that are present in the patient. The most common are the flexor digitorum longus transfer and the lateral lengthening, in which they actually insert either tissue or prosthetic into the lateral portion of the foot to kind of push it back into the correct position. But then in more severe cases where you actually have arthritis, they'll often do an ankle fusion, which is the double or triple arthrodesis, or a total ankle replacement. So our initial questions were asking, do patients with PTTD have changes in different elasticity than healthy individuals in their posterior tibial tendon? And does physical therapy change the elasticity in that tendon? But our big focus was, does PTT elasticity predict the necessity for surgery, and can ultrasound and shear wave elastographies be used as a prognostic tool in PTTD? So our initial project was kind of set up to address these questions in kind of a stepwise fashion, where we would measure the posterior tibial tendon elasticity in both PTD patients and healthy controls to see if there's a difference there. And that we had a couple of cases and a couple of controls that we had measured a while ago. But we were trying to recruit more for that because it wasn't enough to do really any kind of analysis yet. Then the patients would go through 4 months of conservative treatment, and we would measure them again to see if there was a change in elasticity from the initial treatment. And then we would separate out the patients that were successful with conservative treatment at alleviating their symptoms, and the patients who needed to go on to surgery, and seeing if there was a change or a difference in their initial measurements to see if we could see if there's a correlation between the elasticity and the necessity for surgery. But we hit a couple roadblocks that threw a wrench into that plan. People have been talking about the COVID-19 pandemic, so I won't get into that. But during the summer, we were informed that our IRB approval was suspended due to some FDA regulations on shear wave elastography. So due to that, we kind of had to put this project on hold and decided to pursue some different questions. So now we're asking, how does conservative and operative treatment affect the actual gait of the patients? Because usually the literature that's been done on outcomes usually focuses on pain and structural corrections and doesn't really focus on gait specifically. And also, does AAFD surgery significantly improve foot and ankle biomechanics over conservative treatment? So we're taking a two-pronged approach to answer these questions. First, we're doing a meta-analysis of biomechanical specific outcomes in both conservative and surgical PTD treatment. And so far we've collected 17 articles through PubMed and Clinical Key, and we're probably going to be expanding to some more search engines soon. And then we're also applying for another human research project in which we will analyze the gait of PTD patients before treatment, and then we'll have them go through conservative treatment and do another gait analysis, and then the patients who need it will go into surgery, and we'll do another gait analysis after that to see if there are significant changes with the different methodologies. As far as fringe benefits, I was definitely able to review the anatomy and biomechanics of the foot and ankle, which is important to me because I want to go into orthopedics, so that's important to know. But I would say the biggest benefit that I got from this summer was getting firsthand experience in the research project or process, because having come from a small liberal arts college, there wasn't a whole lot of big research going on. And so I was pretty limited into what kind of experience I could get in that regards. And so being able to work on a research team and develop testable questions and, hammering out which methods are going to be best in addressing those questions, and going through, IRB approval and the different types of training we have to go through, and knowing which documents need to go to whom and where to get those documents and all those different things. And now I'm working through writing that analysis, and that's a new experience as well. So just a lot of practical experience that I'm definitely going to be using going forward in my future research. So I'd like to thank Dr. Latt in particular, and also Dr. Whitty and Grace for all the help that they've given me throughout this process. Does anyone have any questions?
Any questions from the audience? If not, I want to compliment so many of the students who've had to truly pivot and change your project design, your methodology, your schedule, and work with your mentor to do so and to accomplish very important results. Now, I think there's a false question out there with most universities. Is it, can we reopen or can we not reopen? Rather than what can we reopen and what should be delayed. And I think clearly you showed many of the students that many things can go on, both with the high school students, the undergraduates, and the medical students. Some of it very much in person, some of it in labs, in clinics, et cetera. If the guidelines are followed and the waivers and checklists are followed, that you can do a lot of very significant, impactful research that you would otherwise do under normal circumstances. And then if you can't do that, you adapt with your mentor to do other things. And some of the things end up being remote by choice of the mentor or by the nature of the project and so on. So it's more that the faculty and students with the administration should be finding out what can we reopen, how can we reopen it? Because clearly the engagement of students in person is important, and it can't be just thrown away. And therefore we have to see how we can adapt. I see Dr. Fonsom is here somewhere. Val, did you want to comment on Emily's project? Is Dr. Fonsom still here, or did he come and go? Sometimes he gets called out. Okay, I suppose he's not still there. Is Dr. Latt there?
I don't think so. He's usually in clinic on Wednesdays.
Okay, so make sure that they know that they can go up and watch your presentation and any of the other presentations they want to watch on the YouTube channel. Okay, we're going to move on then to Ahmad Safdar. He's class of 23, and he's going to be talking about log screws and threaded screws and so on. And he's going to be looking at compression in the hindfoot arthrodesis with Dr. Latt.
Thank you, Dr. Whitty. Hi, everyone. My name is Ahmad Safdar. I'm a second-year medical student, and the title of my project is Comparison Between Lag Screws, Fully Threaded Screws, and Dual Pitch Compression Screws for the Maintenance of Compression in Hindfoot Arthrodesis. I want to start by acknowledging Dr. Latt. He is the PI of my project. He is in the Department of Orthopedic Surgery and Biomedical Engineering. I really want to thank Dr. Latt for giving me the opportunity to do my MSRP in his lab, and also for being a great mentor. I really look forward completing this project with him and hopefully many more. So before I began my summer research project, I had a series of initial questions that I would address over summer. So some of these initial questions include: when is arthrodesis indicated? What are the steps of arthrodesis? How does bone react to compression? What is viscoelasticity and stress relaxation? Will retightening a screw a few minutes after placement help maintain the compressive force? And what effects does resistance exercise have on bone health? So introduction. The ankle joint is the most common joint involved in foot and or ankle arthritis. The ankle joint is made up of 3 bones: the talus, the tibia, and the fibula. And I've included 2 pictures on the screen, one of a normal ankle and one with arthritis. And you can clearly see that the arthritic ankle has joint space narrowing, some osteophyte formation, and maybe even some subchondral cyst formation. And all this is very painful to patients. So end-stage arthritis is defined as arthritis that fails to respond to conservative treatments like NSAIDs, steroid injections, and physical therapy. And for patients who have end-stage ankle arthritis, the best next step is to undergo ankle reconstruction surgery. So one, they can either do a total ankle replacement, or two, they can undergo arthrodesis. And arthrodesis involves removing the joint and fusing the previously separate bones. And the fusion is usually done by screws or bone screws. And the goal of arthrodesis is to eliminate this arthritic pain and relieve inflammation. And so I want to take you all through the steps of arthrodesis. So this is not an ankle arthrodesis, but is one that Dr. Lapp performed on the first MTP joint. So as you can see, this is clearly arthritic. There's cartilage that's worn off on the medial side as well as underneath the probe. So in surgery, the first step is that the surgeon will go in, and it's called surface preparation, where the surgeon removes the cartilage and the soft tissue between the bones that they want to fuse. And the next step is reduction, and this is just simply when the surgeon orients the bones in the specific orientation that they want. And then comes in the fixation device, and this fixation device is used in hopes that the bones will fuse and the patient's arthritic pain will go away. So back to ankle arthrodesis. So this is an example of a successful subtalar fusion. But there are limitations of hindfoot arthrodesis. As you can see in this picture, these bones have not fused. And the primary reason of failure is non-union. And actually 40% of cases, the bones either take longer than anticipated to fuse or they don't fuse at all. And this is likely due to a failure to obtain or maintain this compressive force at the arthrodesis site. So why is compression so important? Well, studies have shown that maintaining compression decreases the risk of non-union. Our osteocytes and osteoblasts actually act as mechanoreceptors at the cellular level, and they respond to this compressive stress by promoting bone growth. I just want to reiterate that the bone screws is what creates the compressive force, but I've also included a mechanotransduction pathway for bone cells on the screen. But what I want you all to focus on is how when the osteoblasts feel this compressive force, they communicate with osteocytes, and this communication leads to the release of prostaglandins and growth factors and other intermediates that really help promote bone growth. So to understand why non-union occurs, one needs to understand the concept of viscoelasticity. So bone is a viscoelastic material, and that means that it has both viscous properties and elastic properties. In other words, it has properties of both solids and liquids. And because of that, they exhibit both the linear elastic response and a time-dependent viscous response simultaneously under applied load. And I've included these equations just to help model what viscoelasticity is. So you can think of force equals Kx, which is spring force, as the elastic component, and force equals Cv, which is for viscous materials or the viscous component. And it's a combination of both of these forces at work and not just one. And this viscoelastic property of bone is an important determinant of how much compression can be maintained at an arthrodesis site, because viscoelastic materials, they have a property known as stress relaxation. And this is just a decrease in stress as a polymer is held at a constant strain. So on the graphs on the screen, you can see that when a viscoelastic material is held at a constant strain or deformation, the force actually exponentially decays over time. And that is due to the material continually flowing into its new configuration. And obviously this is important because if we can't maintain compression, how will the bones be able to fuse? So previous work in Dr. Lott's lab was able to demonstrate this property of stress relaxation. They subjected bone to an initial amount of compression, and they saw the compressive force exponentially decay over time. And what was really interesting was that the compressive force, the majority of it was actually lost in the first several minutes. And that project really led into my project, which is to quantify, comprehend, and compare the stress relaxation at the bone-to-bone interface for various screw types that are commonly used to achieve compression during arthrodesis. And we use lag screws, fully threaded screws, and dual pitch compression screws, just because they're the most commonly used in hindfoot arthrodesis. And our hypothesis is that the compressive force sustained over time that is generated across a bone-to-bone interface will be the greatest with a dual pitch compression, less with a lag screw, and least with a fully threaded screw. And we weren't able to, because of the COVID-19 pandemic, we all weren't able to work on our projects as much as we wanted, but I still want to discuss what I did and what I am going to do. So what I was able to do was dissect out talus, calcaneus, and the tibia from thawed cadaver feet. And then I used an oscillating saw to remove the cartilage and soft tissue that's present in preparation for the simulated arthrodesis. And then I also learned how to make the bone cylinders that we'll use in the experiment. And this process actually took me the longest time just because it was so difficult learning or getting the correct orientation with the drills. But what I plan to do is complete the project and collect data. Figure 2 shows our experimental setup. And as you can see, we'll have a load cell and 2 metal washers that'll be sandwiched between 2 bone cylinders. And then we'll have a sensor that will be connected to a computer that will measure the compressive force at 10 Hertz. And then we'll use various screws and insert them from the posterior aspect of calcaneus to the anterior superior aspect of talus. And that will simulate the fixation during arthrodesis. And we'll compare how the compressive force is being able to be maintained with the different screws. And we will also be taking micro CT scans of the bone samples pre and post compression to quantify bone porosity and also to just see how compression affects the overall quality of bone. And because the lab was closed for the several first weeks of my project, I spent a lot of time reading research papers. And my goal there, my job there, was to create questions and suggestions that could benefit our project and our team. And we would meet weekly to discuss what I'd found. And I just want to talk a little bit about resistance exercise and bone health, just because it was a common topic in the literature that I read, and also just something I'm interested in. So resistance exercise is just contracting your muscles against an external resistance. So like lifting weights. And previous studies have shown that weightlifters have a significantly higher bone mineral density than controls. But what's interesting that I read was that exercise training could enhance bone strength independent of changes in bone mineral density through alterations in bone structure and or localized adaptation in bone distribution at the sites subjected to the greatest strain. To sum it up, I really believe that, or at least the medical literature suggests that resistance exercise could really help reduce the incidence and morbidity of bone-related diseases. And after my MSRP was over, these are the final questions that I had, and I hope to be able to answer them as the project progresses. So would using cement with the screws help maintain the compressive force? Would maintaining a certain degree of soft tissue during arthrodesis surface preparation assist in recovery? Does a short period of training followed by a sedentary lifestyle give rise to a higher BMD decades later in life? And is there a trend between increasing porosity of bone and the number of interfacial deformations? And obviously COVID-19 was a big setback for all of our projects, but another thing was finding ankles once we were able to get into the lab. Because our project is very destructive, it leaves us on the bottom of the food chain for getting ankles. So all the other projects have to finish using them until we get them. So it was a bit of a waiting game in the beginning. But the hopes are to complete the project and hopefully develop more questions to investigate. And I really want to thank Dr. Latt and Dr. Whitty and Grace and everyone involved in the MSRP. And that's it. Thank you. Anyone have any questions?
Any questions from the audience? Thank you, Ahmad. It justifies, I started weight training about 4 or 5 months ago, and it's nice to know maybe I've got a good prognosis here.
Yeah, good.
Improved my prognosis anyway.
Yeah, good.
With boxing and weight training.
Yep.
All righty, then we're going to move on to the next to last presentation, and that's by Daniel Sandberg, class of 23. and he's going to be characterizing kidney stones using convolutional neural network. And he was mentored by Dr. David So. Is David here by any chance? Because he mentored, is he?
I am on the call here.
Great, because David was an MSRP not too long ago. And then he came back about a year or two ago after being in California for a bunch of years, and we're so pleased to have him as a mentor. And he just took on, if I had a leftover student, he just took him on no matter what. And I really appreciate the great job he did mentoring. So go ahead and tell us, Daniel, about your project with David.
Thanks for that, Dr. Whitty. And also thank you to Ben for explaining a little bit more about deep learning and artificial intelligence. Our project coincided pretty closely with what Ben was talking about earlier. So if you remember some of the things that he shared, that applies here. So this summer I worked with Dr. Zoe to put together an analysis of CT images of kidney stones to see if we could train a computer to be able to predict the type of kidney stone that a patient had before a procedure to remove that kidney stone. So a couple of words that might help you understand the project a little bit better, because a convolutional neural network kind of sounds convoluted, is computer vision, or is the convolutional neural network. And that's basically where you teach a computer a sequence of images and simplify them until it can start to recognize patterns by itself. And this is a form of computer vision, where you're teaching a computer to recognize visual patterns. And pretty exciting, a few years back, or a little while back, Google actually came out with a whole package that anyone can use. And they can use this to be able to analyze images and put together a convolutional neural network analysis like this. And the last thing that I think might be helpful to understand is what's called brute force. And that sounds a little medieval, but I think one way to picture it is to imagine you're at Subway and you want to find the best sandwich. And so you order every possible combination of sandwiches and you try each one until you find the very best one. And basically what you're doing is you're letting the computer go through and iterate through a bunch of subsequent settings until it finds the optimal setting to be able to do the task that you're trying to train the computer to do. One other thing before we go into our beginning questions that might help you understand the study is that we were using data from what's called the RESCUE database. And these are demographics and clinical data for people who are treated for their kidney stones here in Tucson. And most importantly for us, this data set had preoperative images of the patients before they had any sort of intervention. And then we also had, after they had their kidney stone removed, the analysis of those kidney stones, so we knew which type of kidney stones correlated to which images. And so we were going to be able to use that to train the computer. But with that background, these were some of the questions that we had as we were getting started. We wanted to know what other research had been done in this area and who else was looking at these sorts of questions using these types of tools and what approaches they'd been taking. Our fundamental question was, can we use this convolutional neural network to characterize stone density, stone volume, and especially stone type? We were also interested to find out how would we need to modify TensorFlow to improve those predictions? And to do that, what kind of computer equipment were we going to need to be able to run an analysis like this? And then another question was whether or not we would have enough CT scans, because the computer is recognizing patterns, and it helps if the computer has lots of examples to work from so it can refine its analysis. As we began trying to answer some of these questions, we started looking at some of the research that had been done. And there's a lot of research that's available, but three of the studies that stood out to us were this first one, where they used TensorFlow specifically to be able to characterize digital photographs of kidney stones. But these were kidney stones that had already been removed from patients. And so they had these kidney stones on a table, and they took a picture of them, and they were able to show that the computer could learn to recognize the stone composition just from analyzing those digital photographs. There was another study that used TensorFlow to see if kidney stones were even present on CT images, and compared CT images that didn't have kidney stones to those that did, and was able to train a computer to recognize which ones had kidney stones present. And then the last study that was important was this one that looked at the demographics, the lifestyle, and clinical lab values, basically everything aside from the imaging. And using that data, it was able to predict kidney stone type. Our other question that we've been trying to answer this summer, or the main question we've been trying to answer this summer, is regarding the convolutional neural network to characterize stone density. And the reason that the answer to this is still potentially is because despite continued efforts to be able to get a hold of the images that are a part of the rescue data set, we're still in the process of working with Banner to procure those images for this analysis in the future. In terms of modifications to TensorFlow, we wanted to use a brute force approach, like I explained earlier, because we weren't sure what settings would be the best or optimize the computer to be able to identify the kidney stones. And so we wanted to give the computer a chance to go through and see what it could figure out using a brute force approach. And as we began running some of these analyses, we learned that we needed to have a pretty powerful computer to be able to run this, particularly the graphics card, or the GPU, graphics processing unit, is the most important thing when running an image-based analysis. And there was a study that had about 535 patient scans that they used for their convolutional neural network analysis. So we didn't have quite that many patient scans, but we were wondering if we'd still be able to run this with the number of scans that we had. So what does this look like? TensorFlow can run in Python, which means anyone can download Python and anyone can download TensorFlow, and you could run a process like this on your computer. It just might take a really long time. And so this particular analysis is taken from a tutorial from the TensorFlow website, and I want to use it to demonstrate to you what the data looks like as you, or what the results look like as you're training a computer to do this sort of task. So in this task, we gave a computer two different sets of images and asked it to be able to learn the differences between the two sets of images. And the first time we ran it through, the computer did okay. This blue line shows how the computer did with the results that it trained on. And here on the x-axis, this is how long it took, or the number of times that it tried to learn how to recognize these images. And so over time, the number of errors, or the validation loss, these errors decreased. And so the computer got better at predicting these images based off of what it was learning. The problem is it's kind of like it memorized the answers to the test. And so over time, it got better at predicting the images that it was learning. But when you tested it with a different set of images, it didn't do very well. So one of the things that you can do to improve the computer's ability to differentiate these images is called pre-processing. And this is where you would take the images in the training set and make subtle adjustments to them to give the computer a lot more opportunities to learn. For example, you could rotate the image 5 degrees and then rotate it another 5 degrees and keep doing that to produce more images for the computer to learn on. And when we ran this with additional pre-processing, the computer did a lot better. So it showed that it was able to learn the training set that it was training on, but then when presented with totally novel images, it was also able to do a good job at differentiating those. While we weren't able to get a hold of the images that we wanted to from the rescue data set, like Ben mentioned, there are publicly available data sets. And so we were introduced to this NIH data set that shows different lesions from abdominal CT scans. And there's thousands of images here. And we were working to see, again, to do a proof of concept, whether we could get the computer to predict the number of lesions based on the images that it was analyzing. And when we ran it through, we used this brute force approach, and that's what all these different lines are. This is from different runs. And we found that we weren't able to get the computer to do a very good job differentiating based on the number of lesions. And one reason for this is that we may not have done enough to segregate the images originally based on lesion type, and there may have been too many extraneous images in there which produce noise, preventing the computer from doing a very good job predicting the images based on their lesion type, or their number of lesions. So some of the fringe benefits that came out of trying to put this study together this summer is we were able to collaborate with a lot of really excellent researchers. We joined teams with the Aztec Lab because they had access to a computer that was going to be able to run an analysis like this. And we were also able to connect with Doctors Corellis and Vedantam. And we were able to start working with them. They're in the radiology department, And one of the things that came out of our interaction with them was the suggestion that instead of using TensorFlow, we could also try to use orange data mining, which could incorporate even more of the information contained in the rescue data set. And when that came up, Dr. Zhou had the idea that we might also be able to look at predicting infection stones. And while identifying the type of kidney stone going into a surgery would be very helpful, identifying when a patient has an infection stone would be even more helpful, because infection stones have really negative outcomes for patients, and the patient can end up in the ICU. So some of the remaining questions that we have are, how can researchers get a hold of these images? How can they get access to CT scans to be able to run an analysis on them? We're also interested in still figuring out what are the best parameters to be able to pre-process CT images so that the TensorFlow analysis can produce the best results or the most optimized understanding of differentiating the images. And we're also interested now in what other information is in the medical record that could be used to augment these images analysis to be able to predict infection stones. In the future, we'd love to be able to get these scans from Banner and to be able to use them in an analysis, and potentially use a server where they're able to hold the scans safely so that we don't have to worry about letting PHI out into the open. And we're also interested in the future to incorporate more from this orange data mining analysis to be able to get an even better understanding using more of the information from the rescue data set. I would like to thank Dr. Zhou and also Dr. Whitty and Grace for all the help that they gave me in facilitating this research opportunity this summer, as well as many other people who all helped contribute to putting this together. Does anyone have any questions?
Okay, David, do you want to comment on this separately or want to wait for the next presentation?
I'll just make a quick comment. I mean, I applaud Daniel for having this study idea. I think it's kind of a sexy topic in urology right now. If you can predict some of the stone qualities before you actually take them to the operating room, and actually that can help with counseling and actually taking some of the concerns that we often deal with post-operatively and addressing them pre-operatively, so that to set expectations appropriately. So I think that's a really nice idea. We ran into a little bit of a roadblock with the images, accessing them from Banner, which is why we had to use the public data set and public images. But I think this project has a lot of momentum moving forward. So I'm excited to see what the results are in the future.
Yeah, and you're going through the sequence. I mean, since my adolescence, my family had a lot of professional chess players in it, including Bobby Fischer was in our immediate circle. And many of them got involved in some of the early programming of chess computers. But from the very beginning, they really didn't have any respect for the computer, because it was just memorizing everything that these great chess players were putting into it. And that really continued up until very recently, that chess players do not respect chess computers. But now it seems like they're beginning to learn a little bit, and maybe some of the ideas that you're putting into your project relate to the way we make some of the computers learn like humans. The goal is to learn like a human, right? That is the goal, not to necessarily to be superhuman. So it's kind of interesting to see that progression. But let's go on to the last presentation, that the student that you also mentored, and that is Sai Shah, who's class of 23, and he's going to discuss pericalculus ureteral thickness, and mentored by Dr. Zhou.
All right, can everyone hear me and see my screen? Okay, sounds good. So my name is Sai Shah, and my faculty mentor was also Dr. Zhou from urology. And together we looked at the association of pericalculus ureteral thickness on CT scans and ureteral stent placement at time of surgery. So to start off, I just wanted to give some background information. We've been through our renal block, but kidney stones are crystalline structures, and they can form either in the bladder, the ureter, or in the kidney itself. As a lot of us who maybe have scribed in the ER before or worked in the ER, we know that this, or even had a kidney stone before, we know that they can cause extreme pain, and usually in the flank area. And there are a couple of different locations where kidney stones can get stuck. And as you see on this photo on the right, could be over here in the uretopelvic junction, in the ureter, which is where we were looking at, and here at the uretovesical junction between the bladder and the ureter. Moving forward, if you do have a kidney stone or a ureteral stone and it's not passing on its own, one of the most common surgical procedures that's done is a uretoscopy. A uretoscopy involves the use of a flexible ureteroscope shown here. As you can see, it's curved down, and it also can curve up, and kind of like a finger going like this, with a controller on the end that you would be controlling, to go in and maybe use a laser, depending on which surgery you're doing, or which product you're using, to fragment or dust the stone to make it into smaller pieces for it to pass. Or you could fragment it and then use a basket to go and pull it out right then and there. However, afterwards, sometimes some patients need ureteral stents, which prior to working with Dr. Zoe, I'd only heard of one type of stent, which was the vascular stent. But ureteral stent is what's put in place sometimes after uroscopies to help patients heal and help with the passage of urine from the kidney down to the bladder. Unfortunately, these stents cause a lot of side effects in patients. A lot of patients complain of bladder storage issues, flank pain, and gross hematuria. And up to 80% of patients in this one study said that their quality of life was affected by having an indwelling ureteral stent. So for me, coming into clinical research, being a newbie, something that I've always been interested in is improving patient outcomes. And hearing about something like this that Dr. Zoe clued me into kind of struck me, because I thought that, okay, what if we could find a way to help with this, week or so after patients have uretoscopies, help best prepare for it. And so Dr. Zoe brought this paper to my attention from, it was published earlier this year. It came out of Mount Sinai with two doctors, Dr. Chandoke and Dr. Gupta, and they went and studied this new measurement called the paracalculus ureteral thickness, and studied its predictive value of stone impaction at the time of surgery. And essentially, an impacted stone means that it's blocking the flow of urine in that area, and it can cause hydronephrosis. So looking at this value, thinking about the placement of ureteral stents and the side effects it can cause, Dr. Zoe mentioned that something he was interested in seeing was if this value, this P-cut measurement, could indeed play a role in predicting if a patient was going to get a ureteral stent or not. And from there, a urologist could better counsel his patient, and a patient could be better prepared, considering the fact that sometimes after these surgeries, the pain is so severe that they can't go back to work, which just brings more burden to patients, especially when they're already going through a kidney stone, which just doesn't sound like fun. So this measurement, and this here is an image from one of our own measurements, but it looks at the most widest part of the stone in the ureter, and calculates the thickness there. As you can see here, that's 5.8 millimeters, and then takes the difference of that from the overall width of the ureter, which over here is 10.2 millimeters. And so that measures the P-cut, which came out to 4.4 millimeters here. We also measured the length of the stone, the superior and inferior ureteral thicknesses above and below the stone, and used that data as this original paper found that those values were also predictive of stone impaction at the time of surgery. So our initial question was if P-cut measurement could predict ureteral stent placement at time of surgery, and we hypothesized that it would be able to for patients undergoing uroscopy and laser lithotripsy surgery. So the way that we went about this, a majority of the summer included a lot of data collection for our team, using the RESCUE database, which is a registry for stones and kidney of ureter. Dr. Zoe has been prospectively collecting data into Cerner into a very specific way that allows someone to, or a researcher, for us to go back and be able to input it into REDCap, which is the EDC, the electronic data capture that we used. And from there, I took the time to sit down with Dr. Zoe, and Dr. Zoe explained to me how I could go in and use the PACS CT viewer software to measure these stones and the width around them. And we came to a conclusion on how we were going to measure P-cut. We also had a calculation for surface area that was integrated into REDCap itself. And that helped us get a 3D measurement of the stone as well, which is something the folks at Mount Sinai had done as well. So the progress that we made, a few weeks into collecting our data and for me measuring the stones and the P-cut, we met with Drs. Gupta and Chandoke that I was saying from Mount Sinai. And we talked to them about what we are doing, how we want to expand on their project, and also if they had any suggestions for us as we went about our measuring process. And they did mention to us that they wanted us to make P-cut, or they want P-cut to be as generalizable and standardized as possible. And so the measurements should be horizontal in the superior and inferior ureteral measurements. So that was something I was previously not doing. So after hearing that, I went back and remeasured the CT scans that I had done, or in the particular ones that I had completed at that point. And we even discussed potentially, making a collaboration happen and making a multi-institutional study depending on our results and going from there. So preliminary results so at this point in time, we have a 22 sample size, and the average age here was 53.4 years and a BMI of about 31. And interesting to note that, it was a greater than 1 previous stone historically for the patients that we had in the study. And so breaking down the preliminary data that we have, the average P-cut was 2.67 in the patients who did have a stent either placed or exchanged. And it was 2.54 in those who did not have one placed or removed. And then going further on that, the surface area was 31.02 in the patients who had stents placed or exchanged, and 35.68 in the patients who had one not placed or had it removed. So from here moving forward, we're still in our data collection phase and are going to continue collecting data. We want to know, we wouldn't definitely expand on the current progress that we've made, but we want to know if P-cut can hold predictive value in other outcomes related to kidney stone episodes. There's a lot of variables that are collected in the REDCap system and that we're continuing to collect. And it'll be interesting to see, if this new measurement, this new way of looking at stones prior to operations can predict values or have an association with other patient outcomes. I'm also interested in knowing what value that P-cut needs to bring in order to be recognized or standardized into the urological community. As I mentioned in one of my fringe benefits coming up, but I'm new to urology. I didn't really know about the field prior to med school either, other than that they worked with kidney stones maybe, but I didn't even know they did surgeries. So, moving forward from there, computer-generated P-cut is something that Dr. Zoe brought up and mentioned that, it could be interesting to see if there's a software that could be developed to just automatically measure the P-cut so that the urologist didn't even have to take the time to see it himself or spend as much time double checking the work, which once again could just lead to patients having better mental preparation for their upcoming surgery and could allow urologists to help counsel them better. So as I mentioned before, the fringe benefit of getting exposed to endourology after having minimal background was great this summer. I also had very minimal research experience in the past, so getting clued in and having a mentor who genuinely understood that and is willing to work with us on that was great. We worked in a team environment where, as Dr. Whitty mentioned, we had 2 high school students join us toward the end that are going into their first year of college. And then also I worked with 3 other medical students, including from our class, Daniel. And then finally, I gained really great comfortability now with using the PAC software and CT imaging. And it was kind of just one of those things where it's kind of second nature now. If I'm going in and trying to find a stone, I feel pretty comfortable finding that, which is something I definitely didn't know how to do before. So my references are here. And I just wanted to thank Dr. Zhou again, and then Ava Wong, who's the research coordinator for the Department of Urology and also helped a lot this summer with planning all of this. Any questions?
David, do you want to make a comment on this presentation?
Yeah, so we had a nice conversation with Dr. Gupta at Mount Sinai and Dr. Chandoki, and so their paper is great. It kind of won some awards within the urology community, but it was also limited by the sheer low number of patients enrolled in that study. So while it was prospective, I think there needs to be some work kind of validating that it's actually helpful. So that's why I brought this up with Sai. He's done a great job looking at the CT scans. It takes a long time, and so that's why we still haven't made as huge a progress as we want, but we're still getting there, and I think eventually we're going to have some nice work to show for it.
Okay, well, we finished the first day, and we only have half a day left, and I think these presentations have been absolutely superb. Not only for describing the research, the framing of your questions, but for your understanding of the research process, that it's not going into a lab and closing the door. It's much more than that. You couldn't go into the lab and close too many doors this summer. And you had these collaborations that were national, some of them even international. You had teams that you work with, multi-level teams. You had mentors, different mentors from different specialties. You learned how to write grants, some of you, how to search databases, learn statistics that you weren't exposed to, and get a lot of clinical precocious training, I think, and also the application of many of the things you learned in the basic sciences. So I congratulate you. It's been a remarkable summer. I hope and predict that the next half day is going to be quite as good. I wanted to again alert the medical students that we will include you in the graduation on Friday. We haven't in the past because medical students have ended their programs at different times in submitting their final reports and surveys and things of that sort. But this year it looks like almost everybody is on time, and therefore we'd like you to join the graduation on Friday, which is going to be short. And you can even bring tortillas if you want, because you can throw them up at your own ceilings and so on. Any celebration, anything you want to do, your family and your friends or whatever can join us in on the Zoom. And we will recognize you by name, those of you who've completed everything. And Dr. Francisco Garcia, who you met in one of the seminars, is going to be giving us a very brief celebration. And it shouldn't take more than, I would say, an hour and a half, maximum 2 hours for that graduation. And then I urge you immediately to turn in your additional information to convert your program to a research distinction track. You need only a letter of acceptance by the mentor, your projected timeline, which is flexible and can change, and just so long as it hasn't changed much and it's with the same mentor, anything you do even next week can begin to count toward your time for research distinction track. And also Grace will be sending you the information on abstract submission for the Western Federation of Clinical Research, the Carmel meetings, which are virtual, and I believe that they will still include a published abstract in the Journal of Investigative Medicine. Along the way, I've mentioned some other meetings for the student who worked on melanoma. There's a major melanoma meeting that occurs every 2 years that I'm involved in, and we're very interested in having the students submit to that. And I'm sure the other specialists here, Dr. Zhou, et cetera, they have their own specialty meetings where there'll be abstract submissions, and they'll work with you on getting those in and work with you on manuscripts and so on. And we have a couple of international meetings in lymphology, one in Assisi, Italy in March, and one in Athens, Greece in the fall that I hope to involve some of the students who've worked with us in the time. Okay, Are there any questions you have about the program, the requirements, the graduation?
Dr. Riddy, I have a question. What time is that event on Friday?
It's 10 in the morning.
Okay. And will Grace send out a link for that?
Yeah, and we're not going to be giving you your T-shirts at that time because we have to distribute those to the undergraduates and high school students, some of whom may be leaving. So we can get those to you. We're going to give you a time next week or two where you can pick up your packages and your certificates, etc. Actually, when you go on your residency visits, often the examiner will ask you, what does this Summer Institute on Medical Ignorance, what was that? What did you do for that? What is ignorance? So often that's a topic that the interviews will pick up on.
Okay, thank you.
And you can include the YouTube presentation that you did on your BioSketch also, because it will have a reference to the YouTube channel. All
Dr.
right.
Whit,
Yes.
Where do we find the link to the recorded presentations?
You have that.
I have to upload them to YouTube. So once they are up, I'll let Grace know, and she'll distribute an email with the links to you guys.
We have a YouTube channel. It's got by now several hundred presentations. It's also had hundreds of thousands of hits internationally from hundreds of countries.
But when one uploads a specific link for the
He's going to do a
presentation, yeah, then I can just give you that, and you won't have to wade through all of the different YouTube presentations.
Any other?
Yeah.
Dr. Whitty, can you hear me?
Yes. Oh, Val, you're finally there. I kept calling for you. Did you want to make a comment?
Yes, I do. I just actually really want to commend my student Emily for doing such an amazing job, and she, dabbled into basic science, and I'm just amazed by, coming into something that she had no idea about and really taking it on, and even writing the manuscript for that paper is already written. For her paper is already written, and she did an amazing job, and I'm just so proud of her and all the work she did over the summer. Right.
Thank you, Dr.
That's pretty nice. Anybody else? Any other mentors that I forgot, or students who want to make any comments, or high school students or undergraduates who want to comment? They were required to be here, and I still see their names, so they've stuck with this. We had quite an audience. We had maybe 80 to 90 people on the Zoom, which improves over when we usually do it, when by the end of the day, there are 3 or 4 students, despite the fact that we encourage them to listen to each other. That's what usually ends up by the end of the day. So this is quite a different audience here that we had. And we're going to begin with Wahid Asif, who's the class of 2023. He'll be talking on the effect of obesity on perioperative surgical outcomes in partial nephrectomy. And his mentor is Dr. Ken Batai, who's research assistant professor of urology.
Am I being given the screen share?
You can go ahead and share.
You can go ahead and share. And make sure that all the presentations you have your beginning and ending questions included. So far, we're running a straight streak.
Okay. Can everyone see this?
We cannot, no.
Share. Okay. There we go.
Yes, we can.
Good morning, everyone. My name is Wahid Asif. I'm a second-year medical student, and my mentor for this project was Dr. Ken Batai. He has a PhD in anthropology, and he works in the Department of Urology here at the University of Arizona. So I just wanted to give a little background on why this project came about. Dr. Bataille is currently studying ethnic disparities among kidney cancer patients, specifically among Hispanic and Native American populations in relation to Caucasian populations. In this area, there's very little data addressing kidney cancer in those Hispanic and Native American populations, and there's still a lot of work that needs to be done in the field. Specifically, we see that within Native American and Hispanic populations, we have a higher rate of obesity. And since obesity is a comorbidity for kidney cancer, it's really important for us to understand how obesity is related to the treatment of kidney cancer. So at the beginning of the summer, my fundamental question was whether robotic nephrectomies for patients who are obese and morbidly obese are a safe option. Based on that, we needed to define obesity, and we chose to define obesity as any BMI greater than or equal to 30 kilograms per meter squared. That's typically how obesity is defined everywhere, although I did find in some Asian countries it's defined as 25. So for the most part, it's 30 in the Western Hemisphere, which is what we needed to use. So then the next question is, why is this relevant? Obesity is becoming an epidemic in this country and worldwide. Some kidney cancers are treatable with tumor resection that requires surgery. And as I mentioned earlier, obesity is a comorbidity for kidney cancer. Therefore, more obese patients are undergoing nephrectomies. And then robotic surgeries are on the rise. And I've listed some of the general benefits. There's less blood loss, shorter surgical times, shorter hospital stays. However, a lot of institutions still haven't implemented robotic surgeries yet. It's not necessarily new, but it's something that requires additional training. You have to have the resources. So in the future, we're probably going to see more robotic surgeries. And that is partially why we wanted to know if it's safe within populations that have elevated BMIs. I added this last point. Although we may want to, we cannot assume that robotic surgeries are equally safe for obese and non-obese patients. It seems like common sense that if robotic surgeries are safe within patients with a less than 30 BMI, they would be safe for patients with a greater than 30 BMI. However, as scientists, we have to demonstrate that. We can't just use anecdotal evidence, and so this was part of the project to actually demonstrate it. So at the start of the summer, Dr. Bataille had me do an extensive literature review. He wanted me to find 10 papers that discussed this problem, and I was able to find a few. There isn't that much information because this is kind of new. However, there was one paper within the Canadian Urology Institute Association Journal by Abdullah Nawaj et al. And they did a pretty comprehensive study. They had a population of about 1,800 patients, and their conclusion was that in robotic partial nephrectomy, obesity was not associated with increased complications and was not an independent predictor of operating time or loss. So they used these two metrics to determine if a surgery was predictably dangerous or not, which is operating time and blood loss. And there are multiple variables that can be used. We also ended up using blood loss as our predictor, but there's other ones that can be used, such as ischemia time and so on. So this is something that I grappled with the beginning part of the summer. And I just wanted to talk a little bit about this. Why ask a question that has already been answered? And I questioned Dr. Bataille about this multiple times because I found literature that had already answered the question we were asking. And so why should we put our resources and time into something that may already have an answer? And he gave me some really good insight. He mentioned to me that science can not only be concerned with developing new ideas. And he said, although it's exciting to ask new questions and be involved in new discoveries, it is important for scientists to also question old truths and continue to prove them or possibly disprove them. So he asked me to try to bring a new angle to this already answered question. And also, if science is done right, for every question answered, multiple new questions should arise. So our new angle was, does obesity lead to more post-surgical complications in robotic nephrectomies? So this is something that actually hasn't been answered. There aren't any papers that have published this extensively. And so we will plan to use the Clavian-Dindo classification to categorize post-surgical complications. It's a classification that's used by surgeons. It's very useful because it allows easy grading. So it's every post-surgical complication is assigned a grade between 1 and 5, with 5 being the worst and 1 being the least. And it's still very controversial because of the subjective nature in determining the grade. So for example, if a patient on post-surgical day 1 ends up with tachycardia, some surgeons may classify that as a grade 1, while other surgeons may not classify it as a post-surgical complication at all. And so generally surgeons are more in agreement with higher grades. So with 5 being mortality, everybody is in agreement that that would be a 5, whereas less complicated post-surgical complications there would be some controversy. So we weren't able to collect enough data to present that today, but we hope to refine the data before presenting it in the future. So the method and analysis, Dr. Bataille in his lab had already created a database in REDCap. It was quite extensive. We did a retrospective review of U of A patients who underwent nephrectomies, both open and robotic, between 2010 and 2020. We added demographics, medical history, clinical history, and surgical information. And the main variable analyzed for this particular study was estimated blood loss. So that's how we determined if a surgery could potentially be dangerous, and type of nephrectomy, open versus robotic. And open nephrectomy is the classical type of nephrectomy between patients with BMI less than 30 versus 30. This particular chart is a little complicated, so just bear with me. So we took the estimated blood loss between, we compared the robotic approach with patients who had less than 30 BMI versus greater than 30, and then we did we compared the open approach with less than 30 and greater than 30. And we used 150 ml as the cut point. So anything greater than 150 ml was considered extensive blood loss. Anything less than 150 was considered within normal range. And so we found that within the robotic approach, patients with elevated BMIs tended to have a statistically significantly greater amount of blood loss than those with less than 30 BMI, which seemed reasonable. However, within the open approach, we found that there was no statistically significant difference in blood loss between patients with elevated BMIs versus normal BMIs. And this was kind of astonishing because we would assume that you would have a greater blood loss within the population of patients who have elevated BMI. And so the next question was, are open nephrectomies safer for obese patients? And so we had to do a comparison between the open nephrectomy versus the robotic nephrectomy in estimated blood loss. And we found patients who have open nephrectomies tend to have larger estimated blood loss. However, the p-value was 0.16 and therefore not statistically significant. This was most likely due to a small sample size, and we hope to increase our sample size to get a more accurate result. So the questions that remain: is robotic nephrectomy a safe option in obese Hispanic Native American patients? This question, as I mentioned earlier, has not been answered in any meaningful way. We see an opportunity to analyze this question because of the patient population in Arizona. I also, we wanted to use a metric of operating times to determine if a surgery had the potential to have complications. So I've been collecting data on that and hope to analyze that soon. And one of the questions that arose from my research was a paradox where obese patients tend to have lower tumor stages than, lower tumor grades than non-obese patients. And that seemed counterintuitive. So this is an example of a question that arose from a question, and that's for someone else to take on. And then finally, are there better ways to measure obesity? Something suggested in one of the papers was measuring the thickness of abdominal adipose tissue. We weren't able to do that because we're doing a retroactive study, and that wasn't one of the metrics that was collected, but in the future, someone might want to take on that particular measurement. And other fringe benefits over the summer, I learned how to research and read medical journals. That was no easy task, as I'm sure everyone can attest to. It's not easy reading these journals, especially doing research and finding them. And so that was, I learned a lot in that process. I also became very familiar with Cerner and EPIC. And most importantly, I became part of a lab that has a long-term project and has taken me in with open arms. If there's any questions or comments.
Any questions? I see that Dr. Bataille is logged in. Dr. Bataille, do you want to make a comment?
Yes, sure. I'd like to say thank you for, Adam's hard work during the summer. I think this is a great data point that we can further explore the impact of obesity on the surgical disparities. So I'm happy to have this data, preliminary data yet produced during the summer, and I'm happy he can continue on this project, and it's been great. I just want to say thank you.
Okay, thank you, Dr. Bataille, for mentoring our students each summer. Are there any other questions of Wahid? If not, thank you, Wahid, and for thinking about your questioning and the point about questions being answered, but not necessarily being answered correctly, and pursuing them nonetheless. Okay, we're going to go on to our next presenter, and that's Diego Jesus Urbina, and he's class of 23, and he studied understanding patients' perspectives for brachial basilic fistula. And he worked with Dr. Wei Tan, who's Associate Professor of Surgery in the Vascular Division.
Hi, can you guys hear me? All right, so I'm sorry, my internet is kind of spotty, so if I kind of just stop sharing or you guys can hear me, just let me know. So my name is Diego Urbina, and my MSc project is on understanding patients' perspectives for the brachial basilic fistula. And my mentor was Dr. Tan from the Vascular Surgery Department here at the University of Arizona. So when we talk about fistulas, we're talking about vascular access for hemodialysis treatment for patients with end-stage renal disease, which is the final stage of our chronic kidney disease. And research and advancement in end-stage renal disease and treatment is important because its prevalence has actually steadily rising in the United States and will continue to do so as our elderly population increases. So there are three types of vascular access. There is the central venous catheter, the arteriovenous graft, and the arteriovenous fistula. And the fistula is the preferred method, and it's made through an anastomosis between the artery and the vein as well. It is superior to central venous catheter and the graft due to its lower complications, such as lower thrombosis and infection, and also comes at a lower cost. So it's more cost effective. And there's also three types of arteriovenous fistulas. There's the radiocephalic, which is a primary option, the brachiocephalic, which is secondary option, and the brachiobasilic, which is a tertiary option. The radiocephalic fistula has been referred in the past as the preferred method, but as ESRD population shifts to patients with less reliable vessels, both secondary and tertiary options actually have started to become more common. So our research focuses on this tertiary option, the brachiobasilic arteriovenous fistula, which is created on patients with non-viable cephalic veins after exhausting the primary and secondary option. And it has the same patency and reliability as the brachiocephalic fistula, but it's considered a tertiary option because it creates a large incision and it's a more complex surgery. And both of these things are due because the basilic vein is deeper in the arm, so it must be transplanted or elevated for the fistula to be able to work. And you can see actually that in the picture on the right. Now, the brachiobasilic fistula, the surgeon can create it either in a one-stage or a two-stage technique. The one-stage surgery, which you can see on the left of the screen, consists of performing the anastomosis and then the elevation of transposition, all in one surgery through a large incision in the upper arm. While in the two-stage surgery, which is on the right side of the screen, you have the first procedure to create an anastomosis through a small incision, and then the patient will come back 4 to 8 weeks later for a second procedure to elevate or transpose the basilic vein. And at the end, both incisions are actually comparable in size. So the two different techniques actually have been compared in several studies, such a recent study by Dr. Tan, you can see on the screen. And the studies pretty much show the results in both techniques, the results, well, actually, the fistula center outcomes, such as patency and fistula-related complications, are actually very similar to each other. And as our main focus to compare the two techniques, we really have to ask what is different between our main questions and our research and what actually other studies have already researched. And well, is that those studies have focused the research on clinical outcomes of the fistula, but they have not looked into the patient's perspective. So our main questions are really like, what technique do patients prefer between the two, two techniques, the one-stage and the two-stage, and what are the difference in patient-centered outcomes, such as quality of life, between these two different techniques. So like we all know that trying to answer one question or two questions actually brings a lot more questions, and that's what happened this summer. So if you start looking at those two questions, you start looking at what is the current decision making that we have? What is the evidence comparing the two techniques right now? What is important to look at outcomes through like a patient-centered care lens? And what are the tools that we will be using in our research, moving forward? So one of the things I did through the summer was to engage in trying to answer the secondary questions through literature reviews and trying to understand the background of my project a little bit better. And I started looking at the current method for selecting between the one-stage and the two-stage. And the current selection relies solely on surgeon's preference. And that could be in part because studies have only looked in clinical outcomes of the fistula, and for the most part, the results have been comparable between the two techniques. And even studies that have shown favorable results, say for the two-stage technique, they did not look into the consequences of having a central venous catheter for a longer period of time, which is, in the two-stage technique, you have it longer because you have that 6 to 8 week period of waiting. And that itself carries the risk of like infection, bacteremia, and infection-related hospitalization. So again, no study has really focused on patient-centered outcomes. And one thing is that patient-centered outcomes is important because understanding what matters most for a patient allows for a shared decision process between surgeon and patient, which is key in patient-centered care. So this is crucial in vascular access, since studies show that the perspective of patients regarding the satisfaction and complications in the access itself is very different from the physicians. And again, also because patient-centered care evidence suggests and indicates that this approach improves the quality of care in all types of patient groups. But to be able to actually look into, say, quality of life or any patient-reported outcomes, we had to use a tool to be able to measure that. And what we looking to use is the patient-reported outcome measurement information system, which is PROMIS for short. And it's a tool for health-related quality of life measures. And this will be, if we use this first time, the tool is used in vascular access, but has been successful in other studies. And this tool is meant to be more adequate than the current tools used to look into quality of life for vascular access as well as end-stage renal disease, which can be difficult to navigate and actually a bit lengthy for participants. So there's still many questions even after the literature review that we need to answer. And mostly they cannot be answered because there's no literature about it, and it requires for us to move forward with the trials we have in mind. And these questions range from the patient's perspective and preference between two techniques to can the PROMIS tool be actually reliable for quality of life measures in the accesses. So that's where our next steps are going to be. Our next steps to be able to answer this question is to conduct a non-randomized study, which will be conducted with participants in 2 centers here in Tucson, Arizona. And we'll start with AIM-1, which will recruit patients for interviews 6 months after the creation of the fistula, asking about like challenges, experiences, and preferences. And this is to try to understand patients' perspective and preferences regarding the two techniques. We believe that patients will prefer the one-stage approach because it has less procedures in itself, and also because they have less time with catheter as well. And the second part of this non-randomized study is our AIM-2, in which patients will complete the PROMIS at baseline, 6 months, and 12 months following the creation of the fistula to compare the patient's reported outcomes between the two techniques. And our hypothesis is that the patient-reported outcomes will be affected by either technique and also the duration of the catheter dependency. So that was like our goal also this summer, to start with AIM-1, hopefully finish it and keep going. But due to COVID-19, we had to move the data start on AIM-1, and we actually will have to start it later on as soon as it's safe to do so. So I kind of skipped a step, and I want to start to write a protocol for a future pilot study. And this is a randomized multi-center pilot study that will come after our non-randomized trial. So we start working on the protocol because publishing a protocol creates an early scientific record, brings transparency to the research, and also prevents research duplication. And to me, this was a really good learning experience for me, because it was the first time that I worked on something that it would potentially be published. And just working through, steps for that, it taught me a lot throughout the summer. So our end goal is to use the prominent data from the non-randomized study, as well as the protocol that I wrote, to conduct a multi-center randomized pilot study, which is a randomized study with participants that will be recruited from 6 centers across the United States, and also to design a pragmatic clinical trial. And what we hope to do is to bring more knowledge and an optimal surgical technique for the brachiobasilic fistula, and shifting from the current decision method that is solely on surgeon's preference to a more physician-patient shared decision method that aligns better with a patient-centered care. So I want to thank you all for listening. I want a special thanks to Dr. Tan for being my PI and also helping me a lot this summer as a mentor. And if anybody have any questions, I'll take them.
Is Dr. Tan there by any chance, or is he on call?
No, he had clinic today, so he was not able to be here. I'm sorry.
Okay. Again, this is another example of these projects not being a student-teacher relationship, but a real collaboration and a team effort, and going forward with the team with RDT. And I think that's really a significant thing. These aren't just summer projects. And you're not just students working in a lab or a clinic. Okay, thank you, Diego. And I also want to compliment you publicly on your extremely detailed logs. Sometimes when I saw them, I kind of cringed because I'm trying to go through what amounts to over 80 logs with each one. It's kind of Herculean task, but it was a pleasure looking at how you dissected your questioning process, how you analyzed it, and how it apparently influenced you, and also the way the project moved forward.
Thank you.
Okay, and that in no way says that the other logs weren't great too. It's just these were very voluminous logs, I would say. Our next presenter is Kayla Rose Anderson, class of 23, and she worked on the neuropharmacology of affective touch in primates, and she worked with Caitlin Gothard, who's a professor in physiology and neuroscience. I don't know if Caitlin is here.
Yeah, she's here.
Oh, great. Okay, then go ahead, Kayla Rose.
All right, so my name is Rose, and so our lab for many, many years has been focusing on social interactions, and there's so many different avenues of this, and we found our perfect animal model for these kinds of questions in the rhesus macaque. So just to give you guys a very broad bit of background in what these monkeys do and why they're a good model for us, here's a few examples of monkeys that are in a wildlife reserve. And I'm going to start with this video on the left. Just pay some close attention to what you think is going on here. So here we see our dominant lady here. She's given some grief over here to our little monkey who's giving called a fear grimace. So this is an appeasing gesture whilst our dominant animal is threatening that one. And so here we can see some close-ups of these. So this guy is just chewing his biscuits and sees somebody enter his territory and he says, "Hey, get the heck out of here." Whereas this guy is a little more subordinate than the animal that we just saw. He's sitting around eating his biscuits when he sees somebody come up and probably threaten him, and he says, "Uh-oh, I'm getting out of here. Don't mind me, I'm nobody, I'm not gonna bother you." And so these kind of interactions are what make this animal model perfect for the questions that we have. And for the past few years, I personally have been studying the affective touch realm, particularly because these monkeys are social groomers. So with grooming in a monkey, it's more complex than just picking out twigs or parasites. They groom much more than is necessary for hygienic need. So what we see in these interactions are monkeys building social bonds. Through grooming and the time that one spends grooming, it increases the likelihood that these monkeys will come to another monkey's defense when they are in trouble. And we also see that it's an intensely relaxing experience. So you see this guy here is in the monkey bliss realm, where he's just super happy that this other monkey is going through his fur and providing that kind of swish and pick kind of groom style that just emulates these macaques. And so to start this summer, we wanted a project that built off of our previous research looking at the neurophysiology of affective touch and how this induces brain states concordant with our autonomic state. So how relaxed we are versus how attentive we are. And so we had these questions to start with to move from the neurophysiology realm into the neurochemical realm and see what's going on with the enkephalins in the system, what's happening with our just dopamine, serotonin, all these other neurotransmitters, what's going on during an affective touch experiment. So the plan was from March to May, I would go in and start forming trusting social bonds with the subject monkeys that we were going to have. And thanks COVID, that didn't happen. So unfortunately, we've had to redirect the social interaction that we've been looking at with the neurochemical baseline. So instead of going into affective touch, which we will get to once we can build those trusting social bonds with these monkeys, it's kind of important to make sure we have clean data for the affective touch, because otherwise it would feel like, you know, somebody walking up and giving you a hug on the street. You know, it's that kind of weird feeling like I'm not expecting you to be touching me in this way without that touch, that trusting social bond. So we'll get there, but other avenues that we're looking at for this summer, we also in the lab have been looking at how subjects, monkeys, are viewing interactions with another monkey using video software. So here we have looking behavior. So we see a monkey and we're tracking the different areas on the screen in which the monkey looks. And so this gives us good information about the social hierarchy, how the monkey feels about the dominance or subordinance of another monkey. And so here on the right, I'm going to show you this video that includes each colored dot is a trial of a monkey watching this video. The monkey's going to be giving a threatening facial expression, and you'll see how the subject monkey, as you track all these little dots, what they find important at certain aspects of the video and what they do in response to some things. So we'll start. So we see a lot of focus on the eyes. Here, when to open the mouth, or looking at the mouth. And then here we have a boom. If you see the eyes flash to the right. That is what we call gaze following. Pay really close attention again. We start here at the monkey, and when we're following, what is that monkey looking at? There's something about the interaction that is pulling the monkey in and sharing attention with, okay, that monkey thinks that this is dominant. This dominant monkey thinks that something is important on this side of the screen. I need to know what that is. So I'm going to flash over and follow what they're looking at. So we're having a shared social interaction here. So what this shows us, so we had a gamut of questions that we can look at the neurochemical realm of these kinds of situations. So not trying to read through all these questions, we have a bunch of them, but the main idea is that we're looking for dopamine, serotonin, prolactin, because prolactin is inhibited by dopamine. So when we see lower amounts of dopamine, we're expecting to see higher amounts of prolactin, and all the autonomic effects of these social interactions as well. And then a particularly pertinent thing to what we're doing in society right now is looking at this social isolation aspect. So we've all been in quarantine for months, and what is the autonomic effect of that kind of social stress? When you're separated from your best friends, when you're separated in some situations, like when your spouse might be in the military and they have to go overseas, and now you're separated for months from the one person that you love and that provides that kind of social support to you. How does that influence your day-to-day life, and how does that influence things like the pain threshold? So that's what we're looking at. And of course, in this summer with COVID, we had to start essentially from ground zero with building up the lab to be able to do these neurochemical experiments. So that's what I've spent most of the first month of summer on, is just putting the lab together. So we had a new experimental control software that our lab is switching over. So we had to learn that new system and then figure out how that can interface with all the other equipment that we have to put together. And so here we have our autonomics that we had to put together as well. So we're going to be measuring the heart rate of the animal using the EKG, the respiratory rate using either a pediatric thermistor, which is a little temperature gauge that just sits in the nostril and it measures the difference of temperature between the room and what's coming out in the breath. Or we're using an EMG of the diaphragm area, so we can measure how much the diaphragm is contracting and get that respiratory rate. And then we also are measuring skin conductance, which Christina talked about a little bit yesterday with her sweat study, is that the skin of the palm has sweat glands that are innervated specifically by the sympathetic nervous system. And so this is going to help us figure out the components of the sympathetic versus parasympathetic activation at any particular time in our experiment. And then here on the right, this is the camera that we use that's going to help us with figuring out what the monkey's looking at on the screen. So it gives us both the X and Y axis location of what the pupil is looking at, and then it's also measuring the diameter of the pupil, which is another autonomic measure. And so through what the monkey is looking at, the monkey is able to interact with the video on the screen, and he's able to complete various tasks that we're asking of them. So here's a good example of the kind of data that we get from these systems. So EKG, most people have seen before, is respiratory rate, just in and out, and we can get our rate from that. Here we have the data that we get from the eye tracker. So based on the level, we can see looking more to the right of the screen versus more to the left of the screen, and then more to the top of the screen than the bottom of the screen. And so from that, we can calculate on an axis what the monkey's looking at. And then our pupil diameter as well, just kind of going up and down. And then these nice long, they're going to infinity responses when our camera loses track of the pupil. So that's when you just close your eye really quickly. So that gives us an idea of when the monkey is blinking in response to the social event. And then the other thing that I've been working on this summer is we had our monkeys essentially at ground zero as well with regards to what kind of tasks they're able to do. So I've been working with these two female rhesus macaques, and they are pair bonded with each other. So one thing that we wanted to do was make sure that we didn't train the monkeys out of being separated from each other. And we want to make sure that that's something that we're actually measuring. So I've been taking both monkeys to the lab together and training both of them at the same time using the positive reinforcement and shaping techniques. And so what this means is that step by step, the monkeys become more and more comfortable with general things like the lights in a lab or the room or computers. Like these are things that are incredibly elemental to us, but to a monkey that's a wild animal, anything new can be a little scary sometimes. And so we want to make sure that the monkey knows that there's nothing that we're going to be asking them to do that's going to be in any way a stressful event or something that the monkey can't tolerate. And so we've successfully trained them so far on that EKG respiratory rate apparatus. They're still learning our skin conductance because that's a little bit more of a stepwise process to get our monkeys comfortable with that. And then they've also been learning how to look at a screen. So here, this is an example of the kinds of things we're going to be showing them, which I'm going to go into that task in a little bit. And so the monkey's now able to start interacting with the screen and letting us know what they're thinking with what they're looking at. And so finally, with these rhesus macaques, we also needed the way to measure the CSF. And so we've designed this 3-stage implant. So stage 1 was complete back in the beginning of the year, which was just a cranial prosthesis. So what that means, here I'm going to show you a 3D model from the engineering company that we're working with, where we went and we've segmented MRIs of these monkeys to get the precise skull shape of each individual monkey. And then they've machined out a prosthesis that exactly fits onto every single monkey. And this provides us a base for what we can attach various other implants to make sure that our implants are secure and that the monkey doesn't have very many things to worry about. After this first surgery is done, we then attached our head stabilization implant. So this is very important in training because we need to make sure that the monkey is looking at the same spot at the screen, that our origin is still 0 in order to do this X and Y axis plotting. So here we have just a little plastic topper that we can use to help stabilize the head. That way we know which way the monkey's looking and we have a good baseline. And then this summer, so that we put in June for both these monkeys. And so we've also finished up the design of our CSF implant, which now the engineering company we're working with has to finish machining. And so as soon as that's done, we're going to put that on. And so that will give us access to the CSF. And essentially all that we have to do is take off that head stabilization implant and put the new one on. And so other aspects of the experiment that we've done this summer is making sure that we can detect the things that we want to detect and how we're going to be doing that. And so we're working with a lab in the chemistry department. And so here we saw a few examples of this yesterday with the liquid chromatography and mass spec, where we can determine what the concentrations of these various chemicals are. So here we have an example of a monkey. So here's the standard, and then we have an example of a CSF that we withdrew from a previous monkey in our lab. And so we can see that we are, in fact, detecting the kinds of things that we want to find. So about the task that we've designed for these monkeys to do, to look at simulated hierarchy, we put together a simulated set of monkeys that have certain facial expressions that they've made on camera. And what we're doing is we're putting them together in a way that they're looking at each other, and then our monkey is watching that interaction from the outside. And so what we're looking at, we have these two monkeys next to each other who are having some kind of social interaction, and we're going to measure based on looking time whether or not the monkey is understanding this hierarchy and how just what they seem to find important about it. So here we can see our alpha monkey versus our gamma monkey. We only have them in pairwise interactions, and so our monkey sees an interaction between these two guys, and based on what they're looking at, we can see what the monkey finds important. And so in humans, we've seen that monkeys, or that we tend to look longer at subjects that we find to be higher on the social hierarchy. And so we've had some very preliminary data from another parallel experiment in a male monkey that has shown this to be consistent in the monkey. So here we have the 4 monkeys in the video, and we can see a nice trend in that the monkey is paying much more attention to these 2 alpha and beta monkeys than he is to the gamma or omega monkey. And so this helps us realize that we're in the right track. It's definitely very preliminary data that we need to look at in these 2 females as well to make sure that this holds up in them. So the next aspect of the experiment after we do that we want to test is this aspect of what happens when my social status changes. So when I do something that's incredibly embarrassing and everybody's laughing at me, what is the effect of that? Versus when I do something really, really well and now everybody's admiring me, and the people that that I might view as above me in the social hierarchy have kind of lifted me up. So what is the effect of that kind of falling or rising within the social hierarchy? So when our monkey is better at understanding the dominance scheme of these monkeys, what we're going to do is have them start directing the facial expressions at the viewing monkey. So now, if I imagine my alpha and beta monkeys are both threatening me, while my gamma and omega monkeys are trying to appease or show me that they're not a threat, then I can kind of figure out that my social status is about here. That, okay, I'm not the highest, but I'm also not the lowest, so I'm pretty comfortable sitting right here in the middle. But now all of a sudden, my gamma monkey starts threatening me. And what is the response to that? Because now I've fallen, and now I'm much lower in the hierarchy than I was to start with. So that's another aspect of what we're looking at. So a lot of training has happened this summer, a lot of building practical things. And so we still have all of our beginning questions remaining, but we're also really emphasizing now, instead of affective touch, because of the provisos of needing that trusting social relationship, we've redirected our emphasis on the simulated hierarchy and looking at that social stress, such like temporary separation from a bonded partner. And then we're also adding in more aspects of trying to find a causal relationship between them. So not just correlating the neurochemistry, but if we block certain receptors on our prolactin neurons that release the prolactin, what is the effect of that? And do we mitigate the social changes that we see, or the change in pain threshold that we can see in social stress? So to answer these questions, we just need to keep going with our experiment like everybody else. And so here's a good outline of what we intend to do. So obviously this is a years-long experiment and possibly a few grants involved here, but I'm hoping for at least my project, we can get past the first 2 or 3 levels and see what happens. So some other fringe benefits of the study. So this is one of the first examples of being able to harvest minute amounts of CSF from an awake behaving monkey. Normally you'd have to anesthetize and do a lumbar puncture, and that would just completely throw off any neurochemistry that you expect to see. So what we're looking for is just basic methods that this idea is going to work. And then we're also, now that we have access to CSF at, moment to moment, we can see what the actual drug distribution of very commonly administered drugs to these monkeys, things like buprenorphine and diphenhydramine and Benadryl and NSAIDs, things like acetaminophen or ibuprofen, things like that, that we don't have any real data of what this actually looks like. We have some ideas, and we have the plasma, of course, we can measure blood concentration, but what is the amount that's actually getting into the brain? And so that's like a side experiment that we can get off of this technique. So with that, I'd like to thank the team. It's a very large team, but for me this summer, especially need to thank Dr. Gotthard, and Derek and Blake have been on my team here. Derek and I have been doing most of the training and building together, and then Blake is our associate in the chemistry lab who's put a lot of effort into putting the chemical analysis together, as well as doing a lot of our programming for the task that we're working on. And then, of course, Gabe, Lizzie, and Tess for their parallel experiment with the male monkey, and everybody else on the screen for all of the hard work that they have to put into decoding exactly what the monkey's looking at and ethogramming those videos and finding frame by frame what the monkey's looking at. So thanks to them, and I'll open for questions.
Okay, well, we're running late. I did give you a little extra time for that very complicated project. And is Caitlin, do you want to make a comment? Dr. Gotthard?
Yes, Rose has been working in our lab before she went to medical school. She's incredibly familiar with this. This is a very complicated basic science project, which I believe has a lot of translational potential, as she has pointed out. And I'm delighted that she was here. I would like to steal her from medical school and keep her in the laboratory because she's extraordinary. She's a go-getter, she's a doer, she's not intimidated by anything, whether this is a complicated theoretical issue or, taking PVC pipes and sewing them off and writing code. So it was an excellent experience. I'm hoping that we're gonna be able to keep her involved in this project, because a lot of the good things that are going to come out of this is to her merit and to her credit.
Been going now just for 25.
Yeah, and we want to keep her in medicine, so we have a great physician scientist who can bring this and really translate this into patient
yes, I know.
applications. So keep together on all of that. Yes, I know you're a physician scientist yourself. Okay, so we will have to move on. We're a little behind, but we have a short program this morning. Our next presenter is Nicole Lee Holly. She's class of 23, and she's going to talk on the efficacy and stability of chronically implanted intramuscular electrodes. And she worked with Dr. Andrew Fugelsang, who's professor in the physiology department.
Okay, hold on. All right. Hi, so I'm Nicole Hawley, and like was just mentioned, I worked on the efficacy and long-term stability of high-density intramuscular electrodes for functional electric stimulation, and the whole goal of this is to be able to reanimate tissues. But to do that in person, we needed to test it in an experimental model first. And like with Rose's project, we are also using rhesus macaque monkeys. However, it's not a behavioral experiment, so you won't get to see a bunch of cute videos like in hers. But what we did do is we designed an implant system using 60 electrodes. 2 electrodes go to each muscle, so we're implanting 30 muscles of the upper arm of a rhesus macaque. So I've been in this lab for a couple of years now, and we've gone through a few iterations of this. And this summer we are going to start a new one. And of course, because of COVID, that got pushed back a little bit. But some background on what we've done before was an implant using one main surgery. It was about 12 hours. And we implanted the head encapsulation, which you can see right here, and tunneled all the electrodes subcutaneously, and they go to their target sites where they get implanted. And part of this method of implanting the electrodes is using this implantation like plunger tool. So we're able to put the electrode into this cannula here. This gives us a good way to determine where we're going to be implanting the electrode in the muscle. The tip of this is you're able to stimulate through it, so we can find out exactly where we are implanting it, what the like if the amount of current that we put in will generate a response that we want in the muscle, and then we can control the depth of the implantation using the plunger. So we're able to get some preliminary input being the current and output being the force generated via this method. So that was our first implantation, and once they recovered from that, we started testing the stability by anesthetizing the animal, securing them to this infant car seat, and putting their arm in this 6 degree of force transducer, which you can see here and here. And we're able to stimulate through the connector at the top of the head, the external connector, and elicit a muscle response that gets recorded via this transducer. So our goal was to figure out the minimum threshold needed at 5 and 8 weeks is when we did this in the previous experiments, so to elicit a muscle response. And so this is what we saw. So we have our day 0, which was based on observation and not with the force transducer, and the minimum current was about, on average, 1.5 milliamps. And at week 5 and week 8, you see that there is a significant difference from the first day, but it still stays relatively stable over time. So overall, we were happy with these preliminary results. However, we did have some problems. One being that some of the leads of these wires were rejected, which you can see in this picture. Is coming through the skin, and that's not good for something that needs to be long-term. The second problem, and what ultimately was the cause of ending our experiments on these animals early, was that we got infections at the site of the skull implant. So this original skull implant that we used dental cement and bone screws and was very large and bulky, and the infections that developed there required us to euthanize the animals. So we needed to kind of come up with some plans to better mitigate these problems. And this brings us to the questions that we began with for the summer. So we wanted to know what mediates the rejection of the implants, how we can minimize the migration of the electrodes. Part of minimizing that migration is there's an immune response that forms around the electrodes, and it forms an encapsulation tissue. So we want to know when that forms, because that acts to functionally stabilize the electrodes. And then we came up with a new surgical method that I'll describe a little bit later, and we wanted to know what some of those benefits were. And then we wanted to better know how to test that input-output stability over time. So some of the progress we made, a lot of my work this summer was gathering papers, going through them, and trying to figure out what work other people have done on FES systems. And that really helped us figure out what we can do to help minimize migration. So as I said before, the encapsulation tissue acts to stabilize the implant. And in the papers that I read this summer, that can form as early as 3 days to 8 weeks. So it's a very large time frame, but some of the things it depends on is micro movement and the number of angles of the implant. So is it completely smooth? Is there anything coming off of it that helps stabilize it? So for us, one of the ways we're gonna minimize the micro movement is to immobilize the animal's limb for a week after surgery to allow for encapsulation tissue to form. But also on our electrodes themselves, we have crimped them to the wire so that there is added texture around the head of the electrode. And that adds a place for this fibrous tissue, for this encapsulation tissue to kind of latch onto and really work to stabilize it in place. So some of the benefits of this new surgical method, one of the things that we know now, and we won't have to wait to see, is that instead of one 12-hour surgery, it's broken up into 2 surgeries. We do one to implant the skull plate, and then another to add all the electrodes and implant the muscles. And so that breaks it up into about a 2 to 3 hour surgery and about an 8-hour surgery. And standing and working for 12 hours is really hard. So being able to split it up and have 2 more manageable surgeries will allow us to take more care in every process and not feel like we're racing against the clock. There's still some other things that we will find out about the benefits as we go, just with time after these surgeries, but we do know that that one is a big help to the surgical team. And then lastly, in these papers, I found a lot of information about how others were testing input-output stability. So in our previous experiment, we were only testing long-term. We tested it when we implanted at week 5, at week 8, and we would have kept going if we didn't run into problems. But one of the other things that we saw that we could do is test short-term, so within trial. So the monkey's anesthetized, put in that contraption, we do the stimulation, and in the same trial day, we reposition the monkey, put the monkey's arm back into that force transducer after moving it around, and see if there's still the same relative input-output stability. That will give us an idea of any muscle or movement of the electrode relative to the muscle in the short term, because that's just as important as long term. But one of the questions that rises with that is, what's the variability of the input-output based on the intrinsic tension length relationship of muscle? So that's something we'd have to quantify, because if we're repositioning the arm, we could, it would be very difficult to put it back at the exact same angle. So for that, you would do something like, if you're testing the electrodes in the brachialis muscle, now you put the angle of the elbow joint at 70 degrees, 90 degrees, and 110 degrees, and then you get an idea of how the force generation will change with the angle of the joint. Some other fringe benefits. So I jumped into this experiment a couple years ago, but they had already gone through what are the different approaches to doing FES, and I knew about them, but I wasn't that educated. So because I was going through and doing this literature review, I got to learn a lot more about cuff electrodes, which are electrodes that wrap around the perimeter of a nerve proximal to where it inserts into the muscle, and epimysial electrodes, which are sutured onto the belly of the muscle. And these will be really important things to know when I go to write a manuscript, because it'll allow me to justify why we made the choices that we did. Another thing was, because I was reading so many papers this summer, I had so much practice presenting these papers to the people in the lab, and it was a weekly thing instead of a monthly or every few months. So that was really valuable practice for me. So the really exciting thing was that 2 days ago, we got to do our first part of the surgery on one of the new animals. And so this is the implantation of the skull plate. And so I'll run you through basically what happens in the surgery. So we were able to trace here, the inner circle is the circumference of the implant, and then the outer is the line that we cut along. And here you can see that we've pulled back the skin flap. We left the posterior portion intact. We made 2 incisions along the temporalis muscle where it inserts into the skull, and removed all the periosteum so that this implant, which is modeled after the own animal's skull made specifically for him, fits like perfectly up against the skull. And we hope, and we will be able to see what happens as time goes on, but we hope that this will minimize the risk of infection at the skull plate, because there's no room between the implant and the skull, and it's a lot less bulky. We're not using the dental cement. So there's a lot of things that make us hopeful that we won't run into the same problems. So once we had the placement correct, then we used a bone drill and bone screws to secure it down into place. And it gets sutured up very nicely until we go in for the second surgery. And the second surgery, what will happen is we'll place the interface on top of the skull plate here. There will be a cap so that's protected from the animal, but that we will still have access to the connectors. The wires will get tunneled through this divot in the plate and go subcutaneously, same way as our other surgery. And this is kind of to illustrate that this is on a cadaver animal. But these colored lines represent the wires. They will all be tunneled under the skin and go to their muscle targets. So that surgery will be coming up. So the questions that remain. When we did the drilling for the bone screws to secure the head plate, we drilled perpendicular to the skull, but there were angles. It was angled inwards on the implant, so we needed to find a way to standardize the angle needed for the bone drilling. We want to know how the surface of the skull implant will hold up between the first and the second surgery. There'll be about a month where the tissue is over it, and so we hope that it'll be easy to go back in and clean it up and move on to the second part of the surgery. And then we also need to know how long we'll have to test the stability to claim that the implant is stable long term, and this will depend on the degree of stability. So all these other papers that I read with different ways of doing FES, they had some degree of stability, and the less degree of, or the less changes that you have, the shorter we'll be able to test for. If there's a little more variability, then I'll take a little longer. But going into the future, so we have another one of the skull implants for the second animal on Tuesday, and then hopefully about a month from now we'll be doing the electrode implants. Once they've been immobilized for a week, we'll start running experiments and be able to analyze some data, and then I will be writing a manuscript. So I'll open up to questions, but I am really thankful for Andrew for helping me through all this the past few years.
Thank you, Nicole. Is Dr. Fugulan there?
No, but Kati kind of acts as my second PI, and she's still here.
Yes, I am here, and we did the surgery together 2 days ago. So I am intimately, Dr. Fugerman is doing a red surgery right now, but I'm intimately comfortable with this project because I've been involved in it from the inception. I did the monkey and the surgery part. So yeah. So I would like to say how much I appreciated Nicole's behavior in the OR. She's very self-aware, she's calm, she's focused, she has very good, clever hands. It was a pleasure working with you. And even though this is, again, one of those complicated projects, I really appreciate your being able to see how important your part in it was in understanding the little details that make or break this, can make or break this project, and how important this would be for people who have a paralyzed limb. And we could truly reanimate the paralyzed limb without going and recording neural activity from the brain, just using the mechanism by which the brain engages the muscles.
Okay, thank you very much again for these fascinating projects. We're going to move on. We are 20 minutes behind. I've been a lenient because these are projects that really have been a long time in coming. They had a summer phase under the COVID-19 constraints, but they are long-standing projects. Our next presenter is Haley Ann Ciccone, and she's from the class of 2023, and she worked on the role of sphingosine and endocannabinoid lipids on the bone microenvironment in a metastatic breast cancer model. And she worked with Dr. Todd Vandera, who's professor and head of pharmacology. And I think the next three presentations will be from Dr. Vandera and his colleagues. He supervised them, but there are several other faculty mentors that have been involved. Is Todd here? Or somebody from his lab?
Nope. Yep. Marlisa, I'm Dr. Whitty. I'm here.
Okay, good. Yep. Good to see you.
Yeah, good to see you.
Let's go ahead and have these three presentations, and I'm presuming that they'll be 10 minutes rather than the 20 minutes that I allowed these previous two presentations. Thank you.
All right. Hi. Can you see my screen okay?
Not yet.
No. Okay. Maybe now.
No, we still can't see.
How about now?
There we go.
Okay.
All right. So, hi, my name is Haley, and I've been working in Dr. Vandera's lab since I was a sophomore in undergrad. So I've been there for quite some time. So I have no disclosures. And I just want to start from the very beginning. I'm sure everybody is familiar with what cancer is, but I just want to make sure everybody is on the same page. So essentially, it's unregulated cell growth, and we like to call this clonality, or an abnormal proliferation of a single type of cell. And as these cells grow, they accumulate mutations, and this allows them to invade the surrounding tissue and spread throughout the body, either via the circulatory or the lymphatic system. And it's classified according to the cell type. So if that from which the tumor arose. So if it's from the breast, then it's breast cancer. So there's three main types of cancers. You have carcinomas, which account for about 90% of cancers in humans, and it's also what I'm going to be focusing on today. And that's a malignancy of the epithelial cells, so like the lining of the organs and the surfaces of the body. There's also sarcomas and leukemias and lymphomas as well. So why study breast cancer? So there's a ton of different cancers. Why breast cancer? So breast cancer is the most frequent cancer among women, impacting 2.1 million women each year. And it accounts for 14.7% of all deaths, cancer deaths among women. And bone is the most common site of metastasis among the breast cancer patients. So how does the breast cancer in the breast get to the bone? How does it metastasize? We actually don't fully know. So the mechanism of metastasis is still a very hot topic. There's different theories that have been proposed. But essentially, we're dealing with this clonal selection that determines which cells are going to travel to new locations. So there's a whole process of selection of the different cells that are going to thrive in different areas. And when they metastasize, obviously it's not random. The targets are determined by the ability of the tumor cells to accomplish all the steps of the metastasis cascade. So this is just an overview of it, but here is a really simple explanation in pictorial form, I guess, of how a primary tumor can grow and proliferate, invade the local area, get into the blood or lymphatic system, and you have to survive in the circulation, so you have to activate pro-survival pathways and inhibit apoptosis or programmed cell death, and you gotta stay alive and good all the way to your target. You finally have to adhere to your new site of metastasis, form a micrometastasis formation, and then essentially colonize and thrive. So how do bone mets present clinically? And I really want to pay attention to this first point here. So they have chronic bone pain, and it's a very common symptom among most patients with bone mets, whether that be from breast cancer, lung cancer, anything like that. And it's really important to notice that there are different types of bone pain. So when we say chronic, we often think of a dull ache that can be progressive as the cancer progresses, but you can also have breakthrough pain as well. So if you're on, for example, opioids to manage your pain, you can still have this really severe, intense, intermittent pain that is not necessarily very well managed. You can also have pathological fractures. So when the cancer is in the bone, it's taking up space, and it's really disrupting the normal strength, the integrity of the bone. So for example, something, if, you know, I broke my ankle or something, I'm healthy relatively. So that wouldn't be a pathological fracture because I'm, you know, healthy, and it takes an excessive amount of force to break it. Whereas if you have a pathological fracture, you can have excuse me, a pathological fracture, you have a decreased bone integrity, and it takes a normal amount of force to break it. And this is really important, especially in older populations, because if you have a pathological fracture, and also if that's combined with insufficient pain management, you're not going to move, you're not going to get up, and ultimately you can develop a blood clot, which can be fatal. You can also have nerve compression and hypercalcemia due to osteolysis. So breast cancer is commonly an osteolytic cancer, and you're breaking down the bone and putting it into breaking down the bone and putting all the calcium into the blood system, which can cause nausea, vomiting, constipation, sedation. All these things are not great. So what are our options for managing cancer-induced bone pain? Well, we have opioids like morphine or oxycodone or things like that. But as you know, that has a very limited therapeutic window. For example, you could have adverse events such as like pruritus or itching. You can have constipation, sedation, and you can have more intense effects or fatal effects like respiratory depression. You could also have an NSAID, which is great, but also not a permanent fix. You can use bisphosphonates, which are a stable derivative of the inorganic pyrophosphate, and that inhibits osteoclasts. So rather than inhibiting the pain and acting as an analgesic, it can prevent the breakdown of the bone. And you can also use radiotherapy, but that is also commonly used in conjunction with these other methods. So what do we know so far? Well, we know that breast adenocarcinoma cells commonly metastasize to bone. We know that bone mets can cause significant debilitating pain, and this severely affects the quality of life. And our treatment options are limited, and they don't always have the intended effects. So what can we do about it? Well, we can develop an animal model for studying the cancer-induced bone pain, which has been done in several other studies, including Dr. van der Rohe's lab. You can investigate the components of the bone microenvironment, which is what I'm mostly focusing on in this study. You can use pharmacological antagonists and genetically modified animals or knockout animals to determine if certain components are necessary and sufficient for developing and maintaining cancer-induced bone pain. So I'm primarily investigating the components of the bone microenvironment that might actually mediate this pain because we don't really know the underlying mechanism. So developing an animal model for CIBP. Luckily, I personally didn't have to do this. This was already a very well planned out animal model. So we use the cell line EO771 breast adenocarcinoma cells. And the animal model is an immunocompetent adult female C57 black 6 mouse. So that's all good and everything, but how do you get the cells into the animal? So we chose a direct intramedullary injection of the cancer cells, and this allows for consistent delivery of a defined tumor burden into a specific location. And this is really important because we chose this rather than an intracardiac injection, which would simulate the hematogenous spread of cancer, but that didn't really have consistent results. So we chose to put it directly into the intramedullary space of the right hind femur of the mouse. And so we have our behavior assay. So we measured spontaneous pain with flinching, guarding, and limb use, and mechanical allodynia with von Frey filaments. And the best way that I can explain mechanical allodynia is, so say I just touch my arm, I don't have any cuts or lesions or anything, so it doesn't hurt. For example, if I had a sunburn or like a rash or something and I touched it and it did hurt, that would be allodynia. So it's like a hypersensitivity, and mechanical is just like you're pressing on it. So we press on the right hind foot with the von Frey filaments, and we can develop or calculate a pain threshold. So we're really quantifying that. We're also taking faxitron radiograph images of the bone. So another thing that I'm looking at is how chronic morphine administration impacts the bone microenvironment. So we really want to get a full picture of what it actually looks like from the molecular level up until like radiograph imaging. Our treatment is either morphine sulfate or a vehicle, which is DMSO between 80 and saline, which is continuously administered via a subcutaneously implanted mini pump. Oh, sorry. And then the collection of the intramedullary space contents for further analysis. So we really flush out the intramedullary space of both the ipsilateral and contralateral femur. So this is my in vivo timeline. We do baseline behavior, and on day 0, we do the implant surgery for the CIBP. Day 7, we do behavior as well. That's what we put the mini pumps in. Day 10 is behavior and imaging. And then day 14, behavior, imaging, and collection of the ipsilateral and contralateral bone. So we have 4 groups: cancer morphine, cancer vehicle, sham morphine, and sham vehicle. So with the sham surgeries, we do everything the same except for putting the cancer cells in. So what can we look at? One molecular candidate for causing CIBP is a sphingosine 1-phosphate, and it's a lipid mediator produced by breast cancer cells and exported to bone microenvironment. It plays a big role in angiogenesis, immune cell trafficking, cell survival, growth, and migration, and you can already tell or see how that would be really important in developing cancer. And it also upregulates the S1P receptor subtype in astrocytes, and it's implicated in neuropathic pain. So that's one thing that we could look at. We can also look at endocannabinoids and their receptors. So we have CB2 receptors, which are in our bones. And this is also a lipid mediator. We can, previous papers have shown that CB2 agonists have been used for the management of acute chronic inflammatory and neuropathic pain. So there's a whole combination of different types of pain that are contributing to the overall decrease in the quality of life. And it can also stimulate osteoblast proliferation, and it's been shown to have some anti-tumor potential. So that's another candidate that we can look at. So my goal for the future, I am finishing the in vivo component today, actually. And then the next steps would be to look at the bone marrow and the serum that has been collected and really quantify what the components are. So specifically looking at sphingosine 1-phosphate and CV2. So what's next? We can examine the effects of chronic opioid use on the bone microenvironment. We can identify therapeutic targets within the bone microenvironment. So for example, with the CV2 agonists, potentially it could be a big game changer for treating and managing CIBP. We can develop therapeutic agents to manage the CIBP, and then also identify barriers to receiving novel cancer therapeutics in general, and then just better educating people on how to manage the pain. So special thanks to Dr. Vandra and Dr. Largent-Milnes. I worked a lot with Austin Thompson. He just defended his PhD and he's an MD candidate. Kelly's our lab manager. She's fantastic, and Angela Smith, and all my cited sources. Thank you.
Yeah, thank you, Haley. I'm going to ask Todd to save his comments so he can discuss all three students. I didn't want to bring up some relevant points, though. As I mentioned yesterday, I've been the co-organizer of the biennial cancer metastasis through the lymphatic system conferences that are now permanently located in San Francisco. And I encourage you, as your project moves along, if it looks like you have an abstract to submit to that meeting. I mean, it's an incredible meeting. We have international experts from all over the world and cover cancer metastasis from the molecular biology, the clinical presentations, and also epidemiology. It's a great educational experience and an opportunity to meet international experts. And we have young investigator awards also and support for travel. So I encourage you to submit to that. Also, in the spring of next year, the next conference will be in September of 2021. In the summer of 2021, we'll be coming out with a textbook on cancer metastasis through the lymphavascular system. It's been commissioned by Springer Nature. And we have 30 sections in the book and multiple chapters. It will be, I think, the definitive text on cancer metastasis in relationship to the lymphavascular system and in general. And it will be covering clinical manifestation, clinical cancer metastasis, as well as molecular biology, liquid biopsies, CRISPR, microbiomes, and then also epidemiology. So it's going to be very comprehensive. I did want to make one point, and I had to make it with the main editors multiple times, and I think it's getting through. And that is not to refer to the circulation and the lymphatic vessels, and the lymphatic system. The lymphatic system is a circulation. It's also a vasculature. So both the expression circulation and lymphatics and vasculature and lymphatics are really erroneous. It should be the blood circulation, the lymph circulation, the blood vessels, and the lymphatic vessels. And I think it affects the way you think about the lymphatic system if you realize that it is a circulation and a vasculature. So I have most everybody trained who work with the conference in the textbook, but I know it's going to continue to be I think an important point, not just a sore point with me, but an important point. And I encourage you, if you have an abstract, to submit to that meeting. I think you'll find it a very rewarding experience. Okay, let's move on then to the next presentation. That's from Andrew Cameron Hustler, and he's class of 23, and he's working on KV7 channels in the prelimbic cortical area that maintain, you've done this to me, Todd, here with these titles, that maintain neuropathic pain. And his mentor is also Todd.
All right. Thank you for that introduction. I'm going to share my screen real quick. Okay. Let's see. Okay. So, hello, my name's Andrew, for all those that don't know me. I worked on KB7 channels in the prelimbic cortical area that maintain neuropathic pain, and my research mentor was Dr. Vanderall. And so I'll start off by just talking a little bit about chronic pain in general. So it affects millions and millions of individuals in the United States every year. It's one of the main reasons people originally go to see a physician. And chronic pain is a unique, complex sensory experience that varies depending upon the disease or injury process, the interpretation and setting of pain, previous experiences, and the individual's psychological state. So pretty much it's saying that pain is a very kind of unique experience to each and every person, depending upon their life and their genetic makeup, their biology, and everything like that. And then over here, you can kind of see all the areas that are involved in pain, such as the insula, the somatosensory cortex, the anterior singular cortex, the prefrontal cortex, etc. There's so many brain regions involved in pain. So next, I'm just going to talk about a couple of regions that we are specifically interested when it comes to chronic pain. And the first is the prelimbic prefrontal cortex, or area 32V, which is this specific area in the rat brain. So as you could see, it's on both sides, and it's in this area roughly around in the human. It correlates to this area. Next, we are looking also at the periaqueductal gray, which is part of the descending pain modulator center, and it's around the aqueduct in the brainstem. And this is where it's located in the rat brain. Next is the rostral ventromedial medulla, which is located in the rostral medulla. So it's up higher in the medulla, and it's roughly this location right here, as you can see right there. And so a little bit about Kv7 channels in the prelimbic prefrontal cortex. The K is potassium voltage gated ion channels. They provide innate inhibition on the pyramidal cells of the L5 layer in the prelimbic prefrontal cortex when functioning normally. But when intracellular calcium levels are increased, the calcium sensitive Kv channels are inhibited and no longer provide inhibition on the pyramidal neurons, which essentially means the pyramidal neurons are hyperexcited and stimulate the pain response essentially. So overall, for this summer and continuing on, our big picture question is essentially what molecular underpinnings exert control upon the Kv7 channels, and how do these molecular mechanisms, in addition to the Kv7 channels and the prelimbic prefrontal cortex, interact with other brain regions known to be involved in the perception and experience of pain. So essentially, we're looking at the molecular, or all the molecular mechanism that controls for the Kv7 channels, and how the Kv7 channels with the prelimbic cortex interact with the rostral ventral medial medulla, the periaqueductal gray, and other brain regions as well. So for the summer, we essentially did 3 experiments that analyzed essentially 3 questions. So I'll start with the first question that we kind of looked at was, can restoration of the Kv7 channels innate inhibition on the pyramidal cells through the use of a P2Y1 antagonist attenuate chronic pain induced by SNI? So a SNI procedure is a spared nerve injury, and the P2Y1 antagonist essentially helps decrease calcium mobilization in the cell, which essentially can, hypothesized to bring back innate inhibition of the pyramidal cells that are sensitive to calcium. So 5 rats made it through all the experimentation. The SNI procedure was performed to induce the model of chronic neuropathic pain. The tibial and common perennial nerves are severed in the rat, leaving the sural nerve, which then transmits the pain response, essentially. After that, Von-Frey behavioral analysis was performed to assess allodynia, and allodynia essentially is a regular stimulus inducing a painful response. And we always measure the contralateral paw because that's the area that's affected, or the contralateral side in the brain is induces, or is the one that processes the pain for the other side of the body. After that, the prelimbic prefrontal cannulas were surgically inserted. So we essentially use a stereotaxis machine, and we plug in the coordinates that we need, the anterior posterior coordinates, the dorsal ventral coordinates, and the medial and lateral coordinates to make sure that the cannulas are inserted properly into the specific brain region that we are looking at, which in this case was the prelimbic prefrontal cortex. After that, blinded injections for the P2Y1 antagonist with behavioral allodynia were assessed. And then after that, the rats were sacrificed and brain slices were taken to assess the location of the cannula. So this is our preliminary data from that experiment. As I mentioned, we performed this on, or 5 rats made it completely through. However, as you can see right here, 3 were on target and 2 were not. So 1 was off to the lateral portion of the brain, and then 1 is not shown on here, but was in a different brain slice. So essentially we had an N of 3 with this experimentation. And as you can see here, this was the baseline before the SNI-induced procedure. Once SNI was performed, the rats had developed pain. And then this shows essentially after the injection what happened for a time course of about 2 hours. And as you can see, there was a little bit of pain attenuation right there, but it went back to baseline. However, this can't be correlated to the P2Y1 antagonist because it possibly could have been attenuated for a different reason. So it might be beneficial to repeat this experiment in the near future if possible. The next question that we had were, are the direct neuronal pain pathway connections, are there pathway connections between the prelimbic prefrontal cortex and the rostroventral medial medulla? So 9 rats made it through all the experimentation. Dual cannulas were surgically implanted, both into the left hemisphere, 1 into the prelimbic prefrontal cortex and 1 into the left rostroventral medial medulla. We assessed allodynia after that, and then blinded cannula injections and allodynia testing was done after that. We used XE991, which is a known KV7 channel blocker. It's pretty well studied. Was injected into the prelimbic prefrontal cortex and either lidocaine or saline into the rostroventral medial medulla. And all rats ended up getting both of these. It was carried over a time course of 3 days. And then after that, animals were sacrificed once again, and brain slices were taken to determine the cannula location. So this was the preliminary data that we got from this experiment. As you can see, this was the baseline pain threshold that they had before all the injections were performed. And this was right when the injection of lidocaine into the, or when XE991 was injected into the prelimbic prefrontal cortex, and then when lidocaine was injected into the RBM. And as you can see, both pain is generated in both. However, for those that received the vehicle or the saline injection, they developed more pain, and it seems like the lidocaine attenuated pain in some animals. However, the sample size was relatively small, and this is preliminary data, so we're going to reassess this and carry out this experimentation again to get a larger sample size and to see if this trend holds up. And then the final experiment that we had run over the summer was to understand kind of the proteins or molecular mechanisms that are altered in the contralateral prelimbic prefrontal cortex, periaqueductal gray, and rostroventral medial medulla following a SNI-induced neuropathic pain model. So we carried this out on 6 total rats. 3 were sham, so that means the whole procedure was performed without ligating the nerves, and 3 post-SNI rats as well. Perfusion procedures were performed, and the specific areas that we were looking at were sectioned in harvest. The proteins were prepared for BCA analysis, and then after BCA analysis, the protein samples were sent for mass spectrometry, mass spec, and we're currently awaiting the data on this set of experiments. So some future directions that we have are to analyze the proteomics data and kind of see which protein levels are changed and which proteins are significantly important in these areas under neuropathic pain, and then kind of target specific directions to continue going forward. We're going to be repeating the second experiment to analyze the trends and see if that trend continues. And then third, we may possibly re-examine bradykinin's link to the Kv7 channels. And that's everything. I just want to thank Dr. Vanderhoff for allowing me the opportunity to work in his lab, and Angela Smith, who is a wonderful undergraduate student who's essentially helped train me throughout the summer, and I really appreciate all her hard work. And then there's all my references.
Okay, and I presume your initial questions are, you're still pursuing those same questions, right?
Yes.
Okay, let's move on to the last presentation out of Dr. Vanderhoff's lab, and it's a very different. All these are very different. Angelica Alvarez in the class of 23, and she's looked at the role of CB2 antagonist, CB2 agonism and microglia activation in respiratory depression, attenuation, and reward behavior.
Hi, okay, do you see my screen?
Yep.
Okay, hi, so my name is Angelica. I'm an incoming second-year medical student, and I worked in Dr. Vanderhoff's lab, also with Beth Wise, a PhD candidate in the lab. And so my research focused on the role of cannabinoid agonism and microglia activation in opioid-induced respiratory depression. Oh, no. Okay, so since 1999, opioids have accounted for nearly 500,000 fatalities in the US, with an increase in synthetic opioid-involved deaths. Synthetic opioid-involved death rates accounted for 2/3 of all opioid-involved deaths from 2017 to 2018. And to put it into perspective, according to the CDC, 128 people die every day from an opioid overdose, whether that be prescription opioids or opioids procured illicitly. As with the rise of synthetic opioids, this is just another way of kind of characterizing this. This is a graph I took from the CDC. So since 2012 up until 2015, we've had a 264% increase in the fatality rate in the use of synthetic opioids across the United States. to put it into perspective demographically, within the United States, in the state of Arizona, for every 100,000 people in 2018, there were about 15 to 19 individuals who suffered from an opioid-involved overdose death. So you can't mention opioids without also addressing chronic pain. So like others before me have already mentioned, chronic pain is a very big issue worldwide. In 2016, 1 in every 5 adults, nearly 50 million individuals in the US experienced some type of chronic pain. And this Journal of Pain in 2012 analyzed that the annual cost of pain was greater than the annual cost of heart disease, of cancer, and of diabetes combined. And so the total cost of this came out to be $560 to $635 billion in 2010 money. However, also addressing chronic pain, patients need effective chronic pain treatment, but we also need to be able to reduce the risk of opioid use disorder, overdose, and death. So what is opioid overdose? What does that mean? So opioids bind to mu opioid receptors within the respiratory center of the brainstem, and this results in respiratory depression, which is the primary cause of death in an opioid overdose. So the pre-Botzinger complex is one of the many respiratory complexes within the brainstem. However, it's the pre-Botzinger complex of the medulla where there are mu opioid receptors on a certain type of neuron. They're called neuron kinin 1 receptor neurons. And so when these opioids bind to these receptors, this results in respiratory depression and then death. So there is a fast-acting mu opioid receptor antagonist. It's called naloxone, and this will reverse respiratory depression when someone is overdosing. However, with the increase in opioid-associated fatalities, the huge bump in the use of synthetic opioids, and the huge prevalence of chronic pain in the United States, as well as the lack of adequate distribution of naloxone in the country, we do need a mechanism to prevent respiratory depression within the brain. Okay, so this is going to bring us back to our neuro block. This is Dr. Van der Rohe's pain lecture from neuro. So as if you remember, mu opioid receptors are located on pre and postsynaptic terminals. So when you receive any kind of pain input, there are voltage-gated calcium channels and also potassium channels. And within the presynaptic terminal, you have pain neurotransmitters. And these are things like glutamate, substance P, or CGRP. However, when you deliver an opioid to the system, you block calcium conductance. So you close those voltage-gated calcium channels, and then you allow for hyperpolarization by opening potassium channels. And this prevents the release of the pain transmitters. So you don't get to feel the pain associated with substance P, glutamate, or CGRP. And then there is this mode of opioid disinhibition where these fibers travel to the brainstem and come back and also release endorphins. Okay, so taking us into the respiratory system. So the pre-Botzinger complex is in the rostroventrolateral medulla. So here's the medulla, and kind of in between nucleus ambiguous around here and above the inferior olivary nucleus is where you would find that complex. It's important to note that it's not a singular nucleus, but rather a collection. But it does account for reflexive inspiration via the activity of the neurokinin 1 neurons. Studies have shown from the Journal of Neuroscience that destruction of these subset of neurons in the pre-Botzinger complex results in irregular or ataxic breathing. So it is responsible for reflexive inspiration. Okay, so what does that all have to do with cannabinoids? So as mentioned previously, we do have 2 cannabinoid receptors in the body. We have CB1, cannabinoid receptor 1, and cannabinoid receptor 2. These have variable distribution around the body. So while CB2 is mostly on things like neurons and the CNS, CB2 is on immune cells like microglia. And so it's also important to note within this diagram that we have this ligand here, 2-acylglycerol, which binds with equal affinity to both of these receptors. And this is synthesized via the hydrolysis of diacylglycerol lipase, and also monoacylglycerol lipase. So, So what has been done in the lab before my arrival? So Beth, the current pharmacology student right now, she wanted to see what the expression was like of CB2 receptors, CB1 receptors, and mu-opioid receptors within the pre-Botzinger complex. So she took tissue from these wild-type mice, CD1 mice, and she took out mRNA to do a qPCR to analyze for expression levels, and she saw that there was actually a huge increase or a huge expression level of CB2 receptors within this complex compared to mu-opioid receptors. And then she wanted to see what this looked like on immunofluorescence. So she took sections of the brain and she stained the PBC, showing an antibody for CB2 using the red and the magenta here for the C and N terminal. And then it's overlaid over TMEM, which is a microglial marker. So this suggests that the CB2 receptors that are heavily expressed within the pre-Botzinger complex are on these microglia. Then she wanted to see what this meant in the context of morphine. So she took mice, she delivered morphine, and as we all know, it results in respiratory depression, so we see this here. But then when delivering a CB2 agonist, she saw in the context of a 0% carbon dioxide setting that you have attenuation of respiratory depression. She did this exact same study again using a 5% carbon dioxide challenge, and she saw the same thing. So she sees expression of CB2 receptors in the pre-Botzinger. She sees expression of mu-opioid receptors. And when delivering a CB2 agonist with morphine synergistically, you see attenuation of respiratory depression. So how does this work? So she also decided to test this another method by delivering a CB2 inverse agonist. And I believe that's the yellow right here. And she saw that by delivering a CB2 inverse agonist, you are able to induce respiratory depression alone, also in the 0% and in the 5% carbon dioxide challenge. So this brings us to my question for the summer. What is the role of CB2 agonism in microglia in opioid-induced respiratory depression? We decided to break this question down a little bit so that we could kind of plan our experiments on it. And so we decided, okay, so how do CB1 and CB2 receptors interact with neurokinin-1 and mu-opioid receptors in the pre-Botzinger complex? So I'm going to bring this diagram back, and everything circled in red are proteins and receptors and ligands that we're interested in seeing the expression of. So what can we do? So we can take wild-type tissue, we can take neurokinin-1 neurons, and we can take PBC tissue in wild type and in knockout mice and assay for expression levels of this. But when we assay for the expression levels, we also want to know what it's like, if it changes, if it's regulated in some way with chronic morphine administration. So for this, we planned to deliver chronic morphine administration. So that would be twice a day, every 12 hours via IP injections for 5 days. And so we would compare naive mice, so completely untouched, with morphine administration mice, and then also our control group, which would just be mice who were delivered chronic saline. So how else can we answer this question? Okay, so we thought, what if we look at the localization of CB1 receptors and CB2 receptors on pre-Botzinger microglia and neurokinin-1 neurons using postnatal primary microglia and neuronal cultures? So why would it be important to do this if Beth already kind of saw this earlier? So it's important to note that the studies that happened earlier all use pharmacological techniques, and we wanted to look at expression of a wild-type mice versus a mice that had that same receptor but knocked out. So that's what was important here. So in this experiment specifically, we would culture microglia and neurons, and then we would stain with the neuron or microglia-specific marker to see localization of CB1 receptors and CB2 receptors. Okay, so what else can we do with this question? So we also wanted to see what happens to the respiratory system when delivered chronic morphine. So we decided, okay, let's deliver chronic morphine between wild type and also knockouts, and then follow these mice with whole body plasmography chambers. And we can assess respiratory depression using various variables such as minute ventilation, tidal volume, and breaths per minute. to see if anything changes there. Okay, so this is just kind of a recap of the past 3 or 4 slides and the experiments we had planned. So when I first started in the lab this summer, we were actually working on wild-type mice, but they were on a CD1 background. And we did want to look at these experiments on a CB2 knockout. However, there isn't a CB2 knockout based off a CD1 background. So we had to procure another kind of wild-type mouse. So that's the C57 Black 6 mouse. And with that, there is a already made CB2 knockout backcross onto a C57 mouse. So there's a lot of mice going around, but what we wanted to do was, again, look at all 3 sets of these mice to look for expression levels of protein, of mRNA, and then look at respiratory studies to do that. And then also to do neuronal cultures, stain these neurons and microglia, and then see what happens there. So as far as actual progress that I made in the lab, so with the strains of COVID, there was limited access to the lab. And so Beth did a lot of the dissections of the neurokinin and the pre-Botzinger complex because they are the tiniest regions of a mouse brain. And so with that, that also means that we need to be pooling a lot of tissue together just to be able to get enough protein or mRNA or even cells to culture. So that did take a lot. So as far as what we have right now, we're also waiting on our CB2 knockout mice, which I think will be ready next week. And so those were kind of my restraints there. And so we have all these, well, some of these in the freezer ready for the CB2 knockout so we can conduct the same experiments, take the tissues, and then run these gels or plates. So fringe benefits to being in the lab. So I learned a lot. I was given a lot of space and room to voice, what I thought, my opinions, and how we can design and implement experiments. I was also given a lot of room to be independent, to go in the lab myself, to do experiments myself. And so I really enjoyed that aspect of it. Another aspect I really enjoyed was getting to know the members of the lab. I really enjoyed that. I've been involved in research for a long time, but I always had this trope of what a scientist looks like in my head. And when I joined the lab, I was under the mentorship also of the graduate student Beth, and she's involved a lot in policy, a lot in volunteering, and also in research. And so that kind of changed my perspective of what it means to really help your community as a scientist. And so I want to thank Dr. Vanderall for allowing me to come into the lab, for being patient with my emails, and for allowing me this great opportunity, and also for Beth for being patient and allowing me to speak my mind. So if there's any questions.
Thank you, Angelica. And Todd, do you want to comment on all 3 of the presentations?
Yeah, sure. So first of all, excellent job, all 3 of you. So it's been a really tough summer, obviously. And really, I want to, praise all of you for trying to go through the summer and doing this. And of course, you, Dr. Whitty, for having this program. So I'll just start with Haley's project. I think Haley's being a bit humble in the fact that she's done so much work. She started in the lab even before med school. She's already got 2 publications. And I think her project at looking at lipids as neurotransmitters with a whole new family of lipid receptors. We should be thinking of lipids as completely different than what we've thought in the past. And the fact that, there's 5 different G protein coupled receptors for these lipids. And so I think this is brand new research that I think is very exciting. It also correlates obviously with the endogenous cannabinoids, which are lipids. So Haley actually didn't show all the things that she did, and she did help with setting up that model. And it's great having her in the lab. I also want to talk about Andrew's project, completely brand new. It's sort of looking at whether there is cognitive psychological pain. And so he and Angela Smith have really sort of dedicated their ideas of looking at prefrontal cortex all the way back down to those pain control centers that I bothered you guys all about in med school. But the connection's there. So they've done that work to actually show that the neurons connect there, and now they're figuring out the mechanism. And that is based on potassium channels. As you guys all know, if potassium channels come offline, the neurons keep firing, and that might be part of psychological pain. So I think excited about that and hope that Andrew continues on. And of course, Angelica, I think she's done a fantastic job. Beth's a great mentor. Again, it's nice to have mentors like that. So, and I hope that she continues on, because we really are the first ones to show that a specific type of cannabinoid can actually inhibit opiate-induced respiratory depression. And as you guys all know, that I believe that cannabinoids are effective in inhibiting pain. So combining those two and showing that it actually decreases respiratory depression would be fantastic. So again, I just want to thank you all. I think these presentations are fantastic, and I'll continue on listening.
Okay, thank you very much, Todd, for being there, and thank you for everything you do for the College of Medicine and the research enterprise here. We're going to move on. I've been very generous with the time periods. They were supposed to be 10 minutes. The high school students kept to their 10 minutes, but that's all right. These were complicated projects and students who've worked on these projects prior to the summer. So we're going to move forward now with Christy Nicole Rasputny. And she's class of 23, and she studied the genetic determinants of variable expressivity of obstructive left heart disease. And her mentor is Dr. Scott Kluwer, who's professor in pediatric cardiology. And Scott was an old MSRP who won the prize for the best presentation at the Western Medical Research Conference in Carmel when he was a medical student. So he's continued to mentor students throughout his career.
Okay, can you see my screen?
Yes.
All right, thank you for the introduction, Dr. Whitty. So as you mentioned, my research this summer was on the genetic determinants of variable expressivity of obstructive left heart disease. So what is obstructive left heart disease? It is the a group of congenital heart defects, including bicuspid aortic valve, hypoplastic left heart syndrome, and coarctation of the aorta, that may be diagnosed in utero or not discovered until adulthood. These typically obstruct blood flow and impair systemic oxygen delivery. So we studied a Tucson family that has bicuspid aortic valve, or BAV, and hypoplastic left heart syndrome, or HLHS. I know we have a mixed audience here, so I'll do some explaining of some things that I know the medical students are familiar with. But BAV is the most common congenital heart disease. It's prevalent in 1 to 2% of the population. And in this, the aortic valve has 2 cusps here instead of 3, and the normal valve, and they're at an increased risk of complication. In HLHS, the patient will have a variety of different problems, including atrial septal defect, mitral valve abnormalities, and hypoplasia of the left ventricle and the ascending aorta. And current research shows that multiple genes are implicated in the development of BAV and HLHS. But a lot of experts think that BAV may be the mild end of a spectrum of obstructive left heart disease. So we're wondering if this family has BAV at the mild end and HLHS at the severe end. So the question that we started with was, what genetic determinants are responsible for the phenotypic variants in obstructive left heart disease? And so I'm going to start out by showing you this pedigree, and I know it's a little bit hard to read, but I'll go through what I can here. So for those who aren't familiar, the squares represent males, circles represent females. The red here represents bicuspid aortic valve, and the blue represents hypoplastic left heart syndrome. And so this is the portion of the family that we're studying. And I want to draw your attention to a few things before we look closer at that. First, the mother here had her father and her half-brother who had heart failure, both of unknown cause. And her half-brother's pretty young, so you know, may be related, may not. And the father has bicuspid aortic valve, and his father also had that and died of a heart attack at 48. Unfortunately, the father's not in contact with any of his siblings or their children, so we don't know if any of them are affected. So we'll take a closer look at the affected portion of the family. So as you can see, we have one of the daughters who's unaffected. And as I mentioned before, the son and father have bicuspid aortic valve. The father also has mild dilation of his aorta, and the daughter has hypoplastic left heart syndrome. The unaffected mom, we don't have an echo on her, so we're not certain that she's unaffected, but we believe that she is. And the father also has a son that he's not in contact with anymore, which is what this little symbol here means. And he's never had an echo done, so we don't know if he is affected or not. So for the purposes of this study, we were able to obtain the raw genetic data from the father, the mother, the daughter, and the son. Due to COVID, we were unable to get the data for the unaffected daughter in time, so we treated the mom as unaffected. And so once we had that raw data, I used a Galaxy platform to process that, do a quality control check, and then pull the data into Gemini. And this is kind of a screenshot of the Galaxy platform with the Gemini tool loaded. And in Gemini, I was able to put in different pedigree analyses, such as like maybe autosomal recessive or autosomal dominant with variable penetrance. And then Gemini pulled out the candidate variants. And the output looked something like this. It had a lot more rows and columns, but this is just a quick screenshot. So you can see it showed the chromosomes, the start position of the variant, the reference and alternate alleles, and then the specific genes involved and the expected consequence of these genetic variants. And then I put each of those into the NCBI genome data viewer. And so what you can do with this is drill into one specific variant and see the frequency of alternative alleles and the clinical or potential clinical significance of those alleles. And then from that, this is kind of the results of the pedigrees and inheritance patterns that I was able to get through during the summer. We found 3 main candidate genes that may be responsible. So we'll go into each of those now. So the first was a disruptive insertion of GGC in the FOXC1 gene, and that was present in the father, son, and daughter in an autosomal dominant inheritance pattern. And we found that according to the NCBI data viewer, had 16% prevalence in 6,000 genomes that were analyzed. And FOXC1 regulates GATA4, NKX25, and the Notch signaling pathway. FOXC1 is expressed in the atrial septum and the cardiac valves. And a deficiency of FOXC1 leads to significant reduction of GATA4 and NKX25. Those 2 genes are important in cardiac embryogenesis, including cardiomyocyte specification, proliferation, and differentiation, in addition to chamber maturation. And NKX25 is also responsible for, or it plays a role in heart looping, embryogenesis, and has been implicated in BAV and HLHS. However, there are a few problems with this.
Your audio is off. Christy, your audio is off.
I think her internet connection might have.
Want to check your internet connection somehow? I don't know if you can get to her.
Christy?
I can hear you guys.
Oh, okay.
Yeah, sorry, you froze up until right now. I think she froze again. Christy,
can you hear me better?
We can hear you, but your video is sort of freezing here and there, as well as your audio. So why don't you turn your camera off to try to save some internet bandwidth? See if that helps a bit. All right,
okay, is that better?
We can't hear you yet. All right, we can hear you now. Yeah.
Okay. All right, so I'm not sure what you heard, but the main things here are that this mutation was also present in the mother. So if she truly is unaffected, it's unlikely that this variation in FOXC1 is responsible for what we saw in this family. Also, as I mentioned previously, BAV is typically present in 1 to 2% of the population. So having a frequency of 16% with this variation is a little bit too common for this to be the most likely candidate. The next, sorry, now my keyboard, there we go. The next candidate variant was a frame shift from AAC to GACA in the Nexin gene. This was present in the daughter in an autosomal de novo fashion. Because it's a novel variant, there was no allele frequency found in the NCBI genome data viewer, which is expected with a novel variant. Nexin regulates GATA4 and GATA6. I don't know if you heard this in the previous one, but GATA4 and GATA6 are important in cardiac embryogenesis. And overexpression of Nexin inhibits GATA4 and GATA6 and downstream targets. So unfortunately, there is not very much research. I think I found a total of 2 papers that talked about Nexin and congenital heart disease of any kind. So there's not enough research for us to say whether this may be what is responsible for HLHS in the daughter. And the third candidate variant that I found was a missense variant from AGGA to TGGT in the MYH6 gene. Again, this was a de novo mutation in the daughter. And MYH6 encodes the alpha MHC protein, which is prominent in cardiomyocyte development. And mutations in MYH6 have been found in HLHS patients. The research that I found on this indicates that decreased contractility and dystrophic sarcomere structure found in MYH6 variants may contribute to the development of HLHS. And this is consistent with one of the leading theories in the development of HLHS, which says that it can be a problem with blood flow from the atria to the ventricle, which prevents normal development of the left ventricle, and then subsequently leads to problems in the mitral valve, the aorta, and keeps the atrial septum open. So that's as far as I got this summer. Remaining questions include what type of bicuspid aortic valve the father and son have. Some of the research that I found showed that that there's a thought out there that the different fusion of cusps in the bicuspid valve may be caused by different genes. And so I'm curious to see if the father and son have that, have the same phenotype. The next question is whether the father and son have a different mutation from the daughter. This would go against that belief that BAV is the mild end of the spectrum in this particular family, but it's worth analyzing so we can see what's really going on with this family. And in order to do that, I would run an analysis of the pedigree with the father and son. And then the final question is whether the mother's exome is masking responsible mutation in this family. Since we don't have an echo for her, we can consider getting that to evaluate her anatomy. In addition, examining the unaffected daughter's exome may help us figure out whether her exome is masking the responsible mutation. We have a swab from her. We're just waiting on PCR results so that raw genetic data can be processed next. And then the fringe benefits that I found from this project was that I learned to process and analyze raw genome data, which I don't think is something that very many clinicians ever have a chance to do in their career, including pediatric physicians. And I gained a very good appreciation for the need for non-white genome sequencing and reporting. This was a Hispanic family, and most of the allele frequency data that I found in the NCBI genome browser was from white people of white or European descent. And so it's really important that we get genome data from people of other backgrounds in order to have a really good understanding. And then I definitely gained a better understanding of cardiac embryogenesis, which is something I struggled with in the cardiology block. And I feel like I understand that a lot better now. And finally, I got to help contribute to helping a local family, which I am grateful for. And I just wanted to say thank you to Dr. Kluwer, Maureen, and the rest of the pediatric cardiology research team for giving me the opportunity to work on this project and for all of your guidance along the way. Of course, the MSRP team for making this possible for all of us, and the affected family for letting us look at their genome and swab them for DNA. And those are my references. Were there any questions?
Thank you, Christy. Is Dr. Kluwer there? Is Dr. Kluwer?
Yeah, I'm
oh, great.
just sometime, yeah.
Do you have a comment you want to make about Christy? I mean, this is very interesting work. And of course, I'm especially interested because, you know, we've been looking for lymphedema genes, and there are 13 very clear-cut pathogenic genes. And several of them are GATA genes, and the other is FOXY2. FOXY1's of interest also. And there may be an overlap. These lymphedema genes also are sometimes associated with cardiac abnormalities like tetralogy, Fallot, and other congenital heart diseases. But what are your thoughts on pursuing this and how these genes relate to cardiac genesis?
Yeah, I think it's a really, really exciting study. You know, Christine and Maureen are, you know, kind of taking this to a whole nother level. The granularity of the information that they're gathering and sharing, I think we're going to get new insights. It's really, really complicated, and I think their approach of having to take a multifactorial approach is sound. It's going to take some people a lot smarter than me to help make sense of it. So that's why I'm glad we got Christine and Maureen working on it. But I think with this progress, we're going to get a lot of information, and I think the important steps. I don't know, Christy, if you think if the research is going to continue, which I hope it does, starting to take some of those and pursuing which candidate genes or pathways might have a functional role, not just for this family, but for others who are affected by bicuspid aortic valve.
Yes, absolutely.
Could I ask either one of you a question that is burning? It's not relating to exactly your project, but it's relating to Taylor's project. And that is, what is the difference between the development of the left heart, and all your lesions are in the left heart, compared to something like Noonan syndrome, where the lesions are all in the right heart? Is there a difference in development of the right heart and the veins as compared to the left heart and the arterial system? Scott, do you know on that?
Yes.
The answer is yes. Well, that's great, because I was thinking there might be.
Yeah, I think some of the candidates that have been looked at. I didn't hear the total beginning of Chrissy's talk, but you know, some of the GATA genes, some of the Notch genes are really more heavily influenced on left heart development than on right. But again, there's that. Plus, you've got the importance of development while you've got a functional organ. So you've got flow on top of genetic determinants. So it's a complex organization that I think the left and right heart have different pathways. I think that's pretty well accepted, but without great sound genetic data.
Okay, well, we'll follow up on that because I think it's could be very interesting. Okay, let's move on to the next presenter, who is Vanessa Eller, and she's class of 23, and her study is on the correlation between executive functioning, coping mechanisms, and brain structure in individuals with congenital heart disease, also with Scott, professor of pediatric cardiology, as the mentor.
Thank you for the introduction, Dr. Whitty. Just want to confirm you can see my screen?
Yes.
Perfect. So hi, my name is Vanessa Eller, and this summer I had the opportunity of working with Dr. Kluwer as well. Specifically, my project was regarding the correlation between executive function, coping mechanisms, and brain structure in individuals with CHD. So over 2 million people are currently diagnosed with congenital heart disease in the US. These individuals are at an increased risk of developing developmental delays, motor deficits. These things could have a significant impact on their quality of life. Fortunately, there has been a lot of advancements in terms of the treatment of CHD, but with that means that there's a growing number of adults that currently have CHD, and that means that there's a lot of unknown about the neurocognitive and the psychological symptoms associated with those living into adulthood with CHD. So the goal of this study is to find a correlation between executive function, coping styles, and brain structure in individuals with congenital heart disease to better understand the deficits people living with CHD may be facing. So in our research, we looked at how people with congenital heart defects manage their condition as they transition into adulthood. We know specifically that people with CHD are facing higher stress than their peers because they have the additional stress of dealing with their condition. We know that some people do an okay dealing with their CHD and others have a harder time with it. So this led me to some of my starting questions, which are, what are some of the stressors that individuals with CHD experience? How does their upbringing differ from that of their peers or siblings? And then what are some of the difficulties these individuals face in the social, academic, as well as the professional setting? And unfortunately, these were some of the questions that I was able to answer through my project. We wanted to assess the factors that may contribute to the success as well as the struggles of this critical transition period into adulthood so that we may help other teenagers with CHD during this critical transition period. So the project entailed recruiting patients from the University of Arizona Banner Pediatric and Adult Congenital Cardiac Clinics, patients that were diagnosed with CHD and were between the ages of 15 and 24. We were going to do clinical evaluations on these patients to understand the neurological deficits within this population. It was essentially a 3-step project involving a self-report questionnaire, an interview, and an MRI scan. So the first part of this experiment was the self-assessment. This was essentially done before I started in the laboratory. Both the patient with CHD and their caregiver or significant other completed a self-report questionnaire. This included questions from the PROMIS questionnaire, which is the patient-reported outcomes measurement information system, and I believe Diego also presented on this. And it looks at physical health, mental health, social health, and different domains within each of those categories, such as fatigue, pain, sleep disturbance, anxiety, depression, and social activity, as well as other things. The participants also completed questions from the Amsterdam Executive Function Inventory, or the AEFI, and this that I'm presenting here is a screenshot of a sample that can be demoed online. And it's a questionnaire assessing 3 aspects of executive functioning, including attention, self-control and self-monitoring, and planning and initiative. And the reason we wanted to look at executive function is that these develop from early childhood into young adulthood. And executive functions develop within each child at their own pace, depending on gender, parental education, etc. So we felt that these were important to be assessing. So these self-assessment scores were compiled with objective clinical assessments from the DSM-5 and were analyzed utilizing repeated measures ANOVA. And from these results, we were able to conceptualize the specific areas of a concern for each participant and identify which patients or which participants were experiencing maladaptive coping. And this allowed me to look at this data that was done before I even started in the lab and to better individualize the interview experience for each participant. So the second part of the experiment, this is the part that I focused on, was the interview. And this was done it was really interesting because it was doing clinical, I guess like the clinical aspect of research, but I was able to do it via Zoom. And I had a good experience doing it, and it was interviews that took about an hour per participant, and it was based on the salutogenic model. So this model focuses on the origins of health and health promotion. It is in comparison to the pathologic model, which focuses on how the disease is acquired and what the specific disease is. So the questions I did focused on things like quality of life, self-efficacy, coping, well-being, etc. And all of these questions were geared towards finding out how the patient's experience was growing up with CHD and how they are managing it today. So I asked several questions many open-ended and closed-ended questions. The closed-ended questions came in the form of ranking the question from 1 to 4, 1 being a lot, all the way to 4 being not at all. And the questions that utilized this format were like, how often were your parents around? How strict were they? How often were you prevented from doing things that other kids your age could do? However, the majority of questions were conducted in an open-ended format so that the participant could answer as freely as they would like, and could elaborate on anything they chose to. So we also made sure to go back to some of the high yield or like the specific closed-ended questions that I guess raised a red flag for us. So if the participant had responded 4, meaning not at all, to a question such as how often were your parents around, we would inquire as to why that was. And then we also use the model of conservation of resources, or the CORE model, which is a resource-oriented model assessing stress. It is based on the idea that individuals strive to protect the resources that they deem are important, and they're threatened by the idea of losing those resources or not acquiring those resources. We use it to better understand how the participants would react in stressful situations and how they specifically cope with that stress. So this is the core resources that I would present to the patients or to the participants during the Zoom call. And what I would do is I would have them go through this list, and they would basically just pick which are the resources or values that they consider important to them. And from that, we would discuss why they chose certain values as more important than others, how they would react if they lost one of those resources. And then I would ask if they had a similar experience where they experienced a similar loss and how they reacted. It was through these interviews that I was able to gain a firsthand patient experience. I was able to obtain firsthand patient experiences that answered my initial starting questions when I first started in the lab. So unfortunately, due to the pandemic, as with many of the other research projects, we had a difficult time recruiting patients. The goal moving forward would be to expand our outreach, increase our end value, and gain more data and understanding of this patient population. So the plan is to first recruit more patients, conduct more interviews, code and analyze the interviews based on themes that we see throughout the interviews with the patients, and then complete the MRI scans. So really quickly, going back, so the MRI scans, it was something else that because of the pandemic, we were unable to proceed with this third part of the experiment. These scans would utilize the molecular changes in the brain in people diagnosed with CHD to provide insight into the possible neurophysiological deficits in patients with CHD. So some of the questions that I hope to answer with the continuation of my project are, which factor is the most important in regard to helping individuals with CHD and associated cognitive deficits? What are the molecular changes expected to be visualized in the MRI? And do the MRI findings correlate with the level of maladaptiveness in the patients? So I just wanted to thank everybody in the MSRP team, Dr. Whitty, Dr. Kluwer for allowing me to be a part of his research team, Dr. Jennifer Andrews and Sarah, who both worked with me on this project, and then all the volunteer participants, for without them, none of this would have been possible. And just like as a the fringe benefits, I guess, of this project was gaining clinical experience despite being in a pandemic. And I think I was really looking forward to having that clinical experience in my research. So I'm glad that that wasn't affected because of the pandemic. And that's it. Questions?
Okay, thank you, Vanessa. Are there any questions from the audience? If not, Scott, do you want to make a comment on Vanessa's research with you?
Yeah, so this is a really exciting project, and it's kind of the spearhead of Jennifer Andrews, who works within our research group, really trying to understand the executive functioning impact of living with a congenital heart issue. And I think this approach is really innovative, and there's a lot of interest in the adult congenital research group across the country. This is one of their top priorities to find out. So again, I think Vanessa did a great job. We've got really, really good data, and this will just be building upon with some of the other aspects in terms of correlating it with the MRI and getting more subjects. But this is a wonderful start to a really, really important topic that nobody really was thinking about when these folks were babies. So it's a great work.
How many centers are there now? I know you were one of the first to have an adult congenital heart disease clinic and program.
Yeah, so right now across the US, there are a little over 30 accredited centers. Most of them are at the large academic centers that you could imagine, but there's also, it's a pretty small network. So there's a research group called the Adult Congenital Alliance for Research that we're involved with, and in their 5 platforms for research priorities, this particular project is one of those 5 priorities. So everybody's interested, and I think this preliminary data is probably going to be used as best practice to hopefully do a multi-institutional study in the near future.
Okay, thank you, Scott. Okay, we're going to move on to the last 3 presentations, and 2 of them are with Dr. Karen Luttrick as the mentor, and she's assistant professor in family and community medicine, and both of them deal with the COVID-19 pandemic. I just want to comment that throughout the summer, obviously, the pandemic has loomed over the whole program. Although we have moved forward, I think we're probably the only summer program locally, and very few summer programs nationally have moved forward that are sponsored by NIH. But what we've done, and it might be of interest to some of the researchers that are involved in the COVID-19 surveys, is we have collected beginning questions on the COVID-19 pandemic from all of our 82 students, medical students, high school students, and undergraduates. So we've collected them at the beginning of the summer, which was in June, and we've now collected them at the end of the summer. So we have probably 800 to 1,000 questions that are coming from students. In addition, the high school students and undergraduates each had either a video or a paper that they wrote on some aspect of the COVID-19 pandemic, everything from previous plagues to political, social aspects to what is the virus, what kinds of treatments, vaccines, et cetera. So there's quite a treasure trove that we have stored electronically from the group this summer that probably someone else will at least take advantage, if not one of the students in the future. So let's move forward with Sri Sai Atluri, who studied investigation of epidemiologic and clinical characteristics of COVID-19 patients in Tucson.
Are you able to see my screen?
Yes.
So good morning, everyone. My name is Sweta Atluri. I'm a second-year medical student. This summer, I had the opportunity to work with Dr. Luttrick on my MSRP project that involved investigating the risk factors and clinical characteristics of COVID-19 patients here in Tucson. So a little bit on the background. The SARS coronavirus 2 is the virus that causes COVID-19. And as you probably already know, there are three main methods of transmission. Droplets involve the respiratory secretions from coughing or sneezing that land on mucosal surfaces. Aerosols are solid particles or liquid droplets that are suspended in the air. And contact involves touching something with the virus and then touching one of those mucosal surfaces. So this is a huge public health emergency, and there have been over 17 million cases reported worldwide with over 600,000 deaths. So this is a widespread problem, and this figure is from early last week. So now the US has surpassed 4 million cases, so it's even greater than what's reported on this map. So here is some of the epidemiology that was recently published. This study pulled data from the Chinese Center for Disease Control, and they included over 44,000 patients. And they looked at the distribution in age and the severity of disease. So you can see here that a majority of the cases involved people between 30 and 79 years of age. And a majority of the cases, or 81% of the cases, were mild, with some severe and some critical cases. The case fatality ratio overall was 2.3% in this study, but it was much higher in some other groups, like the older age group and patients with a greater severity of disease. This was another study that examined clinical characteristics of over 1,000 COVID patients across multiple hospitals and provinces in China. And you can see here that fever, cough, fatigue, and shortness of breath were the most common symptoms, but there were some other reported symptoms. And this study also examined some of the complications with these patients, and these included pneumonia, mechanical ventilation, and ARDS being the most common, but take this with a grain of salt because these were all hospitalized patients, hence the high occurrence of pneumonia. Factors associated with such complications have also been studied, and this study looked at factors associated with ARDS or progression from ARDS to death in COVID-19 patients. And they found that hypertension or diabetes were associated with a significantly greater risk of developing ARDS or progression to death from ARDS. But this data was limited by sample size, since they did look at other comorbidities, but they didn't have a large enough sample size for those. So let's now take a closer look at the structure of the virus and why patients with certain comorbidities may be at a higher risk. The SARS coronavirus 2 is an enveloped positive stranded RNA virus. The spike proteins project through the viral envelope and mediate receptor binding and fusion. The nucleocapsid protein helps regulate RNA synthesis. The membrane protein is involved in viral assembly, and the envelope protein facilitates viral assembly and release. So here's a zoomed in view of the receptor binding domain within the spike protein. This is the domain that binds to the angiotensin converting enzyme 2 or ACE2 receptor in humans. This allows for viral entry into the host cell. And as you know, the ACE2 receptor acts on the renin-angiotensin-aldosterone system, which is a key regulator of blood pressure. So this may have important implications for patients with underlying hypertension and those taking medication that acts on this pathway. So some of the previous animal studies have shown that ACE inhibitors or ARBs can affect ACE2 levels. This study specifically found that ACE inhibitors and ARBs individually upregulated ACE2 receptor activity, but this effect was not seen when they were used in combination. So this again raises additional questions on patients taking these drugs and what their susceptibility to the virus could be. This was a study in Denmark that looked at the risk of developing COVID-19 among those taking antihypertensive medications. And you can see they did not see a statistically significant risk associated with ACE inhibitors or ARBs. But this study was limited to only Denmark and may have had some other selection bias. So it's still important to examine this point further. So now we're here to my research questions. Do underlying medical conditions predispose patients to COVID-19? And if so, which comorbidities are associated with a higher risk? And are antihypertensive medications associated with a greater susceptibility for the SARS coronavirus 2? And how does the discontinuation of ACE inhibitors or ARBs in COVID-19 patients affect their outcome? So in terms of progress, we've been collecting patient data in 3 main sites, the Banner University Medical Center, Tucson main campus and South Campus, as well as the Family Medicine Clinic. We've been recording information in REDCap for demographics, comorbidities, medication, clinical characteristics, results of the diagnostics, length of stay if they were hospitalized, or duration of symptoms if it was outpatient, as well as complications and final outcome. We're recording this information either for each day in the hospital or every clinic or telemedicine visit if they were outpatient. So this is based on the most recent data pull from a few days ago for our outpatient data set. So we've collected data on 265 total patients, with 92 of them having underlying hypertension. 86 patients are taking some form of antihypertensive medication. And some patients are taking only ACE inhibitors or only ARBs or only some other type of antihypertensive, where some patients are taking a combination of these. So some of the next steps, we will continue to collect and verify the outpatient and inpatient data, and we will then begin to process the inpatient data after verification is complete. And then we'll perform a multivariate regression analysis to see which factors are associated with a greater susceptibility. And then we will be correlating these results to the Tucson population, maybe using the Arizona Department of Health Services data set as well to explore public health interventions. So some of the limitations of this study were that there were a lot of changes in the testing criteria over the past few months. In the beginning of the pandemic, the clinic was limited by the number of tests that were available. So there was a more narrow testing criteria. So in the earlier months, we included even suspected COVID patients, even if it wasn't confirmed, whereas now we've pivoted to only confirmed COVID-19 patients. Some patients were also lost to follow-up in the outpatient clinic, so we don't know what their clinical progression might look like. And then this was also limited to only 3 clinical sites, so that kind of limits the generalizability of these results. And there were also several variations in the EMR input and clinical management between providers. Some of the fringe benefits, mentorship. So with Dr. Lutrick and our data manager, Patrick, it was great to sort of bounce out the research questions as well as the different statistical analysis methods that we could use. And I also got more awareness for the IRB approval process. There were a lot of frustrations with the delays in that, but it was my first chance to get exposed to this. Also being able to do a literature review and help draft the manuscript, as well as being informed on the public health response for this pandemic, as well as getting some more exposure to Cerner before our rotations. So we still have the previous questions remaining, but here are some additional research questions as well as some future directions. What steps can be taken to reduce the risk for patients with comorbidities? And how do ACE inhibitors and ARBs affect COVID-19 severity and outcome? So in addition to susceptibility, we also want to explore the progression, and this relies on the inpatient database, so this would be a bit more delayed. Should antihypertensive medications be continued or discontinued to address COVID-19 risk? And this can help inform clinical management. What pharmacologic therapy can improve COVID-19 outcomes among patients with comorbidities? And how does the coexistence of other respiratory virus infection affect outcome in COVID-19 patients? So here are my references. And I'd like to thank our COVID-19 research team, specifically Dr. Lutrick and Patrick, for their support, as well as the other team members. And I'd also like to thank Dr. Whitty, Grace, and the rest of the MSRP team for their support throughout this summer.
Okay, thank you very much, Sri-Sai. We're going to go on. I'm going to ask Karen if she'll make comments after the next presentation about both presentations. Our next presenter is Alexander Moss. He's class of 2023, and he developed an integrated COVID-19 clinical surveillance clinical registry, or he developed the initial steps in that. Proceed if you would, Alexander.
All right, so everyone can see the screen, correct?
Mm-hmm.
All right, so I can't take full credit for creation of the registry, since, as you will see, it was an enormous undertaking. So some of the initial questions that we had were the registry that we're creating. In what ways was it going to be different from traditional registries that are available? This very much had a specific public health approach. We'll talk about why that was needed in the middle of the crisis. We had the opportunity in our groups, in our laboratory group, to have some epidemiology biostatistics partners to help us with the consideration and design of things as we went along. And because, as we'll discuss, it was a unique data set, we knew there would be some limitations, that there would be some questions that we might not be able to structurally answer based on the data set itself. Specific to the question, we ultimately developed this question of, since the cytokine storm seems to be responsible for a lot of the pulmonary damage associated with COVID-19, what possible inflammatory markers would be useful in predicting the severity, and could those markers be used as in a predictive way to help decision makers and other planners determine resource allocation and length of stay in hospitals. So first off, as medical students, we don't have as much initial exposure to the demands of public health research. I learned a lot about that, and some of the things that come most to mind is that this wasn't new stuff that we were pioneering. There had been a lot of research done prior on the utility of influenza surveillance networks with real-time analysis, electronic case reporting forms, and basically integrating multiple data streams from different institutions all coming together to learn about new emerging influenza strains. So some of these ideas had been proven, but never at this scale before. We knew that time was essential because our colleagues in emergency medicine, critical care medicine, disaster medicine were needing to make decisions without well-vetted knowledge. And so normally the time it might take to establish a registry, and after negotiating all the things that you would need to do, deciding all the minutia, would be 3 months. But with the virus project, the inpatient project, the first call here at University of Arizona was on April 8th, and by the 25th it was built and we were already collecting data. Along the way, we realized that we weren't always going to have our way because variables changed and a lot of it was outside our control, but it still yielded some great results. Also, understanding that public health researchers help to fill this need. Government simply does not have the ability, especially local government, to generate the data needed to inform good decision-making processes. So because there are certain things that by law they have to do and they have limited budgets. So for example, in Pima County, contract tracing right now is being done 90% by U of A undergrads. And also there's other needs and questions that public health research answers that's broader than a traditional narrowly focused medical study. So the virus COVID-19 registry is an initiative from the Society of Critical Care Medicine, their Discovery Critical Care Research Network out of the Mayo Clinic. There's 18 different countries participating in it right now, 235 sites, 16,000 total enrolled patients, of which almost 500 are here in Tucson, 38 different states, and we're one of the most productive sites here in the United States. So we have, roughly around 500 people enrolled. And to give you a sense of what that entails, we weren't doing any sort of interventions or having any patient interactions. It was solely a chart review of everyone that had confirmed SARS-CoV-2 infection at Banner inpatient facilities. We de-identified the information, and it was similar, as Swetha was saying, to the outpatient registry. We collected a lot of different data. You can see this is all the broad categories that we had right here. So overall, we had every single patient, there were 541 different fields that we had to fill out for each patient. And each of those fields could be duplicated on the different days of admission that we were looking at, days 0 through 3, 7, 14, and 28, which meant that every patient had 1,642 total unique variables that we needed to upload to the registry. And because quality of data is important, because we wanted this to be a solid data set that people could approach and derive new theories by seeing what was available, we reviewed all the data twice. So each pass took about 8 to 12 hours, depending on your level of experience, and there's a lot of work ahead. So, so specifically, that was all the work that went into creating what we have here in Arizona, our portion of this registry. But the clinical question that we wanted to address is that of the cytokine storm and what we might be able to learn about that from the registry. So we know that inflammation is a key component of SARS-CoV-19. We know that a lot of the traditional cytokines are at play and are causing a variety of different complications that have been well established in the literature. Normally, because once again, we have a diverse audience here, the normal virus immune response in initial stages of viral infection, certain pattern recognition receptors are activated that can identify different nucleic acids. As mentioned before, SARS is a single-stranded RNA positive sense virus. These pattern recognition receptors have downstream effects on cytokines that can recruit neutrophils. Other cytosolic and membrane receptors trigger the production of interferon, toll-like receptors, and some other cytosolic receptors can induce interleukin and tumor necrosis factor production, and that can ultimately have a downstream effect of a clonal expansion of lymphocytes and other leukocytes. And specifically, because of the mixed audience, neutrophils largely have their effect through phagocytosis, which is the cell eating process, degranulation of antimicrobial compounds, and DNA nets that actually can entrap viral particles in some cases and other larger particles. And lymphocytes, T cells and B cells, are important for this longer term adaptive immunity. The normal process of a cell, the normal immune process, the cellular response to a viral insult, it would be like this. You would see an early emergence of neutrophils with their concomitant cytokines, and then after a while that would kind of convert over into more of an innate response. The previous knowledge that we had of SARS-CoV-1 from 2003 was that there were some modifying effects happening here, that we weren't quite seeing the same response. And what we've learned so far is that a lot of that SARS-CoV-2 mirrors some of these effects. And so basically you have a dysregulation of the cellular immune response at multiple levels that interrupt the upregulation of various interferons and other cytokine responses. So in the process of investigating what markers of inflammation might be useful, we came across a relatively new marker of inflammation that I was not aware of previously, which is called the neutrophil to lymphocyte ratio. It's appealing because it's readily available. It's not as expensive to run as CRP or procalcitonin or ferritin or some other things that you might be running, and it's something that's run regularly. So we found in the literature that severe COVID cases tended to have higher total leukocyte counts, but they had lower lymphocyte counts, especially some of the T helper cells and the T regulators, which kind of would explain this cellular dysregulation that we were seeing. And so early on, some of this subclinical manifestations of inflammation, we could determine with an NLR ratio of greater than 3 was highly associated as an independent factor with COVID severity. So we decided, let's see if we can take this and extend it to some of that predictive question of length of stay, because it would certainly help in resource allocation and some of the other outcomes that we were interested in. So as far as methods go, like we said, 500 plus different fields. We had lots of things that we could choose from in addressing our own question. So we decided to exclude any pregnant individuals because that has an effect on the NLR ratio. We derived the NLR from CDC data, and also as a point of interest, we wanted to compare it to more traditional markers of inflammation like CRP, procalcitonin, ferritin. And we decided to normalize that lab data by basing it. Day 0 in our data set is the first day of hospital administration or hospital admission, but in some senses it's not a meaningful 0. So we decided to time normalize that data by starting it based on the days since start of symptoms. We identified in the literature several confounding factors, care at other facilities, age, sex, BMI, comorbidities, etc., that we would need to control for or take into consideration as we attempted to suss out this potential interaction. And as far as outcomes go, we were interested in length of stay, but we thought that some other things might be interesting to look at the same time. So what their diagnosis was on admission, how that related to their overall inflammatory state as measured by the NLR, ICU admission status, whether or not they needed to be admitted, signs and symptoms, severity of their respiratory distress, oxygenation status, any required intensive care interventions, etc. We, unfortunately, as was previously discussed, we had some issues getting the data back out. We had some IRB revocations that happened, and approval finally came through 2 days ago. So with that data, our intent is to do some survival analysis and multivariate regression to determine the effect of NLR on severity and length of stay. That said, there's a lot of descriptive data already coming out of the data set that we can share of interest. So top 5 signs and symptoms: fever, shortness of breath, dry cough, myalgia, diarrhea. Top 5 comorbidities: hypertension, diabetes, obesity, chronic kidney disease, and chronic pulmonary disease. The supports, as most people would be expecting: mechanical ventilation, non-invasive ventilation, nasal high flow nasal oxygen, dialysis, and ECMO. And then perhaps one of the more telling things coming out of it is kind of the overall survivor discharge status. So of people being discharged alive from the hospital, so 81% are being discharged alive from the hospital, 19% after admission are deceasing, and of those who are discharged alive from the hospital, only 52 return home without any sort of need for additional assistance. Being admitted to the ICU decreases that somewhat from 19 to 29, and so we thought that was interesting. Fringe benefits, as discussed before, the joy of mentorship, learning about IRB submission and rejection and resubmission, the ability to do literature reviews, creating an annotated bibliography, the journal submission process, and increased familiarity with the EMR. Some of the main remaining questions we have is we'd love to see what our data has to say about it. We think we've done most of the theoretical analysis, and we just like to crunch the numbers now. And one question we have also is there a specific day or time in the course of the illness that is most predictive of outcomes based on this variable? Because unlike some of the other markers of inflammation that might be done once during a hospital stay, CBCs with differentials are usually being done almost daily in the early stages. It's a very common laboratory test to be ordered. So future plans, there were also some references in the literature to some other emerging markers of inflammation, platelet to lymphocyte ratio, monocyte to lymphocyte ratio, and then CRP to lymphocyte ratio, which we thought was interesting. So that's it for me. Thank you.
Okay, thanks, Alexander. Dr. Luttrick, do you want to comment on both of these presentations?
Yeah, sure. So as they both kind of indicated, right, I think the medical students that are working with us, as well as the public health students, are really kind of getting a crash course in what it's like to study a pandemic during a pandemic, right? Which has its whole sort of set of complications and nuances. And one of the things that, you know, we maybe didn't get to the point where we can really start answering the COVID questions, but I really do firmly believe that, like, sort of building and starting and running and revising a research project during a pandemic really requires you to have a pretty thorough understanding of the methodology and the sort of the why, and we really talk those through. So hopefully, you know, now that they have the data, kind of getting to that end point will go really quickly, because we've spent a lot of time not just refining research questions and talking about all of the sort of the socialization side of research, the how do we make these decisions and how do we kind of plan our time and manage our teams, but also really understanding why we ask certain questions and the value of certain questions, so that now they can kind of run with it. Just really appreciative of the opportunity of being connected to MSRP and having these students be a part of our sort of ad hoc, informal pandemic research team during the pandemic.
Okay, thank you. I do want to comment, since I mentioned this earlier, we had Michael Joyner from the Mayo Clinic as our first speaker. He's a former MSRP, and he's leading the convalescent plasma reinfusion project, which is involving 20,000 patients nationally and I think internationally, and he's part of that critical care group up at the Mayo Clinic. So we opened the MSRP, the SIMI, with the medical students, with Michael Joyner presenting his experience. In addition, I'm working on an editorial because a missing link in all of this is lymph. You're dealing with the interstitium of the lung, and the interstitium of the lung, the proteins that leak out, the proteins that are formed, that leak out, the cells, et cetera, they're all being collected in the lymph. In the lung lymphatics, which go up the thoracic duct and the right lymphatic duct. And the lymphatics are totally left out of pathophysiologic schemes. There was one in the Wall Street Journal that just had blood capillaries, didn't have lymphatics at all. And I think it's an important missing link, because that's where the cytokines and the cells are entering the bloodstream from the lymphatics that drain into the systemic veins. So it's a source of obvious pathophysiologic understanding, plus it's a potential source of removing these products by draining lymph. This is an established procedure. It's been done on hundreds of patients a long time ago, and now it can be done interventionally by endovascular catheterization, and lymph can be drained out. It can also be drained out simply, again, from convalescent volunteers. You can get 10, 20 liters of lymph out over many days with impunity. There is some slight immunosuppression, but you can actually reinfuse what you want to and take out what you don't want to. The final point about the lymphatics, I'm working on the editorial, so I've got the evidence together. There's papers going back to the 1940s definitively demonstrating that viruses the size of COVID-19 from the nasopharynx will enter the lymphatics preferentially over blood vessels. And from that point, there also could be entry around the olfactory nerves because there are perineural lymphatics, and also through the cribriform plate that can go into the brain retrograde. So this whole area of forgetting the lymphatics in this disorder and an ARDS, I think is a really big missing link. The group in New Zealand, the surgeons have been cannulating, have been draining lymph in patients with sepsis and have had very dramatic effects of lymph drainage. We did that a long time ago in pancreatitis and other conditions. So it's something to think about. It's not something that you can, you're going to put in the registry, but I think it's something to think about that has really important implications and is an area of great ignorance, put it that way. So I did want to mention that officially during this this final symposium here. Okay, and we're going to end up, find my notes here. We're going to go into psychiatry now with Linda Osman, a class of 23 for the final presentation. Preventive intervention to modify depression risk targets after breast cancer diagnosis. And our mentor is Dr. Karen Wise. Is Karen here?
No, she's not.
Okay. Well, I've known Karen since she was a medical student, actually. Not here, but elsewhere. So I've known her for a long time. And she's professor of psychiatry.
Okay. Can my screen be seen okay? Sorry, I'm a little congested today. My allergies are really bad. But okay. So my project was to apply the NIH stage model to design and test an intervention to prevent depression in breast cancer patients who are at risk for depression. My PI was Karen Wise from the Department of Psychiatry. And the NIH stage model is a model of behavioral intervention development. It's composed of 6 different stages that are all geared towards improving health and well-being. So a little background is breast cancer is the most common cancer in American women except for skin cancer. There are over 3.5 million breast cancer survivors in the United States. Women with breast cancer are 3 times more likely than their healthy counterparts to develop clinically significant depression in the year following their diagnosis. And as a result, they suffer a multitude of different negative consequences. Just to name a few, they experience greater risk for medical comorbidities. They have a poor medical regimen adherence, unhealthy behaviors. They incur higher medical care costs, and they unfortunately have a shorter survival after diagnosis in comparison to their non-depressed survivors. So some of the questions I had in the beginning are, is the poor prognosis of depressed cancer patients only secondary to a poor medical regimen adherence, or does depression actually expedite the illness's progression? I also wanted to know how accurate are we at distinguishing the pain, fatigue, and insomnia that can result from the cancer itself or the chemotherapy versus the depression? And lastly, I also wanted to know, does detecting breast cancer through screening rather than through self-discovery actually increase the risk of depression or cancer, of depression and anxiety? So I chose this project because I wanted to raise awareness to an unmet clinical need. Here I have a quote by Dr. William Anthony, and it talks about how addressing the symptoms of depression is so much more than the sticky caps of how we're always taught in med school. I think it involves a lot of developing a new meaning and purpose in one's life, especially after a traumatic event, such as being recently diagnosed with breast cancer. So the idea is adapting an intervention approach. We know that depression can be treated effectively in cancer patients, but prevention eliminates the substantial risk of recurrent depression. Depression is a chronic illness, and around 50% of people will eventually get a second episode of depression. So we want to do here is use a unified protocol for transdiagnostic treatment of emotional disorders, and this is going to be the foundation of our study. It's going to be modified so its purpose is to prevent depression and not treat it, and we wanted to use this protocol because it targets awareness, coping, emotional, regulatory strategies that we feel as though are important for a successful outcome. So the prevention module is going to include some psychoeducation, demonstration, practice of different coping skills, and the patients will be able to get some feedback from the counselors from their targeted coping and emotional regulatory strategies. And I think it's interesting because it touches on this idea of neuroplasticity. It's a discovery that our brain is constantly changing and learning new patterns. So it involves synaptic reorganization in response to environmental stressors, and it takes place after a major life event. So what we want to do here is harness corrective neuroplasticity so it's possible to reprogram the maladaptive behavior and produce long-lasting remission through effective psychotherapy education. So the question is, could application of the intervention method actually improve the overall prognosis of breast cancer? We already recognize the fact that women with breast cancers are 3 times more likely to develop significant depression. We also recognize the fact that prevention therapy has better outcomes than treating depression. So the next step was to do a clinical trial, but before that can happen, a pilot study was completed. The pilot study was a single-arm intervention study in women within 6 months of their breast cancer diagnosis. Cancer-related emotional distress is highest during this time, so it only made sense that the intervention would be implemented during this moment. The pilot study was called the First Emerge Project. It had 16 participants, but because of its limitation, the single-arm study was not used to draw any conclusions about the intervention efficacy. As I alluded to before, the focus was on the process and not the results. It gave insight to whether the criteria was too strict for the participants to partake in, whether the appointments were too demanding. This is a very vulnerable time for the patients. They're undergoing chemo treatments. They're undergoing a lot of emotional distress. So we don't want to place too much stress on them. We want them to maximize their opportunity from the intervention module. So after the completion of phase 1, it was time to move on to phase 2, which is the Emerge 2 project. Here we had a larger population to work with, and we had randomization of groups. There were 2 groups that remained that would receive the intervention project, and then the second group was the control group, also called the waitlist group. In order to properly deliver the protocol, we needed to have intervention training. So there was 2 master level therapists and the second-year medical student, which is myself, who were trained by Dr. Wise and another counselor to adequately deliver the protocol. We had several training sessions to review the protocol that included content review, practice in delivering the psychoeducational material, and also role-playing skill practice with mock breast cancer patients. For myself, I needed, of course, a lot more training to make sure that I was up to speed in comparison to my 2 master level therapists. But because of COVID, I had a lot more time to kind of catch up on my basic counseling skills. Dr. Wise monitored the fidelity of the protocol by listening to our audio recordings of all the intervention sessions that we had practiced. So our eligibility criteria was very straightforward. In order to partake in the study, you needed to have be diagnosed with breast cancer for the first time within the past 6 months, be able to speak and read English, agree to not take any new antidepressants or initiate any new depression treatment during the study. And for the exclusion criteria, you cannot be currently experiencing an MDE episode. You have to be cognitively intact, and you cannot be experiencing any other chronic mental illness. So here's an overview of the 4 different sessions that we had for the 6-week period for the intervention. The first goal each session has a very specific goal in mind, and they have different intervention modules that were implemented in each session. After completion of the session, the patient would have to complete a multitude of different questionnaires that they would then submit for data collection. So the first session was a 45-minute phone call session, and it focused on increasing mindfulness awareness. The second and third sessions had a goal of increasing approach methods and reducing avoidance. There's been a link that people who engage in increased avoidance behaviors have an increased likelihood to develop depression afterwards. And the last session was just a maintenance session. It gave a opportunity for the patient to clarify any questions that they had, or develop an action plan to make sure that they are able to retain their changes. So recruitment for the study started in October of 2019. There were 54 subjects that were referred. Out of the 54, only 36 were eligible to partake in the, to continue participating in the phase after the DRQ screening, and out of the 11, only 8 were able to fit the eligibility criteria. Because of the halt on data analysis, I couldn't pull any data from phase 2 to show, but essentially we'll be repeating the same thing as we did for phase 1. All outcomes will be measured using ANOVA to test change over the intervention course. And here is just the different strategies that were implemented in the session 1, 2, and 3, the different questionnaires that were used to collect data. And as you can see here, the effects of the intervention were most prominent in the cancer-related acceptance. It had medium effect on cancer-related emotion expression, and it had smaller effects on cancer-related avoidance and depressive symptoms. Again, because of the COVID situation, I had more time to go over literature. I'll kind of answer my questions through literature review. I ran across this paper that talked about how depression has a strong relationship with cancer progression and less of a relationship with cancer incidence. It talked about how course of depression over a year among women with metastatic breast cancer significantly predicts mortality. So this is all the more reason to believe that this is an important modifiable risk factor that we could target to improve cancer prognosis. I also came across the fact that there is no increased risk of developing depression or anxiety from clinical screening rather than through self-discovery. Some of the fringe benefits that I came across is while I was learning different basic counseling skills, I was able to identify some of the roadblocks to communication that I was using that may have hindered my patient-physician relationship. Sorry, I'm like really struggling with my congestion. I also gathered a greater appreciation for what a counselor and therapist does during their counseling sessions. I think that they're able to really gauge and meet a person halfway where they are in their journey. They're able to break down different emotional experiences into more bite-sized, digestible pieces so a person is not easily overwhelmed by their emotional experience. They're also able to utilize these different core skills of motivational interviewing that really facilitates an open discussion with their patients. They're able to utilize affirmations that recognize the patient's strength. They utilize reflections to make sure that a patient is heard, and they summarize to make sure that a patient is understood. I feel like for me, after coming across some of their different tactics, I feel like I could learn a lot from them to improve and better facilitate my own medical interviewing skills. So lastly, what lies ahead is data collection has been halted due to COVID, and we also have not met target subjects numbers to start data analysis. Our target was 40 subjects for Emerge 2. We wanted 20 in each arm for the intervention and wait list. So once we have enough patients meet the target, we will know if the intervention actually works. We may do an interim analysis, but it might come out as inconclusive due to the limited data collection. If Emerge 2 does work, we may extend this project to other cancer centers across town to include more subjects and hence the validity of the data. Some of the remaining questions that I have for myself is how can this become a transdiagnostic process so that it can be delivered to others facing different mental illnesses? And lastly, how can we make session 3 more effective so that the intervention can have a bigger impact on cancer-related avoidance. And that's all.
Thank you very much, Linda. Are there any questions from the audience? Karen isn't here. So we are finished, and it was a remarkable performance. We had 86 presentations in the last 4 days, and I think they were perfect. They were all articulate, they were well illustrated, they all included the beginning and ending questions. And as you go in the future to medical meetings, you'll find that you're not going to find many sessions where you have such excellent presentations. And this will be with professional scientists and professional presenters. So you've done a remarkable job.